Okay, guys. So next up, I'll teach you the topic of heart blocks. One on the agenda at the moment is first degree heart block. In this condition, the problem is not in the SN node. It's not in the AV node. It is between the SN node and the AV node. Like these black that I have shown here before you can be taken as representation of Ashkoff nodules. Now you're aware that Ashkoff nodules are found in rheumatic fever. And what will happen in this condition is that there would be a slowed conduction between the SN node and the AV node. So the learning point for you guys is that in first degree heart block, the problem is not in the SN node, not in the AV node. It is a connection problem. This entire time that the current will take from starting from the SN node and exiting out of the AV node down into the bundle of hairs, this whole time is what is called as PR interval. And because here the conduction speed will become relatively slow, so therefore the PR interval will be prolonged. You can see here that in the ECG of this patient, if I use a finer font, even I don't count it, it is more than 5 small squares. Now you can see one large square is 5 small squares, as I explained to you. Here it is going into almost 7, 8. So 8 into 40 would be something like 320 milliseconds. The normal PR interval, as I've explained, is in a range of about 120 to 200 milliseconds. Here it's going up to 320. I'll say that again. Why 320? Because if I say, suppose there are 7 large squares, one big square is 5 small squares, add another 2, so making something like 7 to 8 approximately. So 8 into 40 would be 320 milliseconds, which is very, very significantly high. And the same thing is being replicated even in the previous PR intervals of the patient as well. At this moment, I also want to bring to your attention that overall the most common cause of first degree heart block, however, is physiological. Like if a person is doing a lot of running, like a lot of time these marathon runners, they have a high vagal tone. Or if a person is doing rock climbing, for that also you need a lot of I would say stamina. So people who are into sports, especially like marathon running, long tennis, or like rock climbing, they would be having a high vagal tone physiologically. So overall the most common cause of first degree heart block is physiological. But yeah, in India, if it's a child, he had rheumatic fever earlier, then the person could be having like first degree heart block due to rheumatic fever as well. At this moment, I also want to say, and I want you to check out your pediatric notes. When you will read about rheumatic fever in children, you will notice that it is one of the minor diagnostic criteria. The criteria that are taught to you are called as modified Jones criteria. Now, so if you check out your pediatric notes, the modified Jones criteria specifically, then one of the statements will be prolonged PR interval. The rationale for the same is that there is a Ashkoff nodules present between the SN node and the AV node. Then these black dots that I've shown can be taken as representation of non-caseating granulomas. I've discussed sarcoidosis in the respiratory section, but today I want to say that in sarcoidosis, even the heart can get involved. How? The granulomas which are present here can be present between the SN node and the AV node, and they can slow down the conduction. In the endocrine section also, I have touched upon sarcoidosis. There I've said that these granulomas will produce vitamin D and therefore hypercalcemia will occur. In respiratory system, I described that myself, hilar lymphadenopathy, and like the staging of sarcoidosis that has been asked in FMG exam. But today it's the cardiovascular day, and it's non-caseating granulomas causing a first degree heart block. Then another scenario can be a child is having thalassemia and is receiving repeated blood transfusions. Then blood transfusions will cause iron deposition. Again, iron deposition in this area will slow down the conduction. The fifth cause is a rare cause. It is found in southern India. That is endomyocardial fibroelastosis. As the name suggests, there is fibrosis in the conduction system in the heart. So in all of these conditions that I've mentioned before you, including the most common one, that is physiological due to high vagal tone, the PR interval in this condition will be more than 200 milliseconds, and we cannot do anything about it because there is no pacemaker required here, because the disease is not of the SN node or the AV node. You do a pacemaker treatment when there is a defect of the pacemaker. In this condition, there is no defect of the pacemaker. It is the connection between the two that is defective. So as such, there is no treatment that we will be doing for this condition as such, and there is no pacemaker requirement for this condition as well. The universal thing is that the overall most common causes due to marathon, due to rock climbing, people would end up with high vagal tone. You see, most of you and people like you and me, we have a sedentary lifestyle, so our vagal tone is lesser. But once you will start doing exercise, once you will start doing yoga on a regular basis, you will notice that your heart rate will tend to slow down, and that's good because that tends to conserve the oxygen consumption of the heart. So the question of the NEET PG, I'll say once again, he said it's an IT professional. He came for an annual medical checkup and the PR interval was more than 200 milliseconds. He says, what is your advice? One was was like advise him lifestyle modification, one was like tell him that his job is not suitable for him, like he can have a death while working. So obviously like none of them would be valid. It's like just that he needs to take it easy, in a sense that maybe he's doing too much of exercise, right? A lot of people who are into corporate job, you see, you and me are always doing a stressful job which is full of negative vibes, because we have to imbibe negative energy from people. So the tendency to do exercise in doctors is very very less. But when it comes to like IT professionals, school life, no, so they tend to chill out, they do workout, they do, like you look at Google's office or any Meta's office, 1 hour they work, then 1 hour they're playing TT, tennis, something like that. So what I want to say is that everybody, including you and me, should change over from sedentary lifestyle to a first degree heart block, to like doing exercise, but it should not be so much of exercise that we end up with the first degree heart block. That's the main message. But anyway, nothing to worry except for point number 2 to 5, where we will tell the patient that he needs specific treatment for rheumatic fever, like we give benzathine penicillin injections for prevention. For sarcoidosis, we give steroids. For hemochromatosis, we use iron chelators. So specific treatment to the cause would be given, but as such, there is no pacemaker requirement for first degree heart block. Now I will focus on second degree heart block. In second degree heart block, like the question will delve into either of the two. Either he will say Mobitz 1 or he will say Mobitz 2 heart block. So let me explain to you how to identify it. I'll use a finer font. In Mobitz 1 heart block, you will check out the PR interval, and you will notice that it is showing a serial prolongation. The moment you see the PR interval the first time and compare it with the second time, it is more broader, and then the third time it is even more broader. So if you get a serial prolongation of PR interval, then it by default should be answered as Mobitz 1 heart block. I repeat that again. The main feature of Mobitz 1 heart block is serial prolongation of the PR interval. And then after that, you'll get a very interesting phenomenon, which is that this is the T wave, this is the P wave. And after that, you are waiting. This is literally like a straight line. You're waiting for a, like it's a sinus pause, or I can say it looks like a cardiac arrest. Obviously, it's not a cardiac arrest, it's a sinus pause. At this point of time, the QRS complex should have happened. But because the QRS complex will not happen, the ventricles will miss a beat here. The patient is saying, doctor, I'm feeling dizzy. While I'm sitting on a chair, I'm feeling dizzy. And in between, when I check my pulse tends to disappear. I was like, are you kidding me? He says, sir, check my pulse now. So when you will check the pulse of this patient, you will notice that intermittently the pulse of these patients will begin to disappear. And that is when I say like this, that even for 1 second, even for fraction of a second, no, if your ventricles will not beat, blood supply to brain will become zero, and your head will begin to spin and you will feel uncomfortable. So the examiner in a MCQ of first degree heart block versus second degree heart block, in second degree heart block, he will always mention the word missed beat. He will say missed beat or missed beats are present or are claimed by the patient who's having recurrent episodes of dizziness and even possible syncopal events. And all you need to do in the question is check out whether the PR interval of this patient is showing a serial prolongation. And you will also notice in these patients that once the drop beat has occurred, then the PR interval will reset and then will again start increasing. Like once again, you can see the second time the PR interval again will mathematically increase and then will increase even further. And then again a missed beat can happen. Now, if I zoom out of the slide, the one thing that is very, very clear is that when it comes to Mobitz 1 heart block, this that is currently shown to you is called as Mobitz 1 heart block. The highlight of this condition is 1 missed beats, and the second highlight of this condition is a serial prolongation of PR interval. So one way to solve the MCQ is calculate the PR interval the first time, compare with second time, compare with third time. It's a tedious job to do. So I have a shortcut for you also. The shortcut for you guys is that I want you to check out the PR interval of this patient after the missed beat and compare it with the PR interval before the missed beat, and you can notice that the duration is grossly asymmetrical. I said, I'll repeat the options again. One way to solve a question of Mobitz 1 heart block is check out the PR interval first time, second time, third time. Sometimes the drop beat can occur after missed beat, can happen after 4 beats also. So in the exam, when you're sitting in a pressure cooker situation, you may forget when you're counting the 4th time, you might forget what was the PR interval the second time. So I'm saying, why to get into the hassle of remembering the PR interval 1, 2, 3, 4, 5 times? Rather, like just check out only 2 times. When to check? First check out, by default, this is the rule. First after the missed beat and then before the missed beat, and mathematically the size or the duration of this will be totally different. And you will also notice I used an alternative term here, which I'm now writing once again. This alternative term for missed beat is called as drop beat. The rationale in this particular condition is that the conduction through the AV node is dropping. And that's the reason why intermittently, like the pulse of this patient will disappear, and that is why syncopal episodes can be present. Now we will compare this with the ECG of Mobitz 2 heart blocks. So I want you to check out the PR interval of this patient. This is like the first time the PR interval is being checked. Then you're checking the PR interval the second time, and then you're checking the third time also, and there is no change. In this particular condition, we don't have a serial prolongation of the PR interval, but the PR interval of this condition is constant, 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 constant. Then you can check out the T. After the T, the P wave is coming, but then I'm again waiting. Like a QRS complex should have occurred at this point of time. The patient himself put his like hand on his pulse and says, "See, doctor, intermittently, now doctor, some my pulse begins to disappear." So I said, "Okay, let me have a look." And really, there is a missed beat or a drop beat. And he also says, "Sir, every time I have this drop beat, no, I feel as if my head is spinning because the heart did not contract." Now, in this condition, again, the same thing will happen. The cardiac rhythm will reset. The PR interval of this patient will again be normal, 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 normal. And then again, you'll get a drop beat. At this moment, I also want to say that in Mobitz 1 as well as in Mobitz 2 heart block, what I want you to understand is that it is not a guarantee that the drop beat will occur after only 3 beats only. I have limited space on the slides, so shown after 3. It can be 4, it can be 5, it can be 6. But once a drop beat will occur, after the rhythm will reset also. Now, what are you supposed to do in an exam in the shortest possible time frame? Like, how will you crack the question whether it is Mobitz 1 or Mobitz 2 is? One, you have to count the PR interval multiple times. Like in this particular case, if I put numbers here, I can say the PR interval the first time is also normal. Second time is also like about 4 small squares, 160 millisecond. Then is 160, 160, 160. And again, like after the resetting, after the dropped beat, again the same values being present. So one way to solve the question is like you count the PR interval again multiple times, but there's a chance of forgetting. So all I want you to do in the actual exam, in the real, when it comes to the real game, what are you supposed to do? You are supposed to check out the PR interval after the drop beat by default and check it out before the drop beat, and mathematically both will be equal. So I wanted to mainly highlight that if there is a inequality of the PR interval, like in this particular case where I'm putting the data, inequality of the PR interval before and after, then you will say it is Mobitz 1 heart block. If it is gonna be equal, the PR interval mathematical duration before and after, then you will say that you're dealing with Mobitz 2 heart block. Before I go into the next ECG rhythm, which is a favorite of the INISET people, I would like to say that if you're an FMG student, you can skip this. There is no need for you to like try and remember the data that I'll say next. But yes, if you are an innocent or a NEET PG aspirant, you need to be very serious about the next one. But before I do that, I have a couple of handmade sketches before you. What I want you to understand is that the examiner himself might put an arrow vertically like this and say that this is the time when a missed beat is coming, and you can still pick it up because you can notice that in this patient between the R and the R, there's a substantial amount of gap present. Like you can see this is T, this is P. And then there should be a QRS complex coming here. It did not come. And even the distance between the R and R in this particular case is very, very significantly increased. Like this is the time when you are getting a substantial amount of bradycardia. So first I've just highlighted the T, P, and I've highlighted the area of the drop beat. Now comes the core aspect. The core aspect is on a visual scale. All you need to do is if you check out this PR interval at the moment, this one, and compare this with the one that is before the missed beat, you can see a huge asymmetry, man. I mean, the PR interval before is so broad. It's like prolonged PR interval, and this is gonna be like literally looking like normal only. But you see, one way to solve the question is obviously what I was saying. Check out the PR interval first time, compare it with the second time, and compare it with the third time. You can see it's showing an increment. In my opinion, it's always a hassle to remember that. So the easier way to get the question right is Mobitz 1 heart block can easily be identified M1 if the PR interval is unequal. Let's do this again for the inferior handmade sketch that I've also done. If you check out the PR interval after, that's the rule. Always check out after and then before, then mathematically it looks like almost to be equal. So therefore I will say that I'm dealing with the Mobitz 2 heart block at the moment. So this is the fastest way to get the question right, Mobitz 1 and Mobitz 2. And if you say that this is difficult, then the other way is obviously counting it 3 times. I mean, if you're okay with it, in my opinion, I don't have an issue. I mean, most teachers teach like this, serial prolongation, counted 3 times, 4 times, but it becomes a hassle. I said I was a poor mathematics student, so I had to find a hack. The hack was what I've done at the moment before you, and now I come back to the INISET version that I was talking about. A lot of students, when they sat for the paper, they said, sir, it was a question of Mobits 2. One guy said, no, sir, it was not Mobits 2. So I said, okay, hand draw before me. So why they said Mobits 2 was, like, you can see that if I, at the moment, I don't want to do any markings if you're doing it in annotated format in iPad. Like a lot of guys said, sir, PR interval on after, no, this looks like to be a drop beat at the moment. And they said, sir, PR interval before and after was equal. So it's a Mobits 2 hard block. The other guy, one of the students, he said, no, boss, like this is okay. I mean, what they're saying is perfectly right, but there is a subtle aspect which needs to be noted. The subtle aspect to be noted here is that this is normal sinus rhythm. This is PQRST. Then you can notice a P wave. Then again a normal sinus rhythm. Then again a P wave. Then again normal sinus rhythm is happening. You see, what is happening in this particular case is that I agree that there is a drop beat that is coming, that after PQRS should be coming in this particular patient also. But what is happening is a alternate pattern present, that is NSR followed by a P wave followed by a drop. Then again normal sinus rhythm, P wave followed by a drop. This is not a feature of Mobits 2 heart block. In Mobits 2 heart block, what happens is PR interval is constant. Then there is a drop. Here it is alternatively conducted P wave. Like why I'm saying normal sinus rhythm is because this is the time when the person is having a conducted P wave. Conducted means that after PQRS is coming. Then I'm saying it is a non-conducted P wave. Look at the English version that I'm saying. I am saying normal sinus rhythm means P wave is followed by a QRS complex. So conducted P wave, it means it went down, the current went down and there's a QRS complex. Then I said there is a non-conducted P wave present. So if they give you a pattern like this where normal sinus rhythm is followed by a P followed by a drop, I mean conducted, non-conducted P waves alternatively happening, then this is a variant of Mobits 2 heart block. It is called as 2:1 block. This is one of the most important ECGs which is misdiagnosed as Mobits 2 heart block, as I did initially, that if I just check out the PR interval before and after the drop, it will be equal. But unlike when it comes to Mobits 2, I'll say Mobits 2 again. Normal sinus rhythm, normal sinus rhythm, normal sinus rhythm. Then there is a drop happening. Then again normal sinus rhythm, drop happening. Drop can happen after 3 beats, 4 beats, but here it will occur alternatively. Alternatively means it is a conducted P wave, normal sinus rhythm. Then there is a non-conducted P wave, that's a drop. Then conducted, then non-conducted. So if it's happening alternatively, we call it a 2:1 block. But if it is like normal sinus rhythm, normal sinus rhythm, normal sinus rhythm, normal sinus rhythm, drop. Normal sinus rhythm, normal sinus rhythm, normal sinus rhythm, drop. Mobits 2. And the PR interval has to be constant all through. But if it is like a normal sinus rhythm and then a P wave followed by a drop, normal sinus P followed by a drop, then we call it 2:1. And in Mobits 1, obviously that's a total different league. Know that there's a prolongation of the PR interval that is happening in this patient. One of the causes of Mobits 1 heart block can be a beta blocker toxicity. Beta blocker overdosage can trigger development of Mobits 1 heart block in a patient. But Mobits 2 heart block is usually a complication after myocardial infarction. So is the issue of 2:1 block. If you are an innocent aspirant, the max attention that you need to give is for the 2:1 block component. In contrast, if you're an FMJ aspirant, then Mobits 1 और Mobits 2 कर लो, इतना बहुत है. और Mobits 1 और Mobits 2 में भी क्या देखना है आपको, सिर्फ इतना ही है. Mobits 1 में serial prolongation होती है, Mobits 2 में serial prolongation is not happening. The hand-drawn sketches highlight the same thing, M1 and M2, that have been explained. And now I will talk about what is called as a third-degree heart block. In third-degree heart block, what basically happens is that the AV node is damaged. Because the AV node is damaged, now the atria will be controlled by the SA node of the patient, and as a result of this, the atrial rate of this patient can be a maximum of about 100 beats per minute. I explained to you that SA node fires at a max rate of about 100 times per minute. In contrast, now the ventricles will be controlled by the bundle of His, and the ventricular rate of the patient will only be 40 beats per minute. You can notice a huge disparity in the atrial rate and the ventricular rate. In you and me, the atrial rate is always equal to the ventricular rate. Like suppose at the moment your ventricular rate is 75, atrial rate will be 75, vice versa. Here, what is happening is a presence of AV dissociation. This is the second time in this entire discussion that I mentioned the word AV dissociation. First one was for ventricular tachycardia. This time it's a bradyarrhythmia that I'm talking about. And therefore the examiner may help you by saying the word canon A wave is present. Apart from this, I can also say there is a lack of coordination between the two chambers of the heart because atria and ventricles are not working simultaneously, and there's a bradycardia. The combination of the two will cause syncopal events. Most of the time when it comes to third degree heart block in a patient, the question will begin by describing a old man who is having recurrent syncopal attacks on change of position. See, the maximum heart rate possible in this guy is 40 beats per minute. You and me are doing at the moment while sitting on a chair about 75. This guy's max heart rate is 40 beats per minute, man. So the question will begin by saying a old man comes with recurrent syncopal attacks, especially on change of position. Like he got up from the bed in the morning, his head started spinning, he fell down. Then somehow he regained consciousness because the heart rate is still at least in survival limits. And when he went to the washroom, when he stood up, like he was using an English toilet, so he sat on the toilet seat. When he stood up again, he had dizzy episode, again fell down. So lots of time these patients can have subdural hemorrhage or can have a CNS injury as well. So I'm describing a cardiac cause of syncope in this patient. When the ECG of this old man will be done, a very interesting phenomenon will be coming, that the atrial rate and the ventricular rate of this patient will not be matching. Now, how do you calculate the atrial rate? How do you calculate the ventricular rate is what I teach you. At the moment, what I've written in color green before you is called as the RR interval. RR interval is used by us to calculate the ventricular rate. Like at the moment, I've shown 4 large squares. So 300 divided by 4. This would mean that the ventricular rate of you and me, this is normal at the moment, is 75 beats per minute. Now, if I ask you, doctor, how do you calculate the atrial rate? Your answer will be that we calculate the atrial rate by PP interval, like we count the number of boxes between the P and the P. And if you count the number of boxes between P and P, it will still be identical, that is 4 large squares. I repeat that again. If you are asked that how do you calculate ventricular rate, RR interval, that's what we've been doing since beginning. If I ask you how do you calculate the atrial rate, it is PP interval. The number of boxes between the R and the P and P in you and me will always be equal. So our atrial rate and ventricular rate will always match. But now I'm going to draw the ECG of this patient, a third degree heart block. This was perfectly normal. Now I'm going to draw the ECG of this patient. This is P followed again by a P. Normally after P we don't get the P now. Here why it is happening P after P? Because atrial rate is 100. No, SN node generates the P wave. So number of P waves in this patient will be 100, but number of R waves will be only 40 per minute. I repeat that again. SN node generates the P wave. So number of P waves in the ECG will be 100. That is 2.5 times more than the ventricular rate. Number of R waves will only be 40. Guys, number of P and number of R in you and me is always equal. But in this particular person's ECG, what I'm showing is a very interesting phenomenon that is happening, that you can see P followed by a P. And when you check out the ECG of this patient, you might be noticing the following findings. In fact, the number of P's and number of R's is not matching. Let me just draw the number of P's here. I've shown almost 4, right? It could be like subsequently also, but due to lack of space, I can say the number of R waves shown here is only 2 and the number of P waves present is like, much more. So number of P and R is not matching. And if I go by the conventional definition, as I explained to you was the same color pattern being used. PP interval is less. And if you check out the RR interval, you can see the gap here. If you check out the RR interval, the gap that I'm showing in green is very substantially present. So if you want to go by the conventional method of PP interval and RR interval not matching, be my guest, and that is perfectly okay by me. But in my opinion, the simple data is, how do you identify the third degree heart block? The P wave number will never match with the R wave number. The simplest way is P wave and R wave number will not match, and this is the reason for this why P and R will never match is primarily because the AV node is completely busted. That is gonna be a third degree heart block in a patient. Therefore, for the third degree heart block in this patient, we will have to put in a dual chamber pacemaker. We will put in a special pacemaker where 2 wires will be going. One wire will say a shut up call to the SA node because SA node is not doing its job properly and neither is bundle of phase. I said a computer will be put in the chest of this patient. That's like a pacemaker. From this, inhibition mode will be utilized. Inhibition mode means we give a shut up call to the SA node and inhibition mode to the bundle of phase. Now the computer will control the firing of the heart and not like these pacemakers which are making a mess of the situation. So because I'm sending 2 wires out, that is why the word used here is a dual chamber pacing. This itself was a question. Dual chamber pacing is used for, answer would be given as for management of third degree heart block, and the clinical presentation that will usually be given for this patient will say a geriatric age group patient. This is like a 80-year-old man. The complaint of this patient is recurrent syncopal episodes. So there are multiple reasons for syncope. One of them can be cardiac also. So this man, when he came to me with recurrent syncopal attacks, what I did was I checked the BP of this patient first in supine position. Then I requested the patient to stand up. When the patient will stand up, I need to ideally ensure that some relative should be with him, and I will not check the BP immediately. I will wait for about 3 minutes, allowing the compensatory mechanisms to act. And after that, when I check the blood pressure of this patient on standing up, I will notice that after waiting for 3 minutes, the BP in the standing position of this patient will obviously be lesser. In you and me, the blood pressure can slightly fluctuate for a fraction of a second. If you and me suddenly stand up, no, for a fraction of a second, your head, my head might spin for a second, then our aldosterone kicks in and our BP stabilizes. But in this patient, if you check the BP in a standing position, you will notice that the systolic blood pressure of this patient will fall by more than 20 millimeter. The diastolic blood pressure of this patient will fall by a duration of more than by an amount of more than 10 millimeters. So what I wanted to say was postural hypotension will be demonstrated. I This that I've described is a very crude method, guys. This is like a very risky maneuver, because if I will make him stand, he can like fall, and I could have an injury also. So nowadays what we do for our patients is called as tilt table test. In a tilt table test, we will not make the patient stand up like this. Patient will be strapped to the hospital bed, and using a remote control, you will change the position of the bed to standing. Like patient is lying in the bed, then you press the remote control, the patient's position will come up. So tilt table test is actually used for identification of what I explained to you. In earlier times, when we never had facilities, this was the traditional way to demonstrate the presence of postural hypotension, also called as orthostatic hypotension. So ultimately in the question, he will say 80-year-old man with recurrent syncopal attacks is having orthostatic hypotension. The definition of orthostatic hypotension is the fall of systolic BP more than 20, diastolic more than 10. Ideally, we should not do this testing which I put in the box, because this is risky and patient can fall, end up with a head injury. So in hospital, we do a tilt table test. The values are still the same, that on tilt table test, the systolic blood pressure will fall by more than 20, diastolic blood pressure will fall more than 10. And in these particular patients, then he will say ECG was done. If you check out lead number 2 of this patient, you will notice one, that the heart rate of this patient is like very, very slow. If I use a finer font here, if this is R and this is R, then if I count, the heart rate of this patient is gonna be like, this is 5, 6, 7, 8, 9, 10, going up to 11. So if I mathematically divide 300 by 11, you can understand that the heart rate of this patient is literally in 20s, right? 11 threes would be 33. This is like 2 and then maybe 28 per minute, about 28, 29 per minute. So what I want to say is that if you get such a dismal heart rate, remember I told you maximum firing of bundle of his is max is 40. Max is 40, this is 28. So a lot of guys are able to solve the question by just looking at the heart rate of this patient. And second, what I want to bring to your attention in this particular patient is that the PP interval, if you count the number of boxes between the P and the P, and you count the number of boxes between R and R, they're different, because atrial and ventricular rate are firing at different rates in this individual. So the main message for third degree heart block is conventional method is PP and RR interval will not match. But a easier way in the question, like in FMG exam, it was super easy. वो खुद ही बोला, old man comes with syncopal attacks, demonstration of orthostatic hypertension, number of P and number of R is not matching. So because number of P and number of R was not matching, the diagnosis is already on. It is a third degree heart block. The alternative name for this condition. Now comes the real issue. वो सुनना क्या चाहता है? ये तो वो सब खुद ही बता देगा. The examiner himself will tell you that it is like by saying the fact that there is number of P and number of R is not matching. He has already told you it is a third degree heart block indirectly. What he wants to hear is the words that I'm writing. Instead of like third degree heart block, most of the time in the MCQs, this is written as complete heart block, or the word that the examiner wants to hear is called as Stokes-Adams syndrome. Stokes-Adams syndrome is a geriatric cause of neurocardiogenic shock. I mean, I can say this is a geriatric cause of development of recurrent syncopal attacks in an old person, because the AV node of the patient is destroyed due to old age. I mean, the AV node is not being able to function. So the same disorder is having three names. A parallel example I would like to say is pericardial shudder, pericardial knock, pericardial, shock, knock, shudder, or loud diastolic sound, like I described for constrictive pericarditis. Now, in the same spirit, there are different names for the same disorder, and this was like a description for what is called as a third degree heart block in a patient. So the treatment of this is also asked, that is a dual chamber pacing. And now what I will do is I'll do a summary of certain ECG findings of the bradycardia component. I'll also focus on once again when the time comes. Now, a summary of important findings to be remembered is P wave is generated from the SA node. The normal duration of the P wave is 120 milliseconds. And I also explained to you that the vertical height of the P wave should be always less than like 2.5 millimeter. Let's look at the abnormalities. I'm drawing a P wave at the moment where I'm increasing the duration of the P wave to more than 120 milliseconds. If the duration of the P wave is more than 120 milliseconds, then the word we use is called as P mitral. Why do we get a P mitral? The reason is that in this patient, the right atria size is normal, but the left atria is become relatively more dilated, and because of dilation, it will take more time for the current to go across the dilated left atria. You can see if the left atria is structurally dilated, then the current will take more time to go across the structurally dilated left atria. So P mitral basically means duration of the P wave more than 120 milliseconds. Normal, I told you, is 120 milliseconds. The reason for this is LAE, left atrial enlargement. In contrast, I'll show another diagram in which, in contrast to a normal P wave, the vertical height aspect, the vertical height, as I explained to you, should be about 2.5 millimeter. Here I'm saying the vertical height is increased, not the duration. Vertical height is increased. The vertical height increases in patients of right atrial enlargement. This was again an INISAT question that P pulmonale is found in. P pulmonale basically means that the vertical height of the P wave is more than 2.5 millimeter, and this is seen in right atrial enlargement, that is tricuspid stenosis, whereas P mitral is seen in mitral stenosis. Mitral stenosis as left atrial enlargement. Now, let's do it again. Let's go by English now. If I say the word P pulmonale, just think of the word pulmonale, pulmonary artery hypertension. If somebody will have pulmonary artery hypertension, that there would be more stress on the right ventricle, more stress on the right atria also. Imagine somebody is having higher pressure in the pulmonary artery, so right ventricle will have to apply more force to push blood in a forward direction. Right atria also will have to apply more force to send blood towards the lungs of the patient. So when the right atria will become enlarged, that is when we will get a P pulmonale in a patient. So just go by English. Pulmonale is pulmonary artery is connected to which side of the heart? Right side. So right atrial enlargement. P mitral valve is on which side? Left side. So left atrial enlargement. I first gave you rationale, like, the duration is more or the height is more. I'm saying how to solve the question in shortest possible time frame. Go by English. Mitral valve kahan hota hai? Left side pe, to left atrial enlargement. Pulmonary artery kahan pe hoti hai? Right side pe, to right atrial enlargement. Then comes the aspect of pseudo P pulmonale. Pseudo P pulmonale is a feature which is seen with electrolyte imbalance, that is hypokalemia. So I have also discussed the ECG findings of hyper and hypokalemia even in the kidney section, and I will be doing subsequently here also with respect to potassium, that when potassium becomes lesser, we have is an increase in the vertical height of the P wave. It's called as pseudo because there is no chamber enlargement. I mean, why we calling it pseudo is because of the fact that there is no chamber enlargement. It is electrolyte imbalance. That's why we call it pseudo. Then is absent P wave. This was described for a arrhythmia whose name was atrial fibrillation. In fact, for atrial fibrillation, I can put retrospectively that this is one condition where the first wave of ECG and the first wave of JVP will also disappear. I'll say this once again. Atrial fibrillation is a condition where the first wave of the JVP, A wave, will be absent. Atrial fibrillation is a condition in which the first wave of the ECG, that is P wave, would be absent. So, I mean, the commonest arrhythmia in clinical practice which can cause development of syncope due to clots in the left atria will not be having A wave as well as the P wave. Now after this I will discuss abnormalities of the Q wave. Like he will say deep Q waves are found in, then answer is myocardial infarction, and then is S1 Q3 T3 pattern. This I'll describe more in detail in respiratory section, but for today, I want you to remember that this is a feature that is seen with the patient having massive pulmonary embolism. Like this patient was having deep vein thrombosis and the clots of the soleal veins went into the heart and they're blocking the pulmonary artery. So that blockage of pulmonary artery by clot is called as pulmonary embolism, where we get S1 Q3 T3 pattern. And because if the pulmonary artery will get blocked, therefore the right ventricle of the patient will get dilated and stretched. So sometimes in MCQs, he may not write the word pulmonary embolism, he may write the word right ventricular strain pattern, because if you block the pulmonary artery, then right ventricle will be in strain, and therefore the word is right ventricular strain pattern. So here it is like Q3 is one of the component. In fact, let me describe this part here only. Meaning of the word S1, Q3, T3 is, though they'll not ask you this, just for understanding, deep S waves in lead 1. Then is gonna be deep Q waves in lead 3, and then is T wave inversion in lead 3. I mean, why we call it S1, Q3, T3 is what I'm trying to say, though this is usually not asked, but still for the sake of understanding fact, like deep S waves, S1 in lead 1, deep Q waves in lead 3, and then is T wave inversion. That would again be counted in lead number 3. This is a feature of pulmonary embolism and right ventricular strain pattern. Then comes the aspect of PR interval, which can be short or prolonged. So this is where I would like to mention that PR interval is normal in movements to heart block. It remains normal, 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 and we get drop beats. But prolonged PR interval is always a feature with respect to first degree heart block. First degree heart block, remember, was a condition in which the conduction system between the SA node and the AV node was slow. And one of the reasons for this was physiological. Like I described a marathon runner, like this guy does a lot of exercise, and that's why the PR interval of the patient can be prolonged. The second reason why we can get a prolonged PR interval is in MOBITS 1. In MOBITS 1, as I explained to you, it can be due to beta blocker overdosage. The conduction speed will become slow, slow, slow. And then subsequently, what you will notice is that there could be drop beats present in a patient, but PR interval always remains normal with respect to MOBITS to heart block. That is one of the core aspects to be remembered, that PR interval can be prolonged even in patients of third degree heart block. Third degree heart block, the more important thing is that PP and like RR interval are not matching, number of P and number of R are not matching, but still after all, like the PR interval can be prolonged even in patients of Stokes-Adams syndrome. Now the opposite of this would be a short PR interval that will be seen by tachycardia. Now, though I've explained this earlier, PR interval has an inverse relation with heart rate. I just said that verbally, that short PR interval will be seen in tachycardia. Now, what is the conditions, or what are those conditions where the examiner would like to describe tachycardia before you is, one, I can say tachycardia is one of the early examination findings of congestive heart failure. It can also be seen in endocrine conditions like Graves' disease. It can also be seen in thyroid, like Graves' disease has like thyroid hormones in excess. They have an intrinsic sympathomimetic activity. Then pheochromocytoma. So it gives a lot of leverage to examiner to actually ask you regarding a short PR interval, because the causes of tachycardia can be manifold. It is not only limited to only like cardiovascular conditions. It can be limited to panic attacks or anxiety in a patient, Graves' disease, pheochromocytoma, and then obviously like the data is for congestive heart failure. And then I will write like the core cardiology point, which I'll be explaining to you inferly, that is called as Wolff-Parkinson-White syndrome, WPW. Wolff-Parkinson-White syndrome is again a favorite from the FMG exam perspective. Has not been asked in NEET PG surprisingly, but in FMG exam they have been a little ballistic about it. So I'll explain it in next couple of minutes. But before we do that, I want you to compare the data in blue with the data in black. All the conditions that are written for on the color blue, they all imply like the heart is beating very fast, so there's a short PR interval in a patient. But if I say prolonged PR interval, it means that there is a bradycardia component. First degree heart block, MOBITS 1 heart block, Stokes-Adams syndrome, also called as third degree. But the important point is that PR interval will remain normal with respect to MOBITS 2 heart block in a patient. Once we get this right, we have a look at this line diagram that I have currently formed for you, or I am creating for you, which is like normally the conduction system goes like this: SA node, AV node, and then like the current enters into the bundle of His. It goes first into the bundle of His, then it goes into left fascicle, right fascicle, Purkinje. Now the condition that I'm showing here before you would be having like a accessory pathway in the heart. This accessory pathway will be short circuiting the AV node, because conduction through AV node is very slow. So the current will bypass the AV node and will be going very fast into the ventricles. So I can say the condition that I'm describing at the moment is Wolff-Parkinson-White, which is also called as pre-excitation syndrome. We call it pre-excitation because the ventricles in this condition are getting excited earlier than normal, and they will also contract earlier than normal. Now, why that early excitation is bad is because it will cause a contraction of a partially filled ventricle. You see, the problem in this patient is pre-excitation. The abnormal conduction system that is shown here is called as bundle of Kent, and the problem with bundle of Kent is that it has no decremental property. Like AV node is like that broken Indian highway. AV node is like a broken Indian highway. Thanks to the vagus nerve, the conduction is very slow. But when it comes to bundle of Kent, there is no vagus innervation present. So therefore, I can say that this pathway has no decremental property, and no decremental property means that current will preferably go through this pathway. I'll give an example. Suppose I give you an option. One is a broken Indian highway. Second is express highway created by Gadkari ji. Which one would you like to use? Obviously the express highway. Now, though express highway, you might have to pay a toll. Maybe it will be more expensive a ride, but you'll say, yeah, I'm ready. I'm ready to go by the longer way because it's like a smooth ride. Similarly, current is also going to go through the pathway of least resistance. So in the topic that I'm describing to you, which is called as Wolff-Parkinson-White syndrome, there is a early excitation of ventricles. There is no decremental property, and therefore the ventricles will get excited earlier. If there's an early excitation of ventricles, the complaint of these patients would be development of palpitations. Like this guy sitting on a chair, his heart rate in this case, the reason is no decremental property. So fast activation of the ventricles is occurring. The fast activation of the ventricles means a fast firing of the ventricles means the guy is having palpitations even while sitting on a chair. Now, initially I thought he's having panic attacks, and I was almost going to tell him that please go and see a psychiatrist. I don't think so. You have a cardiovascular problem. And then he told me a very shocking thing. He says, my elder brother was dancing in marriage party. Like it was like a cousin's wedding. And he says, my elder brother was dancing in a marriage party and he died suddenly. You would have seen so many videos of like a young, I think this was a recent video from Delhi, right? This girl, she was dancing at the wedding party of her elder sister, like very rich family. You'll notice all designer lehengas and designer, gowns being present there. And like this girl, she's dancing and she collapses on the stage, and everybody in the family is thinking, oh, she just fell down. They're laughing. And then she realized that she's no more. Because in India, there's nothing about awareness with respect to what is to be done if somebody collapses. There's no basic life support training. So this guy, when he told me, my family member died at marriage party while dancing, like I was little taken aback. I said, like, who was it? He said, it's my elder brother. And I was like, okay, sit down, we need to evaluate your ECG. When I evaluate the ECG of this patient, the first thing what ECG will show is, and that was what I was trying to explain to you, the ECG will show, because there's a palpitations, the heart rate of this guy is always more than 100. It will always show a short PR interval. And that is why I had included in the superior discussion of a short PR interval, because early excitation of ventricles is happening. Now, early excitation is bad, one, because this is causing palpitation. Second is it will cause a contraction of partially filled ventricle. Let me just write this there and you will be able to get a semblance of why the cardiac output is low. If I write the word contraction of a partially filled ventricle, then you can understand that input in the heart is less. If input will be less, then output will also be lesser. And that's why like these patients are not able to perform well in sports. Now, when I will scan through the ECG of this patient, I'll notice the following findings apart from short PR interval. So give me like about few seconds to just draw this. First, I'm drawing normal. This is P. Then I've shown a PR interval, QRS complex, and a T. This is like normal. In fact, let me make the T a little more taller as compared to P, because T vertical height is 5 and P vertical height is 2.5 millimeters. So this is normal. If you plan to do with me, and I think you should do it, the PR interval of this patient will be short. So I'll first decrease the duration of the PR interval. This is the PR interval. In this condition, I also want to say that the current will not go via the normal conduction pathway. The reason why we get a Q wave in ECG of normal patient is that there is a septal activation. I mean, if the current will go through the blue pathway and will enter in the bundle of Isno, that causes the Q wave. But in this patient, the current is not going by the normal pathway. The current is directly going down and is activating the ventricles of the patient. This is intermyocyte conduction once again. It's not utilizing Purkinje, but all I want to say is the blue network is not being followed. So Q wave will not be seen in the ECG of this patient. So this is what will be seen. The P will finish, and immediately after that you will notice that the RS complex will start. There is no Q present here because normal conduction is not happening. It's abnormal one. And when you draw the R wave of this patient, what I want you to do is that there should be a change in the slope in the upswing of the R wave. I want you to change the slope in the upswing of the R wave. Like in you and me, the R wave upswing is very, very straight. But in this case, what is happening is that there is a change in the slope. That again is happening because the current is entering in the heart through an abnormal way. So the second important ECG finding of this condition is the change in the slope in the upswing in the R wave. That again indicates abnormal conduction and is what is called as a delta wave. For these 2 points that I wanted to mention, short PR interval and delta wave, the aspect of Wolff-Parkinson-White syndrome had to be remembered, that if you get a patient who's having recurrent episodes of palpitations, family history, sudden cardiac death, and the ECG shows these 2 findings, that's going to be marked as short PR interval, delta wave present, that is the change in the upswing of the R wave is the delta wave. The third point that I'm writing is only for the sake of completion. He will write the word PJ interval is normal. I'll not get into the explanation of why PJ interval is normal. That's just the fact to be remembered. The more important thing is delta wave. That's a hot favorite. I don't know why, like in FMG exam, they've been after this. And then the question can change over to what do you do if it's an acute episode of palpitation? Like this guy came today, right now, he's not having a PSVT. I thought it's a PSVT, but it's the fast conduction occurring through the bundle of Kent. Then for acute episodes in this patient, we will secure a IV line and we will give procainamide. This is the first and the last time that in whole of cardiology that I'll be discussing with you. This is the first and the last time that I'll be describing this antiarrhythmic drug, which is class 1A, that is procainamide. If he says, how can we prevent these episodes from occurring? Then the best way would be that I'll tell him that I'll send you over to the electrophysiology department. They will first do mapping of your heart, and then using a laser beam, they will burn the abnormal electrical pathway. If we burn this abnormal electrical pathway, the current will be forced to go by the normal pathway, because this guy is born with 2 conduction system, normal as well as abnormal. If I burn the abnormal one, current will be forced to go through the normal one. So the treatment of choice for this particular condition should be answered as RFA. RFA would be standing for radiofrequency ablation. It is for prevention of episodes in future and is also the treatment of choice for this condition. That's a separate thing that he says that I don't have money at the moment, or I'm not ready for like this intervention at this moment. So said, okay, koi baat nahi, abhi you can take a medicine that will slow down the conduction through the AV node, and we can proceed with this procedure whenever you are available, when you have money or whenever you are ready, right? I mean, money is secondary. The more important thing is patient should be ready. But this is again a high yield MCQ that I've described before you for a condition where there's a fast activation of the ventricles, because the bundle of Kent has no decremental property. The condition is called as Wolff-Parkinson-White syndrome, and the same thing is what I've written superiorly before you. So at the moment, the short and the prolonged PR interval comparisons are to be remembered, but PR interval will always remain normal with respect to Mobitz 2 heart block. At this moment, I also want to draw your attention to the fact that what is PJ interval. So this endpoint of the S wave is what is called as J point. It's a pure physiology concept, guys, that J point is there, and J point is basically called as the isoelectric point. So if they want to get into a bit of physiology, they might be asking this. And now you can see the distance between the 2 black points, that is the starting of the P wave and the starting of the Q wave, is called as PR interval. And the distance between these 2 points, the black and the purple, is what is called as the QRS complex. If I combine the 2, then I have a new parameter that is called as PJ interval that I was explaining to you. I have not spoken about PJ interval at any point earlier, but I'm just going to bring to your reference here that PR interval in this patient is a combination of PR plus QRS. Now what happens in patients of WPW is that the PR will become short because of the fast conduction. The Q wave in this patient is relatively absent. The reason why Q is absent is because the current is not going by the normal circuit, so septal activation is not happening. And the RS complex in this patient is relatively slightly broad. That is because the conduction is occurring by the intermyocyte conduction. Like if you look at this diagram, no, in dotted purple I've shown a intermyocyte conduction. That explains the RS is broad. What has happened mathematically in WPW cases is that the shortening of PR is mathematically equal to the broadening of RS complex. Pure mathematics, no MBBS now. I said suppose PR interval decreases by few milliseconds. Suppose 10 millisecond is the PR interval reduction, and RS complex increases by 10 millisecond. Mathematically speaking, if the reduction of the PR is equal to the prolongation of RS, the PJ interval will remain constant. That is what happens in patients of WPW syndrome, that PJ interval is normal. This that I've explained to you is having no importance in MCQs. It is just to increase your comfort level that I wanted to say that the PJ interval is normal for this condition. Otherwise, the more important relevant things are what I've said at the bottom, that is a short PR interval delta wave. PJ is normal. I gave the rationale for this is this superiorly. At this moment, we are sorted for like the abnormalities of the PR interval, including the aspects of Mobitz 1 and Mobitz 2 heart block. And what I'll do quickly is also hand draw before you the Mobitz 1 and Mobitz 2 heart block at the moment. Like this is, try to do this way with me. Just increase the duration of the PR interval. This activity will just increase your comfort level, that you have to increase the duration of the PR interval, then draw P and then show like there's a drop beat that is happening. But if you notice that the PR interval is showing a serial prolongation like this, that's gonna be Mobitz 1 heart block. And for Mobitz 2 heart block, like, I don't need to draw it because it will be normal. And the more important aspect is that like when it comes to patient who's having 2:1 block, the 2:1 block would be something like this. This is normal sinus rhythm. Then draw a P followed by drop U waiting. Then again P, QRS, T, and again a P followed by a drop. You can notice once again I'll write this is normal sinus rhythm. This is the P wave that was not conducted. Then once again, there is a normal sinus rhythm where the P wave is getting conducted to the bottom. That is why RS complex is coming. Then there's a non-conducted P wave. You can put vertical arrows here also to say that these are the drops that are happening in this patient. So what I've tried to explain is not Mobitz 2, that you will be able to answer because PR interval is normal. I've just done a hand diagram here, hand drawn diagram here for Mobitz 1 heart block. And the second is a differential diagnosis of Mobitz 2 heart block, that is called as a 2:1 block. This is alternative conduction of impulses, that is P wave is getting when I say the word conducted, uska matlab hota hai ki P is followed by a QRS complex. When I say the word non-conducted, that means that the P is not followed by a QRS complex. So I basically just wanted to once again touch upon this topic of heart blocks, and well, they are important, guys. I mean, that's why these are being emphasized again and again. Then are QRS complex abnormalities. So QRS abnormalities can be narrow QRS tachycardia. That's always a feature that is seen with paroxysmal supraventricular tachycardia. Broad QRS tachycardia is seen with VT, where Josephson sign was also present. Delta wave has been explained to you as Wolff-Parkinson-White. So two are pending at the moment, J waves and epsilon waves. I'll draw line diagrams for the same and then I'll write down the conditions. J wave or Osborn wave is again like a must know fact for you guys. So I'll just draw this on the left for first J and then epsilon. This is a soldier. He was buried under ice. He was buried under snow because there was an avalanche at the Siachen Glacier. And what I have drawn at the moment is what is called as Osborn wave. I'll just draw this once again. Check it out. This is the P wave that I'm making at the moment. So far so good. Then is gonna be the Q and the R. When R is coming down, when R is coming down, then I've shown this notch. I've shown this notch. I've shown a S then. The end of the S is the isoelectric point, that is J point, and then is the T wave of this patient. So you can notice that this time I'm showing an abnormality not in the upswing of the R wave, but I'm showing an abnormality in the downswing of the R, that is called as J wave or Osborn wave. The condition in which you will be getting this is what is called as hypothermia. The soldier was buried under ice for maybe half an hour. Then he was rescued by digging. And when you do the ECG in hypothermia, where the core temperature is less than 35. Definition of hypothermia has also been asked. You can use a thermometer in the esophagus, or you can check out the core temperature in the rectum also. Preferred site would be lower esophagus, then is the rectum. For dead person, you can use rectum, not a problem. But in a live person, the preferred site for checking the core temperature. I mean, if he says that where would you like to place the sensor of the thermometer? Where would you like to place the sensor of the thermometer to check for the core temperature? Then lower esophagus is preferred over the rectum. In a dead person, obviously it is rectum. If lower esophagus is not given in options, again rectum can be an answer, but otherwise it's always advisable to answer this as lower esophagus is the site for checking the core temperature. The highlight here is abnormality not in the upswing of the R wave. When it comes to a delta wave, the problem was in the upswing of the R, but here the problem is with respect to the downswing of the R wave. And now I will mention the condition first, then I'll draw the ECG. Epsilon waves are found in arrhythmogenic right ventricular dysplasia. I'll be covering this topic subsequently, but now I will draw the ECG of this patient and I want you to compare with the sketch drawn superiorly. This is PQRS. Everything is normal till now, including the Q, R, and the S complexes. This is Q, this is R, this is S, and at the J point, guys, now I'm introducing, like, it looks like a M here. This is what is called as the epsilon wave. This that I've currently shown before you is called as the epsilon wave. So if I zoom it in, you can notice that the aberrations in the ECG are coming at a different point. Here the J point is over. This is the J point, this is like the isoelectric point, and after that I've shown like a M pattern that's called as epsilon wave in arrhythmogenic right ventricular dysplasia. So you learn three abnormalities: delta, Osborn wave, and epsilon wave, and I would want you to practice this in your own handwriting. Take a paper pencil and draw these waves so that you feel a little more comfortable while answering it. Before I move on to the ST elevation and the ST depression component, I want to utilize, I'll erase it. I just want to utilize this opportunity to make you practice again. Take out a paper pencil, guys, and do it right now, right here. This is P, and immediately after this, show a change in the slope in the upswing of the R. Then it's gonna be a T wave. Let's just replicate this again. The moment the P is finishing, the moment in the patient, the P is finishing, again, try to do this. Change the slope in the upswing in the R, draw QRS complex followed by a T. And if you do it like maybe a couple of times, you get a hang of this. You get a hang of this, like the P is finishing, change in the slope in the upswing in the R wave. That's called as delta wave. I said hot favorite of FMG examiner. In the next one, what I'll do is, this is a soldier who was buried under, I would say, ice for half an hour. So even bradycardia would be present. So PR interval would be prolonged. And then I want you to introduce a wave, not at like the upswing in the R, but in the downswing in the R here. Let's do it again. The soldier is in bradycardia state. That's because of the hypothermia component. And you notice that there is this wave present that's called as J wave, or also called as Osborn wave. This is hypothermia presentation. If he says soldier, it is okay. If he says a young guy with palpitations and sudden death in sibling brother sister, WPW, so it becomes relatively easier. And then is one more condition where sudden death in sibling brother is present, but here like he was not even dancing at a marriage party, he just died just like that, and the brother is coming for ECG, and in the brother you are noticing this M kind of a pattern present at the end of the S wave. That's what is called as a epsilon wave. So I've drawn three before you. I hope you could actually relate to this. The first one is delta wave, seen in what condition, guys? Say it out loud. I know I cannot hear you, but WPW. In the second one, the hypothermia component, this is Osborn wave that is seen in hypothermia. And then is the epsilon wave that is seen in patients who are suffering from arrhythmogenic right ventricular dysplasia. The treatment of this condition will also be discussed subsequently, but at the moment, like, I just wanted to invest some time into hand drawing the core information at this moment. And now we will talk about causes of ST segment elevation and ST segment depression. I'm erasing this because this unnecessarily increases the load in the ECG. The diagram for the same have already been drawn superiorly. This is the site where I've drawn them. Now coming to the causes of ST segment elevation, the first important reason would be an electrolyte imbalance. Remember, ST elevation, the elevation means it is going up. So the condition to be remembered would be hyperkalemia. The opposite of this also, I can utilize this opportunity to say that ST depression, the arrow is going down. So this would be seen with hypokalemia. So more data for hyper and hypokalemia will follow, but you can see for hypokalemia now you know 2 points, that you get a pseudo P pulmonale and you get a ST depression, whereas for hyperkalemia it is a ST segment elevation. The next part is not to be remembered. This is only for completion of mnemonic left bundle branch block. Then some people can be having a physiological ST elevation. My ECG shows always a physiological ST elevation. Was a shock to me. First time I looked at it, I said, holy shit, man, I am having a MI. And my consultant told me, no, you're not having a heart attack. You are having ST elevation because this is the early repolarization variant. I mean, it was a shock to me the first time I saw it. I mean, I started sweating, when I saw that ST elevation, I was like, oh man, happening to me. I was perfectly okay. So this is physiological, early repolarization variant. Alphabet V is the structural damage in the heart due to MI. It's called as ventricular aneurysm. This usually occurs if the MI treatment is started late due to structural damage, and that is again a cause of ST elevation. Alphabet T would be for trauma. The trauma could be blunt trauma. It could be like a trauma during a procedure like pericardiocentesis. Then I is obviously ischemia. That ischemic injury would be primarily myocardial infarction. Then even alphabet O stands for Osborn wave. I want you to remember that Osborn wave is occurring very close to the ST segment area. So it's also included under, like in the description of the textbook, no, like it's included still in the description for ST segment changes, though it causes a pseudo ST segment elevation, not a real one, but looks like an ST segment elevation because it was like a slight aberration at the downswing of the R wave. Then N is a must-know fact, guys. This is a neglected part. This was not fitting in the mnemonic. Actually, the condition that I want to bring to your attention is Prinzmetal angina. Now, because Prinzmetal angina was not fitting into like the description, so I had to change it to non-occlusive vasospasm. This is the only angina that has a ST elevation. By default, all anginas would be having a ST depression. But the only angina where ST elevation would be present is Prinzmetal angina. I repeat that again. In all anginas, you get ST depression except Prinzmetal angina. Alphabet A would be for acute pericarditis. I have described this in the earlier part of this video. And then is alphabet B. That is a sodium channel defect which is found in Indian patients and causes nocturnal death. That is called as Brugada syndrome. Details of Brugada will be added subsequently, but I just give you a heads up. It can have a ST segment elevation. Even this can cause sudden cardiac death, like the history of sudden cardiac death in a sibling, brother or sister is gradually increasing. And this time it is going to be a sodium channel defect in the heart that is called as Brugada. Hand draw a couple of important ones here. The first one that I'll hand draw is one for myocardial infarction, where you can draw convexity. Do this activity with me, guys. Draw a Q, then a R, and then show a convexity with a T wave inversion. That is what you get for myocardial infarction. Then use same color or a different color pen and show a ST elevation again, but this time don't show a convexity, show a concavity with the upper right T wave. That is a feature of acute pericarditis. Now I will be showing before you ST elevation of Brugada syndrome. This ST elevation of Brugada syndrome is different from others. This is R, this is S, and then this is called as a Cove pattern. This is called as COVE. It is called as a Cove pattern. So I'll just draw these ST elevations before you. This is called as ST elevation with the convexity. The second one that I've shown to you is a ST elevation with a concavity. And the third one that I've shown here before you is a ST elevation again, but is called as a COVE. That is a co-pattern. This is what you get with Brugada syndrome, which is going to be condition of a sodium channel defect. This is MI. The second one shown here is that of acute pericarditis, inflammation of the outermost layer of the heart. It can be due to COVID, TB, or lung cancer, and the co-pattern is with Brugada. So you can see like why ST elevation examiners would love to hear about it is simply because of the variations in the type of ST elevation that can be present. Osborn wave also we can draw again. Like why to hesitate? Like let's draw Osborn wave here again. Like try to show a prolonged PR interval because the patient has been under ice for a while, so the body will freeze, the heart will slow, and then when you draw this, then in the downswing of the R, that aberration can be shown, which can cause that pseudo ST segment elevation kind of a presentation. This is Osborn wave that's seen in hypothermia in a patient. So at the moment, the slide is full of information for ST elevation. The opposite of this is ST depression. So that is much more shorter and simpler. The first entry to be remembered is hypokalemia. Second is anginas of all varieties. Whether he says stable angina, unstable angina, doesn't matter. Like I'll be explaining these terms to you again later on also with respect to myocardial infarction and atherosclerosis, stable angina, unstable angina. But at the moment, the message is there are three types of angina: stable, unstable, Prinzmetal. Only one has a ST elevation, that is Prinzmetal. So that is what will be usually asked to you. Then the next cause for ST depression can be a medicine by the name of digoxin. I'm not saying digoxin toxicity. I'll talk about digoxin toxicity separately, but digoxin can cause a ST depression, and the type of ST depression seen here is also very peculiar. So I'm gonna try and hand draw this before you. The ST segment depression with respect to digoxin, not digoxin toxicity. Digoxin toxicity causes arrhythmia by the name of ventricular bigeminy. But at the moment, I want to draw to your attention, bring to your attention ST depression. Okay, will have a peculiarity, guys. So just be patient and let me just hand draw this before you. Okay, so at the moment, what I've shown is a ST depression. This peculiarity that I'm showing looks like a reverse hockey stick. You see, in India, the hockey that we play, the hockey stick is different, right? I'm talking about ice hockey, which Putin will be playing, or which, like, Americans or Canadians will be playing. So this is what is called as a hockey stick sign. Again, a very big peculiarity that is usually like loved by examiners. Hockey stick sign on ECG is a feature of, the answer is digoxin, not toxicity, but digoxin administration itself. And then any condition that will contribute to left ventricular hypertrophy can also be having ST segment depression. And conditions where we get a left ventricular hypertrophy can be like uncontrolled hypertension. It can be the condition where we were having presence of anacrotic pulse. Remember, Arnold Schwarzenegger had that condition, valvular aortic stenosis. There also left ventricular hypertrophy was shown. So LVH conditions like hypertension, aortic stenosis, hypertrophic cardiomyopathy, to name a few, can be having a presence of ST segment depression. No need for mnemonic on the right hand side, but for the left, obviously elevation mnemonic needs to be practiced. You can skip left bundle branch block, but the remaining aspects that I've said are definitely to be practiced. Now I'll talk about T-wave abnormalities. The vertical height of the T-wave should be less than 5 mm in the limb leads, less than 10 mm in the chest leads. T-wave inversion is found in hypokalemia. T-wave inversion can also be seen in angina. So the two conditions that are having ST depression initially can be having even a presence of could be having presence of T-wave inversion. In some MCQs, instead of writing the word angina, he can use a more technically demanding term that is called as subendocardial ischemia. Both mean the same only, whether I say subendocardial ischemia, whether I say angina. Then is tall tented T waves. These tall tented T waves, the vertical height will become more than 10 mm. They will become even taller than the height of the R. This T wave that I just drew before you, I'm going to draw it once again, will become taller than the height of the R wave, also is called as tall tented T wave. This is seen with hyperkalemia. This is one of the earliest ECG findings that is encountered in patients with hyperkalemia. I'll summarize the findings for hyper and hypokalemia in a second. And then hyperacute T waves are a ECG finding of MI. Here the T wave configuration will be different, so I'm gonna make it before you, but this is like a more asymmetrical. You see the one that I made, I'll do the tall tented T wave again with a separate color so that you can appreciate the difference here. This is PQRS, and then I want you to make a tall tented T wave and make it like a very pointed T wave, like the tip of a pen that I'm showing. So this is tall tented T wave. It is also very symmetrical. The upswing and downswing is equal. But if you check this one out, it's not symmetrical. I've drawn it a little asymmetrical. The upper part is also not pointed. It is a little more rounded, and this is a feature which is earliest with respect to myocardial infarction. Among the three, the most important one is, which I've highlighted in a different color, tall tented T wave should not be mixed up with hyperacute T wave. Lots of guys think that they mean the same. No, they don't mean the same. They're totally different. Tall tented T waves are a ECG finding of hyperkalemia. Instead of writing hyperkalemia, he can write conditions like acute kidney injury. He can write tumor lysis syndrome, rhabdomyolysis, any of those conditions where like the kidneys will fail. Ultimately, the potassium levels in the body of the patient will begin to rise. This also gives me a very good opportunity to compare the ECG findings of hyper and hypokalemia. So let's do this activity also, and I'll try to do it in the shortest possible time frame. The data has been told to you, but I'm trying to organize it. By organization of data, I mean like hyperkalemia, arrows going up. So imagine arrows going up, so T wave is also going up, so tall tented T wave. In hypokalemia, the arrows going down, so right opposite, T wave inversion. Yes guys, arrows going down, so T wave inversion. In hyperkalemia, there is a ST segment elevation, arrows going up, so elevation. In hypokalemia, the arrows going down, so this would be a ST segment depression. So very simple guys, going up, going down, you can work out the data. In hyperkalemia, what happens later is that the first wave, the ECG will disappear. This is the second time I've taught you the first wave, the ECG will disappear. Last time I told you atrial fibrillation, this time hyperkalemia. The opposite of this will be the T wave. The P wave will become taller, more than 2.5 millimeter in the absence of cardiac chamber enlargement. Remember I told you P pulmonale is seen with right atrial enlargement. Now there's no atrial chamber enlargement. There is an electrolyte imbalance. So therefore you will say pseudo P pulmonale in a patient. So if you just use English and invert the data, you will be sorted for as far as the ECG findings of hyper and hypokalemia are concerned. Now comes a very interesting fact in these patients of hyperkalemia, that the hyperkalemia actually slows the conduction through the Purkinje network. So because the conduction through Purkinje network is slowed, so QRS of this patient will be broad. Now keep your focus not on the screen but on me in the right hand corner of your mobile phone. Imagine first wave the ECG smaller has disappeared. QRS is becoming broad and T wave is going up. I said first wave the ECG छोटे होके गायब हो गया. QRS is broad and the T wave is going up. Imagine that broad QRS is merging with the alternated T wave, and ECG will look like this. This is not even an ECG. It looks like some mathematical wave. It is mainly for this description that this term I had to introduce, that the examiner will say sine wave pattern in ECG can be seen, and answer is hyperkalemia. And if I do not intervene at this point of time, then the guy can go into a cardiac arrest. Normal potassium in the body is in the range of about 3.5 to 5.5 milligrams. If it goes in excess of 8, the person will have a sine wave pattern and can undergo a cardiac arrest. In opposite, for hypokalemia, you need to remember is presence of a special finding which is called as prominent U wave. Most students are like, what? U wave in the ECG? We have read about PQRST. You are saying U wave. Yeah, guys, there is a positive reflection after the T wave that's called as prominent U wave. Because of this, the examiner will also use the word prolonged QU interval. When you read it the first time, it looks like a typing error because what I taught you was QT interval. Remember 360 to 440 millisecond. But here when it's saying QT, it is QU. It's not a spelling mistake because T is disappearing. T is having an inversion. So he will say prolonged QU interval. So new points that have been added here, the new points that have been added here are ones which are highlighted. The remainings have been discussed at some point or the other, but I tried to club them together for ECG findings of hyper and hypokalemia. Must know pattern, guys. Again, this is to be practiced by you in your handwriting in the shortest possible time frame. Should remain on your study table for next 2 to 3 days, including the abnormalities that I've said. So if I summarize, I've told you abnormalities of the P wave, Q wave, PR interval. Then is talking about the QRS complex abnormalities, super important. Then is WPW and ST and T wave changes. So I've just gone from P, PR, Q, QRS, T, and like the last waves, and that will make, I hopefully make things relatively easier for you. As far as Brugada and arrhythmogenic right ventricular dysplasia are concerned, the pathophysiology also needs to be practiced. Brugada syndrome is actually a disorder related to defective depolarization in the heart, that is a sodium channel defect. In arrhythmogenic right ventricular dysplasia, the problem is that there is a fibrofatty replacement in the heart. You see, heart is all about cardiac muscle. There is a fibrofatty deposition. Normally, we read about fat deposition in the liver. We call it cirrhosis. But today, I'm teaching you that due to genetic reasons in ARVD, there is a fibrofatty deposition in the right ventricle of the patient. And this fibrofatty area will act like a epileptogenic focus. The presentation of Brugada will begin by describing agonal breathing, that is terminal breathing. Just before somebody dies, breathing is like that. So agonal breathing and syncope would be developing. This is the condition that I'm describing, guys. Brugada syndrome should be remembered as overall the most common cause of sudden nocturnal death. I'm not even saying that the person was dancing at some marriage party or he was doing some workout, he was playing some cricket, football. No, this guy is sleeping and he's dying in his sleep. His family member woke up at morning and he saw इसका erratic breathing हो रहा है, and then the guy was no more. Like in the village they say that कोई spirit आ गया, spirit मतलब कोई भूत आ गया था, उसने इसको खा दिया या सांप ने काट लिया, something like that. They'll give an explanation, but this is one of the most common cause of sudden nocturnal death in Southeast Asian males. Though he's written the word Southeast Asian males, he's basically trying to refer to India only. Like this is a young guy, he's like 18 years of age, he lives in a rural village in Bihar, and he dies in his sleep. People are thinking that maybe snake bit him when he's sleeping in his hut, or maybe like some bhoot came or some upri hawa as they call it. It's nothing like upri hawa, it's the sodium channel defect that caused arrhythmia. Now, because there's a family history present in this case, so therefore in Brugada syndrome, his brother has come to me. He says, sir, my brother had died like this in his sleep. Can I also die? So I told him, let's do an ECG. And the ECG of this patient will be showing that feature that I had shown, that is ST elevation, but will be having that cove pattern. Like you can see ST elevation. I mean, this is the ST part now, it's going up, and then there's a T wave inversion. So we call it a ST elevation cove pattern. And STE means ST elevation, COV is cove pattern. And for this particular young boy who, or his teenager brother who's like petrified that I will also die like my brother, I will tell him that you won't, because we'll put a device in your chest. This device can sense your rhythm, and if arrhythmia will start, usually the arrhythmia in this patient can be like a VT, so the arrhythmia can be terminated by putting a device in the chest. Look at the technology that we have, that this 3 lakh rupees device that I put in the chest will continuously read the ECG. I'm not teaching a pacemaker, guys. I'm not talking about a pacemaker. Pacemaker was for Stokes-Adams syndrome. वो तो पुराना बात हो गया. I'm talking about implantable cardioverter defibrillator. This device will basically keep on reading the ECG. If it will detect abnormal rhythm, it will deliver a DC shock without the patient coming to know of it. Without the patient coming to know of it. So ICD is the treatment for Brugada syndrome. In contrast, in arrhythmogenic right ventricular dysphagia, it is palpitations and recurrent syncopal attack, and again, like sudden death in the sibling would be given. In both of them, the universal data would be family history of sudden cardiac death. Family history of sudden cardiac death in a sibling brother or sister would be mentioned. Either it can be Brugada, it can be ARVD. When you do the ECG of this patient, you will notice that this particular guy whose brother, in arrhythmogenic right ventricular dysplasia, if family history is available, great. But even without it, I can make a diagnosis, right? Because the ECG will be showing that M pattern kind of a presentation at the J point, which I explained to you is what is called as the epsilon wave. And even in this condition, like what I would like to do is manage the patient with ICD, that is implantable cardioverter defibrillator. So I have today in this discussion explained to you that for Wolff Parkinson White syndrome, don't answer ICD. There the answer would be given as radio frequency ablation, but for ARVD it is implantable cardioverter defibrillator that is to be answered. An additional point to just to wind this off is that the pattern of inheritance here happens to be autosomal dominant. With respect to Brugada, the defect is on chromosome number 3. The gene related to chromosome number 3 will be causing defective expression of sodium channel, that is SCN5A. And with respect to a arrhythmogenic right ventricular dysplasia, the gene involved is called as PKP2 gene, and the chromosome that is involved here happens to be chromosome number 12. So you can read about the genes and the chromosome for each of these disorders from the pathology domain as well, but from the clinical perspective, it is the ECG findings that we'll be evaluating in their brothers or sisters, and then we'll proceed with implantable cardioverter defibrillator for these patients. Next up, I would like to focus on a ECG. When you look at the precordial lead, so the one that is shown, that is V2 and V3, you can notice the characteristic co-pattern of ST segment elevation as I've been explaining to you. I'll just zoom it into the ECG so that I can highlight this. This that is going up is the R wave, then this is the S wave, and then in the upswing of the S wave, you should have had a ST segment here. Like this particular area should have been an isoelectric area, but instead it is going up, so that's ST elevation, which is followed by a T wave inversion as well. So as highlighted multiple times, this would be called as ST segment elevation with a co-pattern, very characteristic for Brugada syndrome. And in these patients, as explained, implantable cardioverter defibrillator needs to be deployed. It is just that I wanted to show on an actual patient's ECG also the pattern that we can see. And now next up, the topic that I'll explain to you is called as infective endocarditis. For this particular topic, let us look at first the meaning. I mean, what do you mean by the word infective endocarditis? So the condition is characterized by development of vegetations on the surface of the heart valve. Like you can take this to be a crude representation showing the left ventricle and the aortic valve. And now I'll be showing vegetations that are growing on the surface of the heart valve. What I mean by vegetations is that there will be a central core of fibrin. And on the central core of fibrin, there would be like millions and trillions and megatrillions of bacteria that would be growing. And these bacteria can then like embolize into the distal circulation. This is what I'm saying. On the superior surface of the heart valve as well as on the inferior surface of the heart valve, there are a lot of vegetations. We can see these vegetations on either echocardiography, or we can use the cardiac CT also. In fact, cardiac CT is more like accurate to pick up these vegetations on the heart surface as compared to an echocardiography. But if these vegetations are very small, then what do? Then we can go for a PET CT also, or we can go for blood culture, because see, the point is these vegetations actually can break off from here and then they can embolize into systemic circulation. So what I can say is that infective endocarditis is defined as a condition in which there is literally a shower of infective emboli into the distal circulation. Like every time the valves will open and close, the shearing stress will cause these vegetations to break off from here. These vegetations that break off from here would then be thrown into the distal circulation. So shower of infective emboli into the distal circulation will cause this person to develop fever. In fact, I can say heart is literally becoming a source of pumping organ, which is supposed to pump blood, but today it is pumping literally poison, that is sepsis, into systemic circulation. There is a shower of infective emboli into distal circulation. So therefore, all of these patients would be having high grade fever, chills and rigors, obviously. And then this infection can go into, let me say, the spleen. Now, spleen is that powerhouse that gives us ability to fight against bacteria. But today there would be a splenic abscess. So therefore, don't be surprised if a question mentions by describing a person who's having risk factors. Risk factors could be, he could say patient is having a pacemaker in place, or he may say patient is an IV drug user, rheumatic heart disease, cardiomyopathy. I mean, there must be some pre-existing heart damage present. I repeat my statement. The bottom line, or like the must know fact for development of infective endocarditis, is that there must be some pre-existing heart damage in a patient. Like, it may not be exactly the word heart damage, but he may just say that pre-existing heart disease is present. So if I say to you that if I have a patient of a rheumatic heart disease and today he's having fever for past 2 weeks, he has shown to multiple doctors the fever is not coming down, and then on examination I find a splenomegaly, and if he says what is the first differential diagnosis, my answer is query infective endocarditis. Let me say this again. A patient is having a pacemaker in his heart. Now the pacemaker, when it is put, there are wires obviously going from the pacemaker to the heart. So the bacteria from the skin can via the pacemaker wire go to the heart. So he will say patient with pacemaker was having high grade fever for past 2 weeks. People were thinking it could be dengue. I mean, doctors were thinking it could be dengue, or it could be typhoid, it could be common diseases in India, right? Leptospirosis, corrupt typhus, etc. So we did an infection panel, everything was negative, the fever is still persisting, and on examination we were finding a splenomegaly. So what do you suspect is infective endocarditis? The bottom line is, meaning of this word is that there is fibrin plus bacteria present on the heart valves, and they're called as friable vegetations. Why the pathologist will say friable is because they can break off from here, go into the systemic circulation. That's why I said the word shower of infective emboli, and multiple manifestations will develop. This is just the tip of the iceberg, that is splenomegaly. I mean, it is no big deal in these patients that the infection can go into the brain, and it can result in development of a brain abscess. So it could even cause a hemiplegia in a patient, or for that matter of fact, like this infection can go into distal circulation, it can contribute to a splenic abscess, it can result in development of a lung abscess in a patient. So, and spleen abscess, I'm saying big deal because spleen is the powerhouse of, which gives us that ability to fight against infections, and here itself it is getting infected. Apart from this, digital clubbing can be developing. Like normally we read clubbing with cases of lung cancer, but in infective endocarditis also, in the later run, you might have is development of digital clubbing. Normally clubbing is what we read with lung cancer, but here a parrot beak appearance, so the nails can be seen. So these are like couple of manifestations or complications that can be seen in infective endocarditis. Now in the light of these details, pre-existing heart disease and the clinical manifestations, let's look at the bacteria which are responsible. Some of the questions are going to be very simple and straightforward. Like he will use the word NVE, that is native valve endocarditis. That means the original heart valve of the patient is getting involved. Prosthetic heart valve, as you can understand, is the artificial heart valve that we are putting. Now, as far as native valve endocarditis is concerned, he will say that which heart valve will be having a higher predisposition. Then your answer would be mitral valve has a higher predisposition for development of infective endocarditis as compared to the aortic valve. So that's because mitral valve operates at a higher pressure gradient. So native valve endocarditis is more common in mitral valve as compared to aortic valve, and sometimes they might give you valvular lesions also. The valvular lesions can be like mitral regurgitation, mitral stenosis. In fact, I can write them down also: mitral regurgitation, mitral stenosis, aortic regurgitation, and then mitral stenosis again. I mean, aortic stenosis, two stenosis and two regurgitation. Now, what I want you to understand is that infective endocarditis is directly proportional to the pressure gradient in the heart. I repeat my statement: infective endocarditis risk is directly related to the pressure gradient in the heart. So we will have to go into a bit of mathematics and look at like which of these valvular lesions operates at the highest pressure gradient. One, I can say mitral stenosis is related to diastole, because MS is related to diastole. In the murmur section I've explained it, the flow of blood occurring in the heart, murmur would be produced is a mid diastolic murmur. So I am like ruling it out because this is a low diastole, is like a low pressure situation. So I'm left with like MR, AS and AR. Then even in aortic regurgitation, the blood will leak back into the heart in the phase of diastole. So even aortic regurgitation is ruled out because it's a diastolic event of early diastolic murmur. Between MR versus MS, like which of the two operates at the highest pressure gradient? Then mitral regurgitation, because here the pressure difference at which the murmur is created is LV minus LA. Aortic stenosis is because of the pressure difference between the left ventricle and the aorta. Like left ventricle pressure is 120, aorta pressure is also 120, or maybe let me say because of hypertrophy left ventricle pressure is 125, aorta pressure is 120. So it's a difference of only 5. But if you look at the pressure gradient here, mitral regurgitation operates at the highest pressure gradient. That is why there are two MCQs which are covered at the moment. The question will say which valve will be having higher chances. Then like there are 4 valves in the heart, 2 on the right and 2 on the left. On the right side pressure is any value, so your answer would be left sided valves, that is mitral. And in mitral valve also, if he says like mitral regurgitation versus aortic stenosis, then mathematically I've written here before you that mitral regurgitation operates at the highest pressure gradient. In fact, on the basis of this information, I can say that anytime they ask you any condition that predisposes to valvular lesion and he says what is that valvular lesion, answer is mitral regurgitation. Like if I say post MI, what is the commonest valvular regurgitation? Mitral regurgitation. Infective endocarditis, again rheumatic heart disease in children. मैंने बताया था ना early part में, rheumatic heart disease in a child is not mitral stenosis, it is still MR, mitral regurgitation. And another MCQ will say which of the following the infective endocarditis risk will be least. So the answer would be, rather from pediatrics, this is ASD, atrial septal defect, because atrial septal defect will operate at a pressure difference of only like the left atria minus the right atria, which is really a very low pressure. I mean, there's hardly few millimeter difference between the left atria and the right atria pressure difference. So least infective endocarditis risk is seen with, answer is ASD. This is again an important question. Highest risk is with mitral regurgitation. As far as the bacteria are concerned, the bacteria responsible for native valve endocarditis would be hospital acquired if we say Staph aureus. I mean, if he himself says that patient was hospitalized previously, central line was put, then Staph aureus is responsible. For community acquired, it is Streptococcus. For prosthetic valve endocarditis, that is the artificial heart valve that was put in a patient, then it is aortic valve rather that is more vulnerable. In native valve it is mitral, but in prosthetic valve it is the aortic valve that is more vulnerable. But for prosthetic, usually he does not go into which is the valve that is more vulnerable. The question will rather ask you regarding what is the bacteria. Now this that I'm describing before you has been asked upteenth number of times in FMG exam. Most of the time, like people are able to answer till 1 year correctly, that is, and sometimes incorrectly also, that is they tend to answer as Staphylococcus aureus. The answer is Coagulase negative Staphylococcus. Yes guys, now we don't use the word, like the examiner will not use the phrase staph epidermis, staph albus. He will be using the word cons. Con stands for Coagulase negative Staphylococcus. And then if I change my question and says that what is the organism responsible after 1 year, then the answer is not even Coagulase negative Staphylococcus. Then the answer will change over once again to Streptococcus. And he might even ask you like which species of Streptococcus. Then obviously we are not talking about Streptococcus pyogenes. We're talking about Streptococcus viridans. In most of these questions, the answer will revolve around either Staph aureus or it would be Streptococcus. And I would like you to give more importance to those MCQs where the answer happens to be Streptococcus, specifically Streptococcus viridans. Now I will teach you one infective endocarditis where answer is none of these. In the options, Staph aureus will also be there. In the options, Streptococcus will also be there. You will have to select neither of the two. Rather, you will select as Enterococci. Yes, guys, this patient underwent a transcatheter aortic valve replacement. Like in the beginning of this video, I had told you aortic stenosis occurred in Arnold Schwarzenegger. Then Arnold Schwarzenegger is the guy who has played the Terminator role in Terminator movie. Now, if he develops like infective endocarditis, God forbid, I'd never want him to suffer from that. But if somebody after a transcatheter aortic valve replacement ends up with infective endocarditis, we will call it TAVR, transcatheter aortic valve replacement. Infective endocarditis is caused by Enterococcus. I wrote that in caps because it is important. And then if he says that patient is having a pacemaker in place, Or instead of pacemaker, he says patient is having implantable cardioverter defibrillator. I hope it is also clear that pacemaker is put in those conditions where there is a heart block, and implantable cardioverter defibrillator is put in those conditions where there is the risk of tachyarrhythmias like Brugada syndrome, arrhythmogenic right ventricular dysplasia, because ICD is designed to treat recurrent tachyarrhythmias. Now, the wires of these devices can cause bacteria to be transmitted. The answer will again change over to cons, that is Coagulus negative staphylococcus. So you can see cons is the answer three times. One is PVE, prostatic valve endocarditis, for 2 to in the first 2 months of the operation, 2 to 12 months also the answer is the same. And then would be with respect to like a pacemaker was deployed and the person has developed subsequently infective endocarditis. CIED, the English word is cardiac implantable electronic devices. Pure English. No, I was using more technical words, pacemaker or implantable cardioverter defibrillator. He uses a simple English. The full form I have not written because it's understandable. C is cardiac, I is implantable electronic devices. The multiple electronic devices that we put two in front of you, pacemaker and implantable cardioverter defibrillator, and whichever be the bacteria, ultimately they will be thrown into systemic circulation, so we could get any of these complications of infective endocarditis. Now I will talk about the updated diagnostic criteria for this condition. So the updated criteria is like definitive infective endocarditis is based on demonstration of clinical as well as pathological criteria. Pathological criteria would mean that we are able to demonstrate microorganisms or active endocarditis in the form of vegetations or intracardiac abscess. What I mean by microorganisms is like, the blood culture can turn out to be positive, or we can do a PCR also, no? Like I'm saying, I can be doing a blood culture, that is okay, but blood culture is actually overrated because the report takes like long time to come. So I can do a PCR in a patient, I can do antibodies also. So I'll be teaching you like where we preferably do antibodies. Like if I take one bacteria named Coxiella burnetii, that comes from animals. Coxiella burnetii comes from animals. It is Q fever. It is a zoonotic infection that could be transmitted to a child who's having rheumatic heart disease. Like in India now, they keep goats and cows in the house. So goat or like cattle in the house could transmit Q fever to the child who's having rheumatic heart disease with mitral regurgitation. So lots of time like blood culture will be sterile. So I can be using antibody based tests like IgM class of antibody or PCR that can be done. Or like it is written active endocarditis demonstrated. Like you can use echocardiography, we can do cardiac CT, we can be doing a PET CT in a patient. So we are trying to nowadays, like earlier it was only about blood culture and echocardiography, but now you will notice that I put star marks on PCR, cardiac CT and PET CT. They have been added in the diagnostic criteria to improve the diagnostic yield. Well, what is going to be the diagnostic criteria? The clinicals that I'll discuss before you should be two major criteria, pretty straightforward. But then unlike in Jones criteria that you study in pediatrics, it is like two major or one major with two minor. Here it is one major with three minor criteria. So do remember, this is not the traumatic fever of pediatrics that you read where it is one major with two minor. It is one major with three minor, or it can be five minor criteria. So I'll enumerate those criteria before you. And most of the time, like in one of the FMG exams, he focused on minor criteria. Minor criteria, like he gave a question and then I'll describe that question also to you, but he said calculate how many minor criteria are present. So the first thing is predisposition. Predisposition means that it could be IV drug user, it could be previous history of infective endocarditis, prostatic heart valve, congenital heart disease, cardiac implantable electronic devices, any type of cardiomyopathy in a patient. The point I'm trying to make here is that there must be some pre-existing heart disease. Like the question in FMG exam said, IV drug user comes to the doctor with complaints of high grade fever for 3 weeks. So moment he said IV drug user, predisposition, that would click as one parameter, and said fever for like, fever was mentioned like 38 degrees Celsius, maybe 101, 102 degree Fahrenheit. We should obviously take the temperature on multiple occasions, at least minimum, or at least on 2 occasions to be sure. Yeah, and we should preferably use a digital thermometer, and like because we want to reduce the chances of any, like person can even put the thermometer in a hot water and even that can cause a falsely elevated value. So a digital thermometer that is used so that false values are negated. And like I said, IV drug user comes with presence of fever. Two minor criteria are already satisfied. Then he described that the patient is having oscillatory nodes that you can see. That is an immunological phenomenon. So I'll tell you the mnemonic how to remember them also. But like in the question, the language was, it was a 3 or 4 liner question. IV drug user comes with complaints of high grade fever on multiple occasions for previous 2 weeks, and he's found to have presence of oscillatory nodes. He said calculate how many minor criteria are satisfied. You will say 3 are getting satisfied. There was no mention of vascular phenomenon, but immunological phenomenon were given. So how to remember the immunological phenomenon which are given here? You can remember ROG. ROG in Hindi is disease basically. So R would stand for rot spots. You check them on a fundus examination. Then alphabet R is to be used second time for positive rheumatoid factor. Yes, guys, the same rheumatoid factor that we read for diagnosis of rheumatoid arthritis is also present here. It's simply an IgM class of antibody that can be positive. O is Osler's nodes. Where do you check for Osler nodes? Is in the tip of the finger. ये जो pulp होता है, in the tip of the finger, there would be nodes or nodules that can be felt. These are basically like immunological phenomenon to the embolization of vegetations that is occurring out of the heart of the patient, and Osler nodes are found in the tip of the fingers of the patient. Then they can be glomerulonephritis, post-streptococcal glomerulonephritis. So the message is ROG. R stands for rot spots. It is coming 2 times. R is for rot spots and positive RA factor. O is going to be Osler node. G is glomerulonephritis. Simple. The R is coming 2 times, however. So take care if he says positive rheumatoid factor in a question of infective endocarditis, it is still taken as one of the important minor diagnostic criteria. And then is vascular lesions. For vascular lesions, the most important one that I want to bring to your attention is the word Janeway lesions. What are Janeway lesions is that they would be erythematous macules in the palms and in the soles of the patient. These are vascular phenomenon because there is an embolization occurring out of the heart. So where do you see the Janeway lesions? The Janeway lesions are found in palms and soles. And what are they? They would be red spots. Obviously they may not be fully red, they can be like purplish to bluish in color. I mean anything related to blood would be purplish and bluish. So erythematous macules which are found in the palms and the soles of the patient. At this moment I want to say that in infective endocarditis, in the later part you might even get clubbing in the nails. In the hands and the palms you can be finding Janeway lesions, and in the tip of the finger Osler nodes. I said in the nail clubbing, in the tip of the finger Osler node, in the palms of the patient Janeway lesions can be present. Then another interesting finding phenomenon found here is mycotic aneurysm. On reading the word mycotic aneurysm, the impression that you get is it is related to fungus. No man, the question was very simple. Mycotic aneurysm is caused by, answer is bacteria, Staph aureus. Imagine bacteria went out of the heart and is causing damage to the blood vessels of the brain, and then they can rupture, and because of this rupture, don't be surprised if he says the word subarachnoid hemorrhage or intracranial hemorrhage. I'll say that again. Just like you guys are comfortable with the fact that berry aneurysm burst कर सकता है ना, berry aneurysm burst कर सकता है, वैसे ही mycotic aneurysm can also burst. Mycotic aneurysm is not caused by fungus, it is caused by Staph aureus, and then it can rupture or cause a intracranial hemorrhage in a patient. It could be conjunctival hemorrhages, there could be splenic abscesses, as I explained to you, brain abscess, splenic abscess can develop, they can be palpable purpura in a patient. So all these manifestations, I don't need to like say that these are vascular phenomenon, because purpura is a vascular phenomenon only. Reddish lesions in palms are again vascular phenomenon. Brain hemorrhage is a vascular phenomenon. I mean blood vessel related. There is damage to the blood vessels because of the antibodies that are being produced, and immunological phenomenon that are also running simultaneously. The immunological phenomenon, however, are not hemorrhages. Those would be rot spots, Osler nodes, and glomerulonephritis. And then for positive blood culture which is not meeting the above criteria, well, this statement I have not explained at the moment, so I will be giving you explanation for the microbiological evidence. The last one is still pending. Once I've done with the major one, I'll come back to point number E. But at this moment I want to say that if there is any patient with pacemaker in the heart, or it could be ICD, there could be IV drug user, infective endocarditis, any cardiac situation given, and there is a presence of fever with development of a splenomegaly, Janeway lesions, Osler nodes, positive RA factor, then you know that you're dealing with infective endocarditis. How many minor criteria required? Alone 5. If it is with major, that is still pending, then it would be 1 plus 3, otherwise it is 2 major criteria. And now what they've done here is added imaging criteria even in like for this particular situation, where I want to say that if there is a abnormal like activity on FDG PET or physical examination of valvular regurgitation. This is an add-on which has been added in the update of infective endocarditis. Let me explain the regurgitation part to you. Give me like a few seconds on the slide. Undivided, stop noting if you're doing at the moment. What I am saying is that I have shown vegetations which are present on the surface of the heart valves. Like I'll just recreate these vegetations. These are like bacterial vegetations on the surface of the heart. Some are bigger, some are relatively smaller, some are breaking from here and are going into distal circulation. What can happen in these patients is that if antibiotics are not started, then this infection can go deeper, 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 and it can result in development of a valve abscess also. So don't be surprised that sometimes on echocardiography he may say that the person is having valve abscess. That is one. And then what I want to bring to your attention is that sometimes the infection, like because there was a delay in treatment, so what can happen is that this can literally create a hole or a perforation occurring in the valve leaflet. That if you look at the line diagram, I have shown that there is literally a like a hole or like a gap that like you see normally whenever we read about the topic of endocarditis, what comes to our mind is maybe the valve cusps are damaged. Like this is the tip of the valve, so I'm not showing any damage to the tip of the valve. They are being able to approximate properly, but there is a perforation in the valve leaflet, and because of this perforation, if I zoom out, then I can say is that in the phase of diastole, the blood of the aorta can leak back through this perforation into the cardiac chamber, and this will result in creation of turbulence or it can create noise. Guys, in you and me, not a single drop of blood will ever leak from the aorta back into the chamber of the left ventricle. This on the top is the aorta. Inferly, this is the left ventricle. The blood is leaking from the aorta back into the left ventricle, not across incompetent valve leaflets. You can see that the valve leaflets competency is perfect, like they are able to oppose properly. So the blood is not leaking between the valve leaflets. It is coming through the perforation that has been created. This perforation was not present. It is the bacteria that destroyed the tissue of the valve. It literally punched a hole. It ate into the tissue of the valve. That is why I'll just rephrase what I had said earlier. This is an important minor diagnostic criteria that is in the update, right? This is a minor criteria, that is a new onset valvular regurgitation. This was not present previously. But now there will be a diastolic murmur that would be created in this patient. This is a new onset valvular regurgitation because of fulminant infection which developed in the form of a valve abscess or a ring abscess. So don't be surprised if on the major criteria I say the word vegetations on heart valves, I say the word valve abscess, ring abscess, and then subsequently a perforation that can be demonstrated. But the auscultatory finding, you see, the auscultatory finding of this perforation is a minor criteria. But if he says the word perforation is detected on echocardiography, perforation is detected on a cardiac CT, so if the word perforation is given, abscess is given on echocardiographic phenomenon, then you will say it is a major criteria, but the auscultation finding of the same would be considered as a minor diagnostic criteria for infective endocarditis. So I hope that makes sense at the moment why they've done this activity to increase the diagnostic yield. And now I will focus on like those microbiological criteria. That's gonna be major ones that are to be remembered. For the major criteria, guys, obviously we need to do imaging, because imaging would give me real-time evidence. And along with this, I also need to do a blood culture in a patient. Now, you might get a question where he will say between blood culture and echocardiography, or like between the imaging perspective and blood culture, which of the two would you like to do first? Then blood culture report will take at least 48 hours to come. If like I'm just saying that between the both of them that I'm writing before you, I'll write the names once again just to get the orientation. You see, there are two important major criteria that I will explain to you, as you can see on the slide. One is obviously the blood culture, and the second one is this echocardiography report or imaging. If he says between the two कि पहले कौन सा करेंगे, then you will notice that blood culture report will take at least minimum 40 to 72 hours to come. But imaging like echo or cardiac CT will give me the report immediately. So you will come across questions where he will say that in a suspected case of infective endocarditis, what is the first investigation to be done? Then Harrison says it is imaging that should be done first. Obviously, we will draw blood sample in the patient also. For blood sample, the older guidelines and the newer guidelines I'm mentioning both also so that you can relate to them. In the older guidelines, the rule was 3 to 1. What I meant by 3 to 1 was that you have to take total of 3 samples. Like for example, when I will come for like the rounds in the morning, I will be drawing about 20 ml blood sample of this patient, or maybe 10 to 20 ml blood, and I'll take it in like a culture bottle and send it to the laboratory. Then at 9 a.m. I will be drawing another blood sample from a different site, and I'll send it to the lab. And then the third one would be like at 10 a.m. So what I want to say from 3 to 1 is that there is 3 sets, right? and then is we should be taking 2 bottles each. That is, like I was saying, 20 ml blood now. So the 20 ml blood is 10 ml, 10 ml in each culture bottle, because it says aerobic and anaerobic cultures both should be said. So the technical data is that at 8 a.m. you will take 20 ml blood, 10 ml, 10 ml in each bottle. So it is 3 sets of 2 bottles each. It is 3 sets of 2 bottles each, at least 1 hour apart. These are the traditional guidelines which have been taught for last 30 years. For last 30 years, the traditional data has been how do you draw blood culture for patients of infective endocarditis. It is 3 sets of 2 bottles each, 1 hour apart. This is what is preferred. This is what is preferred. Now let's look at it from the practical perspective. If you will go to the patient over a span of 3 hours, and 3 times you will prick the patient, 1 hour apart from different venipuncture sites. First time when I went, I took a sample from the right cubital fossa, second time from the left cubital fossa. I can't poke the patient again at this side, right? So left cubital fossa. Then I took a sample from the dorsum of the hand. So obviously patient will literally cry, sir, I'm already sick, I'm having fever, and you poking me again and again. Every 1 hour you guys are coming and you are taking blood sample from different sites. So this is the older thinking. This is the old set or older data. It is still valid today. He says in the textbook, or he says in the current guidelines, that this older data, even today, like it is valid. Obviously, it is valid. But do you think that patients nowadays will be so cooperative? Let's talk about patient 30 years ago. No, patients were not like, they never used to say, this is my right. They never used to challenge you. Now, I would say that patient also will say, na, and let's be like a bit humane. See, this is to prove that there is a dissemination of infection happening, right? This is the ideal way. He says this is valid today also, but why to puncture the patient again and again? So nowadays the guidelines are slightly different. He says that you can manage with 2 sets of 2 bottles each, taken at like the same time itself. Like you can draw, like they use a big syringe 50 cc, and you can draw like 2 sets, that's almost like 10 ml, 10 ml, 4 bottles, and send it to the lab. The guidelines are at the moment, if he says the word typical organisms and atypical organisms. For typical organisms would be like Staph aureus or cons. Atypical would be like, Coxella burnetii or Bartonella. So if atypical organisms are being talked about or non-typical organisms are being talked about, then the answers will vary. For typical organisms, he says you can manage with 2 sets. But for non-typical organism, it is again 3 sets that are recommended. And nowadays the guidelines are you don't need to like these take these sets at a gap of 1 hour each. It can be taken in a single go only using a big jumbo syringe, and you can then make the sets and send it to the laboratory also. Now, when I say like this, the query of lot of students is what should we answer in the paper if this will come. So the MCQ has specifically said that based on the latest guidelines for typical organism, if that word is written typical organism or non-typical, then the answer will vary according between 2 sets and 3 sets. If nothing is given, then your answer would be 3 sets or 2 bottles each for different sites. This is the standard. Harrison still retains the older data. Harrison still retains the older data. He says this is like one of the ideal ways, that 3 sets or 2 bottles each, 1 hour apart, different sites, to prevent or demonstrate the dissemination of infection. Now it's okay. Patient said no, or like already patient is admitted in a hospital, so venous access will also be difficult most of the time. So he says why to get into the hassle of puncturing the patient again and again? Just take a single access, put in a wide bore needle, and draw a jumbo sample of blood and send it to the laboratory. So here I don't think so that you need to get bothered by what the apps are saying. This is what Harrison says, older as well as the newer data. I've handled both of them. For typical, it is like 2 sets. For non-typical, like for example Bartonella, Coxella, it is 3 sets. Then as I explained to you, we can be doing PCR also. We can do IgG class of antibodies, immunofluorescence, especially for this organism like Coxella. So this again is a question, like this is an old NEET PG question, that for which organism single blood culture is sufficient. The answer is Coxella burnetii, because we have an alternative test available, that is, you see, earlier the older guidelines were 3 sets or 2 bottles each. So out of these 3 sets, like, multiple samples have to be taken. But he said single, this is to be remembered, guys. Single blood culture report is sufficient, for which then the organism is Coxella burnetii. We can supplement it by antibody demonstration, or we can do indirect fluorescent investigation. Why I was deliberately like descriptive about it is because blood culture is overrated, guys. Blood culture, in like when you read microbiology, it's all about culture. He says कि भाई culture का report आने में time लगता है. It can be biased due to multiple reasons. So therefore, like, rely on technology. Coming to the imaging criteria, we can do echo, We can do a cardiac CT, we can do a FDG PET. He says we can do any one of these to demonstrate the presence of vegetations. It can be perforation, abscess, whatever. And then he also says a new thing in the major criteria that was not present. This new thing is surgical criteria. Like maybe patient was undergoing cardiac surgery and the cardiac surgeon has by direct inspection found that the vegetations are there on the heart valve. That is again a major criteria. This was never a part of the discussion. Earlier it was only microbiological criteria, microbiological criteria, imaging criteria. Now the new thing is surgical one. I'll just mark the names once again so that you can remember. It is MIS. In major criteria, it is MIS. This is what I would like to write. M is microbiological, I is imaging criteria, and S is surgical criteria. I'll move the slide so that I can just focus on the core things. Guys, microbiological criteria would be ideally 3 sets or 2 bottles each, 3 to 1, as I explained to you the ideal way. Alternative methods have also been discussed. In imaging, it can be echo, it can be cardiac CT, it can be FDG PET, and surgical criteria means direct inspection at the time of cardiothoracic vascular surgery. If you are having 2 of these features present, suppose out of these 3, if 2 are present, diagnosis is made. Suppose only 1 is present, then you need 3 minor, the superior ones that I explained to you, or you need at least 5 minor criteria for diagnosis of this patient. And as far as like patients of heart diseases are concerned, lots of time, like because dental caries is so common in India, people might be going ahead with dental procedures. So what are the indications for dental prophylaxis for infective endocarditis? Then for routine cases, you don't need to give dental prophylaxis, antibiotics before the procedure. See, if you're taking out a tooth, then the bacteria in the mouth can go in the bloodstream and can damage the heart valves in a patient. So if somebody is having a prosthetic heart valve, like somebody has undergone a TAVR, transcatheter aortic valve replacement, I would suggest the person to take antibiotics at least and inform the dentist. The dentist himself will give amoxicillin 30 to 60 minutes before the procedure. Previous endocarditis, congenital heart disease, repeat in last 6 months, and cardiac transplantation with valvulopathy. 4 standard indications for like dental prophylaxis, because when you do a root canal treatment or you do gum procedures or you do a dental extraction, the bacteria in the mouth can actually go to the heart and can cause infective endocarditis worsening, which is already present. What is the antibiotic recommended? Amoxi about 1 hour before the procedure. In case of penicillin allergy, clindamycin in the patient can also be used. The most important thing for this is MIS. Don't get confused by or worried about like कि मैं new data बोलूँगा या older data बोलूँगा. Both are valid, he says. Obviously, like the newer technology we have to embrace. वो बोलता है gold standard culture को मत बनाओ ना. PCR से diagnosis करो. Use like antibodies for detection, and if PCR is available, then gradually I think आने वाले time में blood culture को हटा ही देंगे यहाँ से. Okay, MIS is, M would be microbiological, I is imaging, and S is the surgical criteria. I've deliberately colored the surgical criteria separately because this is a new thing that has been added in the discussion. And after discussing this topic, our next focus would be to talk about a couple of cardiac emergencies. Now, the cardiac emergency first that I'm talking about is the patient is having extreme whiteness in both the lung fields. It looks like wings of a bat. So the person is having a bat wing pulmonary edema. The question himself mentioned that this person is a known case of hypertension. He is having a spike of blood pressure, and after that there's a breathing difficulty being experienced by a patient. Chest X-ray was given. There was a bat wing edema. I mean, what are the pointers that would be given for congestive heart failure? Would be bat wing edema, B-type natriuretic peptide, BNP levels in the patient, that is pro-anti-BNP levels would be elevated in a patient. Along with that, he might mention that there are bilateral crepitations in the lung fields of a patient. So if any of these data are given, like bat wing edema, elevated BNP levels, bilateral creps that are present, then we have to think in terms of that the person is having left ventricle failure. And why the person is having left ventricle failure or acute pulmonary edema is due to hypertensive crisis. Suppose the systolic blood pressure of a patient goes more than 180, diastolic blood pressure goes more than 120, and there is evidence of target organ damage. If I don't have evidence of target organ damage, then I will call it hypertensive urgency. But if there is a evidence of target organ damage, then yeah, I would be calling it a hypertensive crisis in a patient. So for this particular patient, now he has asked what is the drug of choice. This was like a case-based scenario that came in NEET PG, replicated again in FMG exam. I'll describe the question once again. He said a known case of hypertension has today come to the hospital with extreme shortness of breath. When the doctor evaluated the X-ray was given, like he did not describe the word bat wing edema, but this was the X-ray that my student sent me. Plus, he himself mentioned B-type natriuretic peptide is elevated. This is a product which is produced from the volume overloading of the left ventricle. Plus, he mentioned bilateral crepitations present. In fact, some students said, sir, it was also written bilateral fine crepitations. That gives even more accuracy to the fact that there would be presence of pulmonary edema in a patient. Coarse crepitations are what you can get in like pneumonia, but in cases of fluid in the alveoli due to cardiogenic pulmonary edema, it's mainly fine crackles or crepitations. Any of the two would be written. Now, I think I've given you enough lag time, guys. Can you tell me the best antihypertensive drug to bring down the blood pressure of this patient and treat the pulmonary edema component also? Options are standard. I mean, it's going to be like sodium nitroprusside, nitroglycerin, nicardipine, labetalol for this patient, and try to answer it without looking at your notes. Guys, the answer here would be given as NTG, that is nitroglycerin drip, because nitroglycerin being a drug which causes vasodilation. Being a vasodilator, it will help you in controlling the high blood pressure and will also treat the pulmonary edema component, because it is the preferred drug in patients of acute heart failure, because it will reduce the preload as the afterload, and predominantly it is the preload that would be affected. See, the overall treatment for this patient will be LMNOP. What I mean by LMNOP is that if he says what would you like to give first to the patient, then I would like to give Lasix, that is furosemide. The diuresis part that I want in this patient has to be aggressive. Obviously, the amount of Lasix that you might be giving in this patient might be very high, maybe up to like 160 milligrams. But the point is, when you give very high amount of Lasix, the diuresis will reduce the pulmonary edema component. Alphabet M will be for morphine. Question for you guys once again for testing your pharmacology. Why do you give morphine to patient of like hypertensive crisis with pulmonary edema? There is no chest pain. The patient came with shortness of breath only. So considering that the symptom of the patient is only shortness of breath, maybe he may also add the word that when the person will lie in supine position, then supine position will cause the breathing difficulty of the patient to worsen. So orthopnea can be given. And the question had mentioned, as I had explained to you, that this is a known case of hypertension about 60-70 years of age. He said, I mean, morphine is being given to this patient. Why? That's my question. Morphine is one drug which is obviously a painkiller. I agree to that, but today I'm not giving it for pain. Morphine has a vagotonic action. By vagotonic action, what it does is that it decreases the oxygen consumption of the heart, because when you activate the vagus nerve, then the heart rate would slightly reduce, and that will decrease the oxygen consumption of the heart. Then obviously the main drug that we will give is nitroglycerin in the form of a drip. It's a predominant vasodilator and will decrease the blood pressure and also reduce the preload of the heart. Then you need to give oxygen. Now, how will you be giving oxygen to the patient? What machine will you ask your nurse to bring in? You will ask your nurse to ask the technician to get in the BiPAP machine that will be helping in delivery of NIV, that is non-invasive ventilation. And then obviously we need to position the patient accordingly. Positioning would mean that the head end of the patient should be higher than the feet of the patient. We can adjust the hospital bed in such a position so that the patient is comfortable. The head-eye position will reduce the venous return to the heart. You see, if person will lie down, then the venous return of the legs will come to the heart. When person will lie down, the venous return of the legs will come to the heart. The heart is already decompensated, so it will worsen the pulmonary edema. So we will have to put the patient in like a reclining position or in a sitting position. This is what is called as Fowler position. So P basically means position. P basically means positioning of the patient, and the technical word is Fowler position. So this is management of acute pulmonary edema, and the single best answer in this question, which is usually very commonly asked in the exam, is nitroglycerin drip. The answer is not sodium nitroprusside. It is not nicardipine. Well, you answer nicardipine. I will also teach you that subsequently in my next slide. Nicardipine is to be answered for hemorrhagic stroke. If CNS emergency is given due to hypertension, he says patient known case of hypertension comes with features of stroke, then it is nicardipine. But if he says that what is the drug used in heart failure, then it is nitroglycerin drip. Next comes the aspect of cardiogenic shock in a patient. Now, cardiogenic shock and heart failure have identical findings. Cardiogenic shock will also be having presence of crepitations in the chest. Heart failure will also be having crepitations in the chest. So a query that I want to put to you is, like, when do you say cardiogenic shock? I mean, what is the difference between cardiogenic shock and heart failure? Both have breathing difficulty, both have pulmonary edema, both can have pedal edema, both can be having elevated JVP. So what is the fundamental difference? The fundamental difference is that if you're getting a question in which heart failure findings are present, I've already explained heart failure findings. Those could be in the form of pulmonary edema and pedal edema. Then, along with heart failure findings, if acute kidney injury is beginning to occur, definition of acute kidney injury, I'll say verbally, I've discussed it in nephrology. Serum creatinine will rise 1.5 to 1.9 times. Along with that, the urine output is also beginning to reduce. So if with heart failure findings, if acute kidney injury is beginning to occur, that is when we need to be aggressive and like treat cardiogenic shock. Cardiogenic shock is combination of heart failure findings where like pulmonary edema, pedal edema, elevated JVP can be written with the development of acute kidney injury that will cause a renal shutdown. Now, in earlier times, when the examiner used to ask regarding acute kidney injury, most students used to answer dopamine. Dopamine, because of pro-arrhythmogenic potential, is not recommended anymore. Guys, even in a pharmacology, in the older videos, they have said if there is acute kidney injury, give to the patient dopamine. We don't use dopamine now because of the pro-arrhythmogenic potential. The answer in this case should be given as norepinephrine. It is NORAD infusion that is given to patient. We can add dobutamine subsequently. Why we don't start with dobutamine initially is dobutamine will also act on alpha receptors and will cause vasodilation that will worsen the heart failure findings. If you will lower the BP further, blood supply to kidney will become lesser. So dobutamine is always started whenever in the person systolic BP is hitting about 100. Dobutamine acts on beta 1, that is okay. But at the same time, apart from stimulating beta 1, it also inhibits alpha. If you inhibit the alpha receptors, it will cause a vasodilation. Dobutamine कैसे काम करता है? वो beta 1 को activate करता है, heart rate को बढ़ाता है, so BP will increase. But at the same time, if you inhibit alpha, then you're decreasing the vasoconstriction. If you decrease the vasoconstriction, then the blood supply to kidney will become even more compromised. So he says, don't start with dobutamine. We always start with NORAD and then move on to like giving dobutamine to the patient. Then is routine heart failure, congestive heart failure. He may write the word acute heart failure or he may write the word HFref. HFref means heart failure with reduced ejection fraction. The definition of the word heart failure with reduced ejection fraction is that on echocardiography, the ejection fraction is less than 40%. Normal ejection fraction is 65%. Heart is one of the most effective machines, but if he says ejection fraction is less than 40%, then it is heart failure with reduced ejection fraction. So he says, what is the main drug that would be used, which is major mortality reducing drug? Then your answer would be given as ARNI. ARNI would be a combination of, I'll write it at the bottom, ARNI would be a combination of two things. That is, one, we can be using in the patient angiotensin receptor blocker. The commonest one used is valsartan. And along with that, valsartan, that is angiotensin receptor blocker, the second molecule that we use is a nephrilysin inhibitor. While I'm writing that nephrilysin inhibitor, I know you know the name sacubitril. Tell me the mechanism of action. Like nephrilysin inhibitor, that is okay, but like what is the mechanism of action of nephrilysin inhibitor? Your answer would be nephrilysin inhibitor acts by inhibiting the breakdown or degradation of BNP. You see, BNP is produced from the ventricles due to volume overloading. If you will inhibit the degradation of BNP, then BNP will be able to act for longer duration. If BNP will be able to act for longer duration, it will be able to cause more natriuresis, and this will be beneficial for me because when I lose salt from the body, it will be beneficial for the person. Natriuresis will cause salt loss. Now, in heart failure, if you lose salt, then it is beneficial because it will prevent the further expansion of the plasma volume. So the molecule that would be used in this particular case would be sacubitril. So one, you need to remember that valsartan and sacubitril are drugs which are like the major mortality reducing drugs for patients who are having presentation of heart failure with reduced ejection fraction. This is the single best answer. If this is not in the options, then you will answer as ACE inhibitors in a patient. Like it is not both of them. Either it is ARNI or it is ACE inhibitors that can be given. Then additional molecules which can be used in this patient. So I'll write 1 and 1 again. But this time I'll write it as like 1 dash. I've written 1 or 1 dash, meaning that either I give ARNI or I can give ACE inhibitors to a patient. Then we can give beta blockers also. We can give mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonist would be like spironolactone. And then comes one of the most important questions, which has like totally revolutionized everything, that which anti-diabetic drug can be given to patients who are having heart failure, even if the guy is a non-diabetic. Obviously, we give like SGLT2 inhibitor to diabetics, but then SGLT2 inhibitors are those wonder drugs which have been found to be beneficial in both nowadays in heart failure with reduced as well as in preserved ejection fraction. So I will add some more details on this slide for like beta blockers also, and then I'll add data for MRA and SGLT2 inhibitors. As far as the beta blockers that I've described, I'll continue writing in black for like the data for HFrEF. The data in blue is for patients of like left ventricle failure onwards. Then like you see, what I wanted to understand is in acute pulmonary edema, you are supposed to give LMNOP. Once the acute pulmonary edema part is over, then these are the drugs that would be given to a patient. So this is the same patient, like the same patient of hypertensive crisis. When he will improve and he will come out of acute pulmonary edema, his ejection fraction would still be lesser. That is when I shift this patient or plan to shift this patient out of CCU into the ward, then these are the drugs that would be given to a patient. I'll say this again: hypertension wala patient came to the hospital. Right now he's having pulmonary edema, so for 2 days I will keep in his CCU. I will give him lot of Lasix, morphine, nitrates, NIV, and Fowler position. After 2 days, now saturation has improved. His lungs have, like, X-ray has improved. The bad wing pulmonary edema has improved. Patient is feeling better. He can even, do sleeping in semi-reclining position, not fully supine, but semi-reclining. He's able to sleep. So person is better. Now I want to shift him to the ward. So when I shift him to the ward, these are the medicines that would be given: ARNI or ACE inhibitor. Then we will add beta blockers, which are like one of the very wonder drugs that that decrease the oxygen consumption of the heart, MRAs, and then SGLT2 inhibitors. So it's the same patient, but like the data in black is given to say not that it's a different patient, it's just different color added, just to introduce that the treatment of the same patient done in the ward will be different from what we are doing in the coronary care unit initially. So beta blockers would be given. Here he has asked like what beta blockers are used in patients of heart failure. He may either write the word heart failure, he may say what is the beta blocker that you would be using for these patients who are having heart failure with reduced ejection fraction, or he may just write the word chronic heart failure. Beta blockers in heart failure. I wanted to remember beta blockers are not given in patients who are having acute heart failure. They are used in only chronic heart failure. So here these words mean the same. Whether I say plain heart failure, whether I say heart failure with reduced ejection fraction, whether I say chronic heart failure, they all mean the same. Listen to my statement with care. Beta blockers would absolutely be contraindicated in patients having acute heart failure / acute pulmonary edema. If the patient, when he came to me, his BP was very, very high, he was having tachycardia component, which was helping in clearance of pulmonary edema. If by mistake I will give beta blocker, I will kill the patient. Guys, this is an important concept that is missed by students even after studying pharma, that beta blockers are good in heart failure, understandable, but they are not used in acute heart failure. They are used in chronic heart failure. That's the main message. Acute में यूज नहीं करते हैं. Acute में देंगे तो भाई जो tachycardia component है ना, जो pulmonary edema clear करने में मदद कर रहा है, that will be cut off. But once the patient is stable, then you can use beta blockers. Now, what are the beta blockers that can be used? What are the beta blockers that can be used? FDA approved वाले सारे नहीं use करते ना. So the beta blocker that can be used in this patient is metoprolol. Obviously, like this has been used for ages altogether. Then is gonna be carvedilol, and the third one, yes guys, don't check out the notes. Let me know. Carvedilol is alpha plus beta, right? Then like metoprolol, carvedilol. Can I have the third one, please? FDA approved. That would be bisoprolol. So all beta blockers are not FDA approved, guys. All beta blockers are not FDA approved for management of patients of chronic heart failure, also written as heart failure with reduced ejection fraction, also written as plain heart failure. If you read the word AHF, if you read the word acute pulmonary edema, if you read the word acute heart failure, they both mean the same. But यही patient जब improve कर जाता है after 48 hours of your treatment, 72 hours of your treatment, when you shift him to the ward, that is when you would be using the following approach that is being discussed at the moment. So we will be using ARNI or ACE inhibitors, then we will be giving beta blockers to these patients, any of the three. Then we will also be using MRA, that is mineralocorticoid receptor antagonists in the patient. The mineralocorticoid receptor antagonists are used because in heart failure, aldosterone RAS system is activated. So I need to give a aldosterone antagonist. So I can be using spironolactone, I can be using like eplerenone, finrenone. These are a couple of like aldosterone antagonist drugs that can be used in a patient. And then obviously the drugs which will even help in saving the kidney, even they can be used in those patients where eGFR is relatively low, because a lot of hypertensive patients can be having damage to the kidneys as well. This drug can be used in non-diabetics also. This is obviously a hot favorite of the examiner, that is empagliflozin. I once again like dapagliflozin, empagliflozin. The point is SGLT2 inhibitors can be used in non-diabetic patients as well for management of heart failure. Why? Because they cause salt loss, no? salt and glucose loss. Because of the salt loss, this medicine will cause the systolic blood pressure to fall by only about 5 millimeter. The query that I get from lot of doctors is, sir, it's causing only a 5 millimeter fall. So why are you so happy about it? Why it is only causing a 5 millimeter fall? That is what I want. If the BP fall is more, then it causes postural hypotension, dizziness, and vertigo, and patient can fall. So I was waiting for a drug to come in the market which will cause just a thoda sa fall. See, our heart is beating 75 beats per minute. Multiply that by 60, it is 5,000 times in 1 hour. Multiply that by 24, it is 1 lakh times a day. Our heart is beating 1 lakh, more than 1 lakh. Mathematics करके देख लो. Our heart beats more than 1 lakh times per day for our entire lifespan, 70-75 years जो भी इंडिया में है. So for that longer duration, if you are causing that systolic blood pressure to decrease by only 5, you are reducing the stress on the heart, you are increasing longevity. So all of these drugs that I've explained to you are mortality reducing drugs. ये स्लाइड सर जो मैंने बोली है ना, ये पूरी समरी है जो आप पढ़ते हो ना फार्माकोलॉजी में. I mean, if you're following this slide, that means your pharma concepts are clear. If you had even one iota of doubt with respect to any of these statements, like suppose आप dopamine बोल दिए, यहाँ पे dobutamine बोल दिए, that means you've not studied your pharmacology domain. So मैं suggest करूँगा कि after finishing this video, listen to the pharma part. Then you will understand this slide better. Come back and listen to this again. अगर आपको लग रहा है ना कि सर ये वाला स्लाइड थोड़ा टेक्निकल है, भाई टेक्निकल्स इज व्हाट दे आर आस्किंग कि भाई इनिशियल आया क्या करोगे, सब्सिक्वेंटली आया क्या करोगे, कार्डियोजेनिक शॉक में चला गया क्या करोगे. द फर्स्ट पेशेंट इज द प्रेजेंटेशन. The second part of that is cardiogenic shock, is the worsening of this guy, that he will have acute pulmonary edema plus kidney will shut down, multi-organ dysfunction हो रहा है. But luckily, because I treated him on time, he did not go into cardiogenic shock but has recovered. When he will go into recovery mode, that is the drugs that I'll be using. और आप बोलते हो सर इतना सब कुछ मत बताओ, FMG एग्जाम के लिए बता दो क्या आना चाहिए. तो मैं बोलूँगा 2 पॉइंट आने चाहिए. इफ़ यू आर अ नीट PG एस्पिरेंट, इनीसेट एस्पिरेंट, आपको पूरा आना है. बट इफ़ यू से सर आई एम एन FMG एस्पिरेंट, आप मुझे मोटे मोटा बता दो कि व्हाट इज़ द मिनिमम दैट आई शुड बी नोइंग हेयर. तो पहले तो फार्मा तो सुननी है, right? Listen to the pharmacologist. But 2 concepts which I want you to remember forever for your life is nitroglycerin drip is the drug of choice for acute pulmonary edema. That is one. And second point which I want you to remember is that drug of choice for reducing mortality, major mortality reducing drug for heart failure with reduced ejection fraction is ARNI. Obviously, I would love you guys to study the whole thing that I have said, but this is the minimum that you're supposed to remember. इसके ऊपर वाले जो क्वेश्चंस है, ऑब्वियसली वो ही कैन आस्क यू बट एनी वन ऑफ दीज ड्रग्स. सी व्हाट आई एम ट्राइंग टू से इज द बेसिक मिनिमम दैट जो आपसे कभी गलत नहीं होना चाहिए कि भाई acute pulmonary edema का सवाल गलत हो गया, heart failure with reduced ejection fraction में, like DOC word is not given nowadays. He writes the word major mortality reducing drug in a patient. And like the third concept, again, like if I, क्योंकि मैं बोल रहा था कि भाई broad perspective में क्या आना चाहिए, beta blockers are contraindicated in acute heart failure. मैंने बीटा ब्लॉकर्स के लिए तो ना आगे भी आप देखोगे मैंने निमोनिक बताया हुआ ABC. Beta blockers are contraindicated. A for acute pulmonary edema, V for bronchial asthma, C for patients of COPD. I'll write that contraindication subsequently also. B सब याद रखते हैं, बीटा ब्लॉकर contraindicated in bronchial asthma. C सब याद रखते हैं, COPD. But I will teach you the A, that is acute pulmonary edema. Then I'll also teach you another thing. Beta blockers are not given in patients of Prinzmetal angina, vasospastic angina. Right, so a lot of interesting data that is lined up, but I would rate this as one must-know slide from cardiovascular system. So if you had any iota of doubt related to the inputs that I've said, or if these things were like you आप बोलते हो नहीं सर याद नहीं हो रहा था, तो it's like you have to go through the pharma domain again and then come back here, and then if you listen to this is going to make more sense to you at the moment. Okay जी, now we come to heart failure with preserved ejection fraction. On this the query of students is sir खुद ही तो लिखा है preserved, तो फिर इसका मतलब तो normal हो गया ना. No, when you say the word preserved ejection fraction, it is in a relative sense that the person is not gonna die very soon. In preserved ejection fraction, the ejection fraction is equal to or is more than 50%. It is not 65%. If I write down the data, normal ejection fraction कैसे calculate करते हैं? So normal ejection fraction is stroke volume divided by end diastolic volume. Stroke volume is about 80 ml, the blood going out of the heart every time, and diastolic volume is 130 ml. If you divide this mathematically, heart is the most efficient machine made by God. Heart is the most efficient machine made by God, 65%. Preserved ejection fraction means heart failure, ejection fraction between 50 to 65. The major mortality reducing drug here also is ARNI. The second drugs which are showing benefit for these patients is again SGLT2 inhibitors. So SGL, like the anti-diabetic drugs, na, tabhi to SGLT2 inhibitors are becoming a hot favorite. Tabhi to in the diabetes section I've highlighted that for all diabetic patients, what is recommended nowadays is start treatment with metformin with SGLT2 inhibitor. हम स्टार्टिंग में अगर मेटफॉर्मिन के साथ में SGLT2 inhibitor ऐड कर देंगे, so the cardiorenal benefit will prevent the deterioration of like the cardiac function in these patients. As I've explained to you already, cutoff value for hypertensive emergency is value more than 180 by 120 millimeter of mercury with evidence of target organ damage. If he says the word hypertensive urgency, the blood pressure is more than 180 by 120, but there is no evidence of target organ damage. Let me see if you got my concept or not. The main feature that you need to remember for emergency word is the word TOD, that is target organ damage in a patient. Let's see if you've understood me. Suppose a patient came today, his BP was 160 by 120 and he had a brain hemorrhage. Then would you call it an urgency or would you call it an emergency? You're going to call it an emergency, right? It is not the mathematical value of blood pressure. It is the presence or absence of target organ damage that is more important. Let me do it again. Today a patient came to the OPD. He said, sir, wo sir mein dard ho raha tha, and like I have lot of stress at work. I wasn't feeling well, so I came to the hospital. So I checked his BP. It was 200 by 100. 200 by 100. Walk in patient into the OPD. No neurological deficit. Smile करके आपसे बात कर रहा है, मतलब he's like somebody will greet you to partial smile तो होता ही है. So not that he's very happy, but he's like greeting you, hello doctor, and like I'm having a headache and I've come to you. BP is 200 by 100. Walk in patient, no target organ damage. You will say hypertensive urgency. In hypertensive urgency, don't try to lower the BP aggressively. In hypertensive urgency, don't try to lower the BP aggressively. You will start the patient on ACE inhibitors. So if he says for urgency, what will you do? You'll give ACE inhibitor. But for emergency, your answer will depend upon whether it is a cardiac emergency or a neurological emergency. Especially if he says neurological emergency like brain hemorrhage has occurred in a patient, which is proven by a CT scan, then your answer will be I will lower the BP by giving nicardipine to the patient. But suppose he gives you acute pulmonary edema, which I explained, bat wing edema, elevated BNP, orthopnea kind of manifestation, bilateral crepitations in the chest. Then what will you give? Then I've already given you a heads up, IV nitroglycerin drip. These 2 points again, if I'll say like this, if you say that doctor, I have studied antihypertensive drugs, cardiovascular system drugs multiple times, but this was not clear to me, then I'll say that you did not listen to my words. Might look a little harsh, but like I'll say, doctor, you did not read pharmacology very well. You see, this is the core thing. I mean, after all, why are we studying all this? Medical science is to be precise. There's a lot of data, right? There's so many drugs which are available. करना क्या है उस टाइम पे acute pulmonary edema में क्या करना है? Anti-G drip चालू करना है. And if it's gonna be a brain hemorrhage in a patient, it is IV nicardipine. तो total 5 बज पॉइंट्स हो गए जो मैं फिर से हाईलाइट कर रहा हूँ. पहले तो मैं बोल रहा था ना acute pulmonary edema, LMNOP, heart failure with reduced ejection fraction, ARNI. Then I talked about heart failure. Then I said beta blockers are contraindicated in acute heart failure. 3 buzz points already. These are 2 that are added to your vocabulary, especially like nitroglycerin drip is to be given, has been told even in the previous slide. And then I'll mention regarding the target BP to be obtained. The target BP in brain hemorrhage is not 120 by 80. He says if you will not lower the BP, then there would be like rebleeding. If you don't lower the blood pressure, rebleeding. If you lower the blood pressure to 120 by 80, it will cause a brain infarction. So we deliberately keep a threshold at 140 by 90. This has been asked in NEET PG. What is the target blood pressure to be obtained in patients of brain hemorrhage? The answer is 140 by 90. For urgency, it is like use ACE inhibitors to bring down the blood pressure. There is no evidence of target organ damage. And then he will give you a hypertension patient who has become unconscious. He will say hypertension patient had LOC, loss of unconsciousness, and MRI of the brain was done. The MRI showed cerebral edema. You can see this white is the cerebral edema component in the occipital lobes of the brain, can spill over into the parietal lobes. So like the diagnosis can be asked or the treatment can be asked. So diagnosis is called as PRESS. PRESS would be called as posterior reversible encephalopathy syndrome. We calling it posterior because occipital lobe पीछे होता है. So this guy had blurring of vision. फिर उसको दिखाई देना बंद हो गया, and then he became unconscious. Hypertensive patient says, I woke up in the morning, I was having blurring, and then he became blind, maybe in one or both eyes, and then he became unconscious. Then we call it press posterior reversible encephalopathy syndrome. The good news about this condition is that if we diagnose this condition on time, then we can treat this patient and make him recover. What is the drug of choice for press? The answer would be given as, like, ultimately I need to get the blood pressure back to normal in this patient. We have to make the blood pressure come back to normal in this patient. So in posterior reversible encephalopathy syndrome, a CNS active drug would be recommended. That is once again nicardipine. We can use sodium nitroprusside also, but sodium nitroprusside causes a very fast fall in blood pressure. So in CNS cases, he recommends using nicardipine initially for both cases of hemorrhagic stroke as well as for posterior reversible encephalopathy syndrome. Remember that press is not stroke. It is a vasogenic cerebral edema that has occurred. There is no bursting of any blood vessel. If I say the word hemorrhagic stroke, that means that there is some bursting of blood vessels in the brain. Like in CNS part in hemorrhagic stroke, I've described the penetrating arteries, which are branches of the Charcot's artery. Charcot's artery is lenticulostriate artery. उसका जो छोटा छोटा branches होता है, penetrating branches, they will rupture. So that's like a totally different aspect, that there is a rupture of brain blood vessel. Whereas at the moment, I'm just talking about vasogenic cerebral edema in a patient. Next up is a term by the name of malignant hypertension. Now, what this means is that this hypertension patient, when he's come to me, his blood pressure is serially increasing. Like he came to me 3 months ago, BP was 150 by 100. So I had put him on antihypertensive drugs. But next month, the BP had increased to 170 by 120. So I increased the dose of oral medication. He's on now 3 classes of antihypertensive drugs like ACE inhibitor, calcium channel blocker, and diuretics also. The subsequent month he came, the BP in spite of these medicines was still rising. So he's going towards resistant hypertension. And I need to like plan treatment for this patient. And because of this increase in blood pressure, when he came to me after 3 to 4 months, I noticed that in this patient there is a fundus finding or target organ damage coming up, that is in the form of papilledema, or it's a possibility that while I was in still the phase of contemplating what should I do for this patient of resistant hypertension, he had become unconscious by that period of time. So malignant hypertension is like, I can say like this, like the cancer keeps on increasing very fast. The BP is increasing very fast and is causing any of the following: retinopathy, kidney injury, encephalopathy in a patient. Then for management, I need to obviously aggressively lower the blood pressure. The drug that I would be recommending even in this particular case is nicardipine. Harrison says that whenever it is a hypertensive emergency in contemporary medicine, the commonest medicine that is used is nicardipine. However, you will notice that in some of the older MCQs, nicardipine is not given. So I want to make a mention of sodium nitroprusside as well. It is a very, very good drug. The only issue with nitroprusside is one, it can cause a very fast fall in blood pressure. That fast fall can sometimes be very unpredictably fast and can worsen the brain perfusion. One. Second, like sodium nitroprusside has to be given through a light protected infusion set. Like the routine infusion set is going to be plastic, it's going to be white in color. But when you give nitroprusside, you will notice that it would be given through a light protected infusion set that would be like brownish or blackish in color. When we don't have it, we can use aluminum foil also. That foil that we use to keep our rotis fresh, the same aluminum foil can be put over the infusion set and then infusion can be given. And in spite of that, like if it's exposed to light, then there can be risk of cyanide toxicity. The antidote for cyanide toxicity is sodium thiosulfate and hydroxycobalamin. It is not to be answered as amyl nitrate, as like forensic people sometimes say. I mean, we have been saying it for a very long time now. Even Reddy, the textbook of forensic, they say the same thing, that the antidote for cyanide toxicity is sodium thiosulfate with hydroxycobalamin. So one, because of the practical issues with infusion. Second, the risk of cyanide toxicity, nicardipine is one of the commonest drugs that are used. And malignant hypertension would mean that there would be like a fundus finding of papilledema developing in a patient. Now comes a question on the topic of scleroderma crisis. When I say the word scleroderma crisis, that means like anti-topoisomerase antibody present positive patient is having damage to his kidney, so he's having a high renin hypertension. Guys, this is the only time in this table where, in spite of the fact that the word crisis is mentioned, we will not be giving IV drugs. That is why I've included it here. Because in scleroderma crisis, it's like a chronic long-standing disorder. I can't give IV drugs daily to the patient. So in spite of the fact that the MCQ will say the word crisis, you will answer as oral ACE inhibitors for management of this patient. So 2 times in this table, ACE inhibitors have come: hypertensive urgency and scleroderma crisis. But yeah, if there are neurological complications developing, nicardipine, if there are cardiovascular complications developing like acute pulmonary edema, then it is nitroglycerin drip that would be useful for management of these patients. Let's look at another situation where sodium nitroprusside is usually asked. The complication is again a known complication of hypertension, that is aortic dissection. In aortic dissection, there would be a tear that would be developing in the aorta. This tear is also referred in radiology as tennis ball appearance. You can see a intimal flap here. You can see a intimal flap at the moment. Okay, I'll use a different color. You can see a intimal flap, yes, very much visible, the intimal flap in the descending aorta. ये जो आगे है इसको बोलेंगे ascending aorta. This would be a descending aorta. And here the tear is present both in the ascending aorta as well as in the descending aorta of the patient. But if the tear is present exclusively in the ascending aorta, then we call it type A aortic dissection. If it is present exclusively in the descending aorta, it is a type B aortic dissection. There are two statements I want to say. One is a CT angiography report in this condition will be showing a tennis ball appearance. That is what they love to hear in the radiology section. Second is the two types of aortic dissection that can be type A and type B, about which I'll be writing subsequently also. Obviously that it can be an extension also of the ascending aorta into the descending aorta. We still call it type A, but sometimes you could be having exclusive ascending aorta, sometimes you could be having exclusive descending aorta, or it could be ascending aorta progressing into descending aorta involvement. What will be written in the question of aortic dissection that will make it like so obvious in front of you? He will say hypertension patient came to the hospital, and then he will say that person was complaining of chest pain. So out of habit asks the patient, okay, put your hand where the chest pain is. So expected patient will put his hand like this, but patients of aortic dissection will mostly describe the pain maximum concentrated in the interscapular area. So when you read this question, known case of hypertension, development of chest pain, so initially you will think that the guy is having a myocardial infarction. But then the question will also say this word chest pain localized in the interscapular area. Well, you can argue that in MI also the chest pain can be focused in the interscapular area. What is the big deal? But the next word would be an examination finding that would be given here, where he will say unequal radial pulses. The reason for that is the tear in the ascending aorta can go and involve the subclavian arteries also. So if you read about unequal radial pulses, right? I mean, normally the radial artery impulses on both sides would be equal, but unequal radial pulses, that implies that there is a complication of hypertension. So I need to go ahead with either a CT angiography, or I can do a bedside transesophageal echocardiography in this patient. Either the two can be done, CT angiography or transesophageal echocardiography. If both are given, then first answer is CT angiography, which would help you in a quick visualization. The radiological finding I've already explained to you, that would be tennis ball appearance. Sometimes they might give you a view on the lateral side, no, still you can see the tear present in the descending aorta of the patient. It could be starting from ascending aorta going down to descending as well. So the gist of the question would be chest pain in interscapular area with unequal radial pulses is feature of aortic dissection. Then he will say like what is the imaging modality or what is medical management. So in medical management, I need to put on brakes. I need to prevent the heart from beating faster. So I will first give beta blocker and then I will be giving sodium nitroprusside to this person. Now let me say by mistake a doctor will give or the nurse, you had written properly, but maybe your nurse misinterpreted your orders. No, maybe you have to establish a very good rapport with your team, right? When you write the orders, I mean, what is to be done first, what is to be done subsequently. It is just that, you know, you and me would be so busy, nurses will also be busy, that the communication part was lacking. So by mistake, sodium nitroprusside was started. Obviously, sodium nitroprusside will cause a drop in the blood pressure of the patient, understandably, but when the blood pressure will begin to decrease, there will also be a very substantial reflex tachycardia. That reflex tachycardia will make the heart beat faster and it will increase the tear. I'll say that again. Sodium nitroprusside, very good drug. BP will get controlled. But the reflex tachycardia that will happen will worsen the tear. It will progress. So I would not like to go ahead with this approach. The approach for management of this patient will be that first we put on the brakes. What I mean by putting up the brakes is we will first be giving beta blocker to this patient. The beta blocker that can be given is mostly a short acting beta blocker. In hypotensive states, one of the short acting beta blocker that can be used is by the name of esmolol, and then subsequently sodium nitroprusside can be used. For type A aortic dissection, After giving medical therapy, the patient will have to be taken in the OT. The main treatment is surgical repair. But type B aortic dissection sometimes can be managed without surgery also. I repeat my statement. For type A aortic dissection, it is a must that the patient must be taken up by a cardiothoracic vascular surgeon and a surgical repair should be done, otherwise the patient will die. But in type B aortic dissection, he can say that you can be medically managed. Obviously, like if it keeps on increasing and the blood pressure keeps on falling, we might have to go for surgical repair in type B also. But I wanted to bring to your attention that in type A, it is mandatory that surgical repair should be done. But if he says what will be done first in the patient, then I hope I am able to explain to you that patient immediately cannot be taken in the OT. We must start medically managing in the casualty. So if he says first intervention to be done for this patient, then answer is beta blocker. Esmolol can be given to these patients, and then subsequently sodium nitroprusside. He will deliberately like give these combinations, and sodium nitroprusside is given first, as I explained to you, can cause a reflex tachycardia. Then I will also speak about couple of drugs for cardiomyopathies, though cardiomyopathy slides would be coming subsequently. One of the main drugs that we use for management of hypertrophic cardiomyopathy is propranolol, because it helps in controlling the oxygen consumption of the heart. And then disopyramide, because we wanna reduce the left ventricular outflow tract obstruction, and it also reduces the chances of tachyarrhythmias. The MCQ of hypertrophic cardiomyopathy is very famous. I'll write it subsequently. A young guy playing football collapses on the pitch and dies suddenly. That's a standard feature of HOCM. I'll show you the slide. But at this moment, I wanted to talk about the treatment options available for these patients. That is in the form of alcohol-based septal ablation, because these patients have interventricular septal hypertrophy. That septum will consume more oxygen, and thereby it will cause ischemia in the heart that can trigger an arrhythmia. So because I know that these patients can die and they can be an arrhythmia like ventricular fibrillation or ventricular tachycardia, I would also suggest these patients to get a ICD deployed, that is implantable cardioverter defibrillator. If the MCQ simply says what is the treatment or choice for hypertrophic cardiomyopathy, and all these options are given. Propranolol is one, disopyramide is two, alcohol-based septal ablation, and implantable cardioverter defibrillator. Then the treatment of choice is implantable cardioverter defibrillator, because it substantially decreases the risk of sudden cardiac death. This is an autosomal dominant condition where the elder brother of this patient had also died suddenly. His elder brother was dancing at a marriage party. He had collapsed and he had died suddenly, and the younger brother has been diagnosed with hypertrophic cardiomyopathy. So the specimen of this is still will be discussed, including the clinical domain of that, how that sudden death would be occurring while he is playing football. But since I was talking about drugs, I had to introduce this concept of drugs used in hypertrophic cardiomyopathy, then is dilated cardiomyopathy. The specimen is pending, but for dilated cardiomyopathy, the manifestations will be that of heart failure. At this moment, I want to say two things. In dilated cardiomyopathy, the pulse that is present, which I've already explained to you, is what is called as dicrotic pulse. And the findings that would be given in this patient will be that of heart failure. So whenever you get a question on heart failure findings and the additional point given is dicrotic pulse, think in terms of DCM. One of the causes could be alcohol. So one treatment in this patient will be obviously heart failure treatment, that is like ACE inhibitors, beta blocker, MRA, SGLT2 inhibitors, and supportive drugs would be like diuretics, ivabradine. Ivabradine is a drug that acts on the funny current in the heart. Now that is called as IF. This funny current, if it is inhibited, then again you can control the heart rate. Like traditionally we were using beta blockers for controlling the heart rate, but even ivabradine controls the funny current, and by inhibiting this funny current and decreasing the heart rate of the patient, again oxygen consumption of the heart can be reduced. Question for you guys is, why I went into this here is, what is that medical device that is available for patients of heart failure who are not responding to conventional medicines? Obviously, one is cardiac transplantation. So I'm not talking about cardiac transplantation in this patient. That would be the best way for management of dilated cardiomyopathy. Can you tell me an electronic device which can be used in patients of refractory heart failure pending a cardiac transplantation? The guy is put up on a waiting list. We need a beating heart donor for that. So obviously, we never know when it will come. So to keep the person alive in a refractory heart failure, what is the treatment that we can do? That is called as CRT. CRT stands for cardiac resynchronization therapy. The point to be understood is that left and right ventricles in dilated cardiomyopathy do not beat at the same time. In you and me, the left and the right ventricles beat at in you and me they beat at the same time, so there is no pulmonary edema. Imagine your left ventricle is beating a little later than the right ventricle, so there's pooling of blood in the lungs. Normally, both ventricles contract with equal power at the same time. The firing is precise. If that firing is missed, there's a pulmonary edema. So we need to put in a device which will ensure that both ventricles work at the same time. That is synchronous contraction of the left and the right ventricle. So we call it CRT, that is cardiac resynchronization therapy. You will notice that in this entire discussion that I've had, there was no mention of digoxin, though digoxin is the first drug that is taught by pharmacology people. So let's revise about digoxin also. One of the mechanisms is it inhibits sodium potassium pump, increases intracellular calcium, so it increases the force of contraction, which is what is called as positive inotropic action. So the word is that digoxin, when it is administered, it increases the force of contraction, it causes a positive inotropic action. The second aspect is that digoxin activates the vagus. By activating the vagus, it will decrease the heart rate. The good news is that will decrease the oxygen consumption of the heart, and this is called as negative chronotropic effect. So just making you revise your pharma, that how does digoxin work? It causes positive inotropic and negative inotropic action. एग्जाम में परमोटेशन कॉम्बिनेशन बना दी ना उसने, तो आपको याद करना है पॉजिटिव आइनो मीन्स फोर्स ऑफ कॉन्ट्रैक्शन, क्रोनो इज हार्ट रेट, सो डिक्रीजिंग द हार्ट रेट एंड डिक्रीजिंग द फ्यूल कंजम्पशन. Coming to the half-life of digoxin, this would be about 48 hours. It's a range actually, 36 to 48 hours. So importance of knowing this is that once a day dosaging of digoxin can be done, though you need at least 7 to 10 days of daily dosaging to achieve a steady state concentration. As long as the drug levels will remain in this therapeutic range, you will get benefit. That is first order kinetics. You increase the drug level in the blood and therapeutic benefit will be obtained. But once the drug levels will go beyond this range, then zero order kinetics would come. That is, you will not get therapeutic benefit, rather you will be getting side effects, and those side effects are the key reason why we are talking about digoxin at this moment before I describe the topic of cardiomyopathy. The bioavailability is about 75%. The drug is excreted by the kidney, and therefore if the kidney will fail, the drug levels would be elevated. And the second is an important risk factor for digoxin toxicity, that is hypokalemia, because most of the time when you are giving digoxin to the patient, person is also having pedal edema, so we will be giving diuretics. And diuretics, if we give, whether it is furosemide, thiazide, they cause hypokalemia. So with respect to electrolytes, two electrolytes becoming lesser are triggers for digoxin toxicity: hypokalemia, hypomagnesemia. But for calcium, don't answer hypocalcemia. For calcium, answer hypercalcemia. Let's do this again. Toxicity can be triggered by, your answer would be variation with respect to thyroid hormone levels, that is one, hypo and hyper both. Second is for electrolytes, hypokalemia, hypomagnesemia are triggers, but for calcium it is hypercalcemia. Digoxin increases oxygen consumption of the heart. If you increase the force of contraction, you need more power, and for more power you need more oxygen. So you could be having ST segment depression and a T wave inversion. Both of them are findings of myocardial ischemia, and because of the vagus activity, remember I said it activates the vagus, that is why PR interval will be prolonged. याद है मैंने बोला था PR and heart rate have an inverse relation. So when the heart rate of the patient, when you slow down the heart, then the PR interval will get prolonged, and the myocardial ischemia component can explain the ST segment depression and a T wave inversion. This also explains why digoxin should not be given to patients of chronic stable angina, because if somebody is having chronic stable angina, he is already having ST segment depression, it will worsen, and it will worsen the myocardial oxygen consumption of the patient. A miscellaneous point to be remembered here: resistant hypertension is defined as uncontrolled blood pressure or uncontrolled hypertension. In fact, I should say uncontrolled hypertension despite more than 3 classes of antihypertensive drugs being used in a patient, and must include, he says before, without giving a trial of thiazide diuretics, must include thiazides being administered. Include, 3 classes can be ACE inhibitor, calcium channel blocker, and thiazides. If in spite of giving like these 3 classes of drugs, BP is not getting controlled, then I will say person is having resistant hypertension. But the number one cause for this is usually non-compliance. Either it is faulty readings. If he says what is the most common cause of it, then number one cause is not like rare things like renal artery stenosis. The number one cause for resistant hypertension is either the cuff size is not adequate. If the cuff size is not adequate, you are using a smaller size cuff, you are overestimating the blood pressure. Second could be non-compliance in a patient. So number one cause for this is faulty reading. After faulty reading, the second thing would be like it could be non-compliance on the part of the patient. And the definition is 3 classes of antihypertensive drugs with must include thiazides as well. Thiazides, they affect the lipid profile, agreed, but we have to give a course of thiazides before we say a person is having resistant hypertension. The cutoff for hypertension, you anyway know, hypertension cutoff is not 140/90 now. The revised guidelines say it is blood pressure more than 130/80. Obviously, single reading will not be sufficient. You need multiple readings at different points of time before you say that the person is having hypertension. Now we will focus on digoxin toxicity, which is the core aspect that I wanted to say. In digoxin toxicity, we will divide the discussion into extracardiac and cardiac side effects. Extracardiac side effect that is most common happens to be nausea and vomiting. But if he says the word most characteristic, it is xanthopsia. Xanthopsia basically means yellow vision in a patient. You don't read this word anywhere else. For the cardiac one, they love to ask about it. Ventricular bigeminy is the commonest arrhythmia that is seen with digoxin toxicity. But if he changes it into most characteristic, then you will not read this word in entire cardiology. Non-paroxysmal atrial tachycardia with a AV block. The word is NPAT, non-paroxysmal atrial tachycardia with an AV block. Then he's asked, what is the drug of choice for ventricular bigeminy? You will answer lignocaine. This is first time that I've talked about lignocaine. I did speak about it as a backup drug in management of PVT and ventricular fibrillation in ACLS, but now this time it's like coming straight on. Antidote for digoxin toxicity is obviously digiband. These are special like antibodies, FAB antibodies that bind to digoxin, because digoxin toxicity cannot be treated by like hemodialysis because the drug is not in the blood, the drug is in the tissues. So you need specialized antibodies to bind to the drug which is bound to the tissues. Then this was a NEET PG question. He gave a question on digoxin toxicity. Person was having a bradycardia and he said कि क्या करोगे, तो फिर वहां पे आंसर लिग्नोकेन नहीं है. वहां पे I mean it's not, he's not talking about tachyarrhythmia. Ventricular bigeminy will cause a tachy. He's talking about bradycardia. So for bradycardia, I will be giving atropine in the patient. So it was a very smartly designed question. He said patient had consumed 10 tablets of digoxin together. Heart rate has gone down to 40. BP of the patient is decreasing. What is the main antidote? Lignocaine was also given. Digiband was also given. Atropine was also given. If the heart rate is less, symptomatic bradycardia. And he said patient is becoming drowsy, lethargic. I've explained symptomatic bradycardia could be chest pain. It could be altered mentation. So he had written patient has become drowsy, lethargic, blood pressure is decreasing. What is the first line drug you will give to the patient? The first line drug would be atropine administration to the patient. As far as nitrates are concerned, I want to say that nitrates could always be having is a development of tolerance. So to prevent the development of tolerance, we should always be giving eccentric dosaging of nitrates. Eccentric dosaging would mean like one tablet to be taken at 8 am in the morning and the second dose to be taken at, let me say, 5 p.m. in the evening. And the patient is asking you, sir, like normally we give medicine 8 am, 8 p.m. or you give once a day, this time 5 p.m. Chai ke sath lena kya? With this question is FMG exam question, guys. Listen to this carefully. Eccentric dosages of nitrates are to be done to prevent the development of tolerance. Agar digoxin will be present in the blood 24 out of 24 hours per day, there would be a tolerance or tachyphylaxis that would be developing. If we will take first dose at 8 am, it will work till 3 o'clock, 4 o'clock in the evening. Second dose at 5 p.m, so it will work till 12 o'clock in the night. But from 12 o'clock in the night to 8 am in the morning, next 12 o'clock to 8 am in the morning, then for those 8 hours, there is no nitrates in the blood. We want to prevent tolerance to nitrates. Otherwise, nitrates will not be working. Nitrates are used in management of chronic stable angina, acute coronary syndrome, acute pulmonary edema, as I've explained to you. And how they work is by increasing the level of cyclic JMP, and they help in improving the perfusion of the areas with angina. All nitrates undergo first pass metabolism except, the answer is isosorbide mononitrate. That is a long acting nitrate, but the longest acting nitrate is pentaerythritol nitrate. Shortest acting is GTN, that is nitroglycerin. I mean, if he says like what is the drug of choice for somebody who's having angina episode right now, like this guy was walking fast, he's having chest pain, then we will give GTN sublingually. The moment you will give it sublingually, wo bola ki patient is a shopkeeper. He says my house is nearby. He was walking fast to the house because maybe it was his daughter's birthday. So he had carried some cake, some gift, and he was excited because it's daughter's birthday today, 18th birthday. And this man, he started having chest pain. So your clinic is nearby. They brought the old man. So you're given sublingual nitroglycerin. He said, what is the first side effect that would be coming? Your answer would be flushing and throbbing headache would start occurring in this patient, and there would be a reflex tachycardia. Whenever you give nitrate, देखो a patient सर दर्द बताता है, throbbing headache and reflex tachycardia, comfort the patient. This will pass away. This is means medicine is working. It's dilating your coronary arteries. Nitrates are not contraindicated, are not given in. That is inferior MI, because one of the side effects of this medicine is hypotension. and inferior MI already has a hypotension. So because BP is already low, never give nitrates to anybody whose blood pressure is less than 90/60. I will teach you inferior MI subsequently, then I'll teach you the reasons for why you get a hypotension there, but the message is never give nitrates in inferior MI and blood pressure being 90/60. If somebody is on sildenafil, sildenafil is that used for erectile dysfunction now, that acts by increasing the levels of nitrates so that blood supply to penis is more. So nitrates level will increase, it will cause hypotension, and they're contraindicated in hypertrophic cardiomyopathy. Listen to me carefully, guys. What are the drugs that are used in hypertrophic cardiomyopathy? Disopyramide, propranolol. We used alcohol-based septal ablation, ICD, and the question will say which of the following is not used in hypertrophic cardiomyopathy. It is nitrates in these patients, because in hypertrophic cardiomyopathy already less blood is coming in the left ventricle due to septal hypertrophy. If I will give nitrates, it will decrease the blood supply to the left side. It will worsen the angina episodes in this patient. When I describe hypertrophic cardiomyopathy, I will touch this point again, but there I'll be focused on medical examination findings. So at the moment, I'm touching those pharma domains which are like taught in pharma but are being covered at the moment also. So I can say at the moment confidently that even if you have not read drugs acting on cardiovascular system at all, आप कहते हो सर मैंने पढ़ा ही नहीं है, आप जो मैं बता रहा हूँ, if you get these points right, you are sorted in both your pharma as well as the medicine aspects. One of the important questions that I just mentioned is what are the contraindications? I'll rate this as one of the most important, like data for nitrates on this slide. I was earlier saying nitrates are life-saving in acute pulmonary edema. They can be used in emergency for somebody having chest pain while he is walking very fast, that is chronic stable angina, but don't give it if the BP is less than 90/60, person on medicines, that is Viagra and hypertrophic cardiomyopathy. Now coming to ACE inhibitors, the mechanism of action is simple. They block the conversion of angiotensin 1 into angiotensin 2. All ACE inhibitors are prodrug except captopril and lisinopril, but they're absolutely contraindicated. Contraindication वाला point हमेशा याद करना है. ACE inhibitors are not given in bilateral renal artery stenosis in pregnancy. इन FMJ एग्जाम में पूछा प्रेगनेंसी में क्यों नहीं देते हैं. एग्री टेराटोजेनिक होते हैं, उसने बोला टेराटोजेनिसिटी क्या होगी फीटस में, फीटस को क्या हो जाएगा. सो योर आंसर वुड बी रीनल एजेनेसिस. They are the first line drugs for management of hypertension less than 55 years of age. They are the first line drugs in diabetic nephropathy because they slow down the decrease in the GFR. Scleroderma crisis में भी मैंने बात करी थी. They're used in MI and heart failure also. The side effects are obviously like dry cough, angioedema. वो ये सब नहीं पूछेगा, वो आपसे क्या सुनना चाहता है. तो these are the side effects that the examiner wants to hear. Change in taste, azotemia in volume depleted states, and hyperkalemia are the neglected side effects of ACE inhibitors. The must-know facts for ACE inhibitors are renal agenesis, the teratogenicity part, and the side effects like dysgeusia, azotemia in a volume-depleted state, and hyperkalemia. So next up is the much-awaited section of cardiomyopathies. First and foremost, if you check out the heart, there is a asymmetrical septal hypertrophy, because of which there's a disparity in the size of the ventricles also. Just check out the size of the right ventricle and then compare this with the size of the left ventricle. There are two interesting observations. One, though the name of the condition that I'm describing is hypertrophic cardiomyopathy, the size of the left ventricle is actually smaller than the left ventricle of a normal person. This also looks like a section of a banana, right? So banana shaped cavity of the heart is what you will read in the subsequent part of the discussion. And what I also want to bring to your attention is that the heart wall is a little mota, so it's going to contribute to increase in oxygen consumption of the heart. So from the pathology component, I want you to understand that this condition would be having a subendocardial ischemia because the oxygen consumption of the heart will be more. This explains why when this patient is running after a football fast, they would be worsening of the subendocardial ischemia, and therefore these patients can develop a myocardial infarction or they can develop a possible arrhythmia as well. More about this disorder from the clinical domain subsequently, but at the moment in hypertrophic cardiomyopathy, the size of the ventricle wall is mota. There is a asymmetrical septal hypertrophy, and then pathology, they describe this helter-skelter appearance of the myocytes, which is also called as myocardial disarray. In fact, in Harrison, the word used is not helter-skelter. That's a Robbins terminology. When it comes to Harrison, he has used the word myocardial disarray. That is, you can see that the myocytes are arranged in a very random fashion, whereas normally myocardium would be functioning in the form of a syncytium. Now, in the next specimen, I want to draw your attention to the fact that here the size of the ventricles, the left and the right looks pretty equal. But if you check out the size of the atria literally jumbo atria. The size of the atria is much bigger as compared to the size of the ventricles. The reason for that is that in this condition there is fibrosis. Now this fibrosis is not visible at the moment. Obviously we will need a histopathological like slide for it, but then just like you're comfortable with the fact that we have fibrosis in the liver and that's called as cirrhosis, I am teaching you a condition in which we have fibrosis in the muscle wall, because of which the atria will have to work against a resistance. When atria work against a resistance, the size of the atria in this condition will be bigger than the ventricular cavity. Normally, ventricular cavity is bigger than the atria. These are obviously thinned out atria. They are having to work against a resistance, but volume-wise, the size is relatively bigger. So this time I'm talking about the rarest type of cardiomyopathy that's called as restrictive cardiomyopathy. One of the leading cause of the rarest type of cardiomyopathy is amyloidosis. So these areas where I'm putting the star mark is where the pink highline deposits of amyloid is present. And plus, if you check out the myocytes, some of them are like totally damaged or destroyed, or like are relatively narrower in caliber, and some are relatively bigger. So there's a gross asymmetry as far as the size of the myocytes is also present. Now comparison wise, if you look at the third cardiomyopathy, he is himself in the exam given a normal size heart, and then you can notice that the heart is relatively big and dilated. In fact, what I want to say for this cardiomyopathy is, one, there is a thinned out myocardium. The overall thickness of the myocardium is relatively lesser. Now, how will the examiner mostly like write the word thinned out myocardium will be a echocardiography finding. That echocardiography finding I'll write subsequently. I'm just saying it verbally at the moment. That would be global hypokinesia. That means all global means all the four chambers of the heart is not working optimally. The cardiac output is lesser. So in dilated cardiomyopathy that I'm describing to you at the moment, the myocytes in this condition look relatively more thicker and hypertrophied. So the peculiarity is the condition is dilated, but we have hypertrophied myocytes. When you read this term casually, error on a part of student can be that we may answer hypertrophied myocytes as a feature of hypertrophic cardiomyopathy, but that is not the case. I can say that in this condition, some myocytes are damaged, and therefore the remaining ones will hypertrophy to take over the function of the damaged one. The main thing is there is a thinned out myocardium in this condition. This is written in books as global hypokinesia, and this is a feature of dilated cardiomyopathy. In fact, one of the important toxins that can cause development of this has also been asked, that is alcohol induced dilated cardiomyopathy, though it can be due to genetic reasons also, and you can read about the titin star kind of stuff from pathology. But I wanted to bring to your attention that all the chambers of the heart in this condition will be bigger than a normal size heart. In the previous one, it was atria bigger as compared to the ventricles. So I'll just write A more than V. And when it comes to hypertrophic cardiomyopathy, the most important thing would be the size of the left ventricle is smaller than the size of the ventricle of even a normal person. So the important thing is that it is an example of diastolic malfunction. You see, the problem is not with the banana shape. The problem is that this ventricle is receiving less ventricle as compared to normal. So therefore, the cardiac output of these patients would also be lesser. And then obviously I said myocardial disarray, so pretty straightforward. Now, because this has become very common in the exam, what he started asking in NEET PG and INISET is that they will give you an image in which you can obviously identify the myocytes. But between that, you will be able to identify fat. You know from your pathology classes that fat is washed out. So it looks like fat globules. There is some fibrosis, fibrotic material also present. So that MCQ will give you this slide. You will say this is a fibropathy replacement of the myocytes. This is not present globally. It is usually found in the right ventricle. So therefore, the diagnosis or the condition that I'm talking about is called as arrhythmogenic right ventricular dysplasia. ARVD, in which epsilon wave in the ECG was discussed earlier. In fact, in all of these conditions, because there is a risk of arrhythmias and they can be a sudden death, therefore to prevent the development of sudden death, implantable cardioverter defibrillator would be used. In fact, what are the indications for implantable cardioverter defibrillator? So let me just make them practice. You practice before me. One is ARVD, arrhythmogenic right ventricular dysplasia. Name itself is like this, na, arrhythmogenic. So I will use an implantable cardioverter defibrillator. Then was a sodium channel defect that I described to you, which was having that SCN5A defect, that is Brugada. And then all the cardiomyopathies that I described before you superiorly, whether it is dilated, hypertrophic, restrictive, in all of them, because there is a tendency for development of like arrhythmias, tachyarrhythmias to be precise. So implantable cardioverter defibrillator would be used. ICD is a device that basically used to prevent death due to recurrent tachyarrhythmias, because we can't wait for the patient to develop like VT, VFib and like come to the hospital. He may not reach the hospital in time in most of the cases, and patient can die at home. Now, as far as hypertrophic cardiomyopathy in comparison with dilated is concerned, hypertrophic is autosomal dominant. There are multiple chromosomes involved. One of them is chromosome 14. The gene involved is MYH7 gene. And as I explained to you, there is a banana-shaped cavity of the heart. The most important thing is that in this condition, not only will you be having a septal hypertrophy, where I put the star mark, this is septal hypertrophy, but you also have is a increased thickness of the free wall of the left ventricle. This will act like a speed breaker and will interrupt the exit of blood from the heart. You see, when your car goes over a speed breaker, now, howsoever fast you're driving a car, when your car goes over a speed breaker, it's going to cause a decrease in the velocity. Similarly, here I can say that when the blood will try to go out, this will act like a speed breaker. It will limit the blood going out of the heart. So therefore, the technical word that they use for this is called as dynamic left ventricular outflow tract obstruction, or the simple English word would be subvalvular, because problem is below the aortic valve. You can see here I've shown the leaflets of the aortic valve. So problem of that speed breaker is below the aortic valve, and therefore the word is subvalvular aortic stenosis. The technical word that may be written in some questions is LVOTO. LVOTO stands for left ventricular outflow tract obstruction. So irrespective of the terminology, whether you read the word left ventricular outflow tract obstruction, or if you read the word subvalvular aortic stenosis, both mean the same. Then there's a special echocardiography finding of this condition. Apart from increase in the thickness, we are also able to get a SAM. Now, SAM is not a surface to air missile. With all this, wars going on, I think you are aware of military jargon, SAM. I mean, surface to air missile, but this is systolic anterior movement of the mitral valve. So instead of writing the word anterior, like I would like to just modify the data here. It is SAM. That is, it is actually the anterior leaflet of the mitral valve that is moving. But to keep it simple, I'm saying the word SAM, that is systolic anterior movement of the mitral valve. And as you can see, the size of the cavity of the left ventricle, guys, is even smaller than the cavity size of a normal person. So the end diastolic volume in this banana-shaped cavity of the heart will be lesser than 130. Less blood will come in, less will be going out, and that is why this is predominantly a diastolic malfunction. Now, the pulse that is found in this condition has been asked in FMG exam. This pulse will be having two peaks, one bigger as compared to the smaller, and this would be referred to as pulsus bispherians, as already explained to you. But when it comes to a pulse of dilated cardiomyopathy, where we get a global hypokinesia, we get a thinned out myocardium, the pulse will be again having two peaks. But here I would like to just draw with a different color. One peak will be in systole and the second peak will be in diastole. Normally, like this time okay, let me just put markers there as well. This is two peaks in the phase of systole, that is period between S1 as well as S2. That is the representation. There is no peak in the phase of diastole. Obviously, like if I improvise on this diagram that I made before you, I should have actually mentioned the dichrotic notch as well, but I want to draw your attention at the moment to the fact that obviously dichrotic notch will be present. So actual tracing that will be coming will be something like this. One is the big peak, the percussion wave, the tidal wave, and then there is a dichrotic notch that is happening. But I want mainly to focus on the two sides of the peaks. Now for this diagram, what I will do is, once again in dotted green, I'm showing S1 and S2. And you can see that one of the peak of the pulse is coming with respect to the phase of systole, and the second peak is coming with respect to the diastole. So that is why this is called as a dichrotic pulse. Let's put on the theory as well, because they put up graphs related to it. This I thought I should first mention the graphs once again if I'm getting an opportunity. Most guys are able to solve the question by this point of time because the pulse is given, but sometimes murmur will be handy. In hypertrophic cardiomyopathy, the murmur will be same as that of valvular aortic stenosis. Remember I told you that mnemonic pass, pulmonic and aortic stenosis causes a systolic murmur. So the same thing to be used here, that is ESM, which is called as ejection systolic murmur. And the speciality of this murmur is that it increases with Valsalva. It increases with standing. Traditionally, all murmurs will be decreasing because the rationale is that when we stand or whenever we do any activity like amal nitrate inhalation, it decreases the venous return to the heart. If less blood will be coming in the heart, less blood will be going out also. So all murmurs tend to decrease or reduce in intensity with Valsalva standing amyl nitrate, but not the murmur of hypertrophic cardiomyopathy, which will increase with Valsalva and standing. In contrast, in dilated cardiomyopathy, we can get a functional mitral regurgitation or a tricuspid regurgitation. I'm calling it functional because in this condition, there is lack of approximation. Like this is a dilated heart, and then what I'm showing is that the leaflets of the mitral and the tricuspid valve will not be able to approximate each other. Let me zoom in. This is what I'm saying. Because of the dilatation, Because of the dilatation of the heart, what is happening is that the valve leaflets are not able to approximate each other properly. Normally, the tricuspid valve and the mitral valve leaflets are able to like approximate each other properly. In this condition, what is happening is that because of the dilation, you can imagine mitral valve annulus, tricuspid valve annulus dilate हो गया. तो डायलेशन की वजह से क्या होगा कि यहाँ पे blood can be leaking across these valve leaflets. The blood will be leaking like this from the right ventricle to the right atria, causing a tricuspid regurgitation. The blood will be leaking like this from the left ventricle to the left atria, and both of them would result in a pansystolic murmur. So the question will waste your time by mentioning the word pansystolic murmur here. Now, as far as hypertrophic cardiomyopathy is concerned, what are the approaches we can be using? So one is obviously the approach of ICD, that is implantable cardioverter defibrillator, because the risk of sudden death in these patients is substantially high. Like this guy will say, my elder brother had died suddenly, even this guy has had a syncopal episode, so implantable cardioverter defibrillator. Another approach we can use for these patients is we can inject alcohol into that interventricular septum. This is the first and the last time that I'm saying alcohol can be therapeutically beneficial, because every time I've criticized alcohol only. So alcohol based septal ablation can be done in these patients, and the advantage would be that you would at least reduce the subendocardial ischemia. But if the patient is not ready for any one of these interventions, then the least we can do is give a non-selective beta blocker, propranolol and disopyramide, for management of these patients as discussed originally. In contrast, when it comes to dilated cardiomyopathy, there can also be development of clots, and these clots in the left atria can go in the brain, so it can cause a cerebral embolism. The clots in the right atria can go in the lungs of the patient, so it can cause a pulmonary embolism. So here, apart from cardiac resynchronization therapy, what cardiac resynchronization therapy does is that it makes both the ventricles contract together. I've spoken about it earlier. It is a cause of it was discussed in the topic of refractory heart failure. And who are those patients who have refractory heart failure? Dilated cardiomyopathy. One of the reasons can be ischemia also, and because the ventricles are like hypokinetic, that's where stasis of blood will happen. Even in this condition, arrhythmias can occur, so ICD will be used in this patient, and then warfarin, as I explained, because there is a risk of cerebral embolism in this patient. Then all murmurs decrease with Valsartan, standing amyl nitrate, I've already explained. Nitrates are not given in hypertrophic cardiomyopathy, so it's digoxin. The routine drugs, just remember my statement that all drugs that are used in heart failure management are not given in hypertrophic cardiomyopathy. The logic is that in these patients, nitrates are decreasing the preload now, so they will cause less blood to come to heart. If less blood will come in the heart to the right, it less will go to left. And if less blood will go to left, the BP of the patient will begin to drop. So the point I want to bring to your attention is, इसमें तो पहले से ही less blood आता ना left ventricle में. If you look at the heart of this patient, मैं इसको nitrates दे दिया, less blood will come to right, less blood will go to left. पहले से ही less आता है. So it will cause further decrease in the output from the heart of this patient, and thereby can kill the patient, क्योंकि coronary blood flow भी decrease हो जाएगा. So therefore nitrates are not given, digoxin is not given for this patient. Standard question: sudden death in a young guy playing football. The cause is hypertrophic cardiomyopathy. And if he wants to go a little deeper, then you will say that there is a worsening of the subendocardial ischemia, क्योंकि heart में ज़्यादा muscle है ना, मोटा heart है, it's consuming more oxygen, so it will cause worsening of the subendocardial ischemia, and therefore there can be a development of ischemic ventricular fibrillation, or they can be a ventricular tachycardia developing in these patients. I mean, why these patients can die is because there is, like, he is running after the ball fast. Already there is ischemia in the heart. So the worsening of this endocardial ischemia can cause ischemic ventricular fibrillation and ventricular tachycardia. And to prevent sudden death in a sibling who's symptomatic and has hypertrophic cardiomyopathy because of autosomal dominant nature, the single most important intervention that can reduce the chances of death in this patient is implantable cardioverter defibrillator. Now I will mention regarding the rarest type of cardiomyopathy, the most common cause of the rarest type of cardiomyopathy. That's the language of the question. What is overall the most common cause of the rarest type of cardiomyopathy? It is restrictive cardiomyopathy. In this condition, sometimes the pulse can be normal, but in some cases, there can even be a presence of pulsus paradoxus. Now, this is the first time I've introduced the word pulsus paradoxus for restrictive cardiomyopathy. This is a rare finding that he says. So, pulsus paradoxus traditionally is defined for cardiac tamponade, but can be seen in constrictive pericarditis and can be seen in restrictive cardiomyopathy also. So, what are the additional things you should look for? The additional findings in this patient is, I hope you remember that mnemonic COPS restrict right heart. In COPS restricting right heart, COPS was constrictive pericarditis, R was restrictive cardiomyopathy. So there would be a small sign present here, which is a paradoxical rise of the GVP. On this, the query of a lot of students is, sir, these findings are same as that of constrictive pericarditis. So how will we differentiate? Exactly, we have a challenge. So the challenge can be that either we can do a cardiac MRI. If cardiac MRI will show a calcification outside the heart, it is constrictive pericarditis. If it's going to be fibrosis in the cardiac muscle, then it's going to be restrictive cardiomyopathy. Or we can go in for endomyocardial biopsy, which is a gold standard investigation. You see, patients will usually not agree for a biopsy of the heart. I mean, you can understand taking a piece from the heart is not a joke. But yeah, endomyocardial biopsy is a gold standard investigation for these patients. And cardiac MRI, well, a very good investigation that helps you identify whether it is fibrosis in the muscle or is it calcification outside the heart. Let me just give a crude representation for this one. Let's imagine this to be the cardiac muscle. Let's imagine this to be cardiac muscle once again. Give me like another 10 seconds and we are sorted for the topic. Suppose I say to you, the doctor patient is having calcification outside the heart. This thick zone that I've shown is calcification outside the heart. It is constrictive pericarditis. But suppose I say to you that there is fibrosis in the myocardium, then this fibrosis in the myocardium is restrictive cardiomyopathy. So what I've tried to just do here is give a line diagrammatic representation of fibrosis in the muscle, stiff heart, versus constrictive pericarditis, which is stiffer heart, but because of the calcification component that is present, the cardiac catheterization finding in this condition will be same as that of constrictive pericarditis, that is square root wave sign. So the main message is that restrictive cardiomyopathy and constrictive pericarditis can mimic each other from the findings perspective, but causes are different. In constrictive pericarditis, it was tuberculosis. So question will always mention regarding the person having like history of tuberculosis. Here there would be no history of TB. It would be amyloidosis, maybe radiation to the chest. I'll explain how radiation to the chest. This lady had breast cancer. So she was subjected to modified radical mastectomy, and after that radiation to the chest was also given because she had a recurrence of breast cancer. So lots of time he will mention a lady had breast cancer recurrence and radiation was given. Due to radiation, the breast cancer that had recurred will die. But the radiation will cause fibrosis in the cardiac muscle, and that's why future may she will start developing swelling in the feet, she will start developing pulmonary edema in a patient. जब भी patient में right ventricle failure होता है, so there is always pooling of the blood in the extremities, and pooling of the blood in the extremities causes pedal edema. And in left ventricle failure, left ventricle is connected to lungs. So there would be pooling of blood in the lungs, that is pulmonary edema. Repeating once again, if a person is having right ventricle failure, ऐसे याद कर लो ना, right ventricle will always be having the involvement of the right ventricle will always be having his involvement of the rest of the body, because all the venous return of the body comes via the liver to the right side of the heart. So if there is failure of the right side, then liver will become congested, jugular vein will become congested, and even pedal edema will be there. And left ventricle is ultimately connected to lungs now. So if the left ventricle will fail, there would be pooling of blood in the lungs that will cause pulmonary edema in a patient. So restrictive cardiomyopathy will have features all of them. Then he will say pulsus paradoxus to small sign. But suppose if they give you a question in which these findings are given, and the question says patient is having dichrotic pulse, then you will say that it is dilated cardiomyopathy. I said if they give you a question of pedal edema, pulmonary edema, shortness of breath, and the question says patient is having dichrotic pulse with functional MR and TR, then you will say dilated cardiomyopathy. Also to assist you, you will say echo shows global hypokinesia, then you will say dilated. But suppose they give you a question in which he is giving the following information. Pulse can be normal also. Majority of cases में normal होती है. This is a rare finding, guys. I mean, don't be surprised कि sir pulsus paradoxus इसको मैं पहले नहीं बोला, because this is a very rare finding that may be given in questions. The main point is if they give you pedal edema, pulmonary edema, shortness of breath with dichrotic pulse, DCM, if it is given with the following findings, think in terms of restrictive cardiomyopathy, and the retrospective history also needs to be considered. For restrictive cardiomyopathy, there is only one solution: cardiac transplantation. We don't do a cardiac transplantation in hypertrophic cardiomyopathy, but cardiac transplantation is the best way to treat patients of both dilated and restrictive cardiomyopathy. Cardiac transplantation is not required for hypertrophic variety of cardiomyopathy. Cardiac transplantation is done for dilated and restrictive and is not required for hypertrophic, because वहाँ तो muscle है ना, so it is rather ICD and alcohol-based septal ablation and like propranolol disopyramide are the kind of approaches that I can be using for these patients. Next, I'll teach you an acute onset cardiomyopathy. Normally, cardiomyopathy is always a chronic presentation, but this time it's an acute onset presentation. We call it Takotsubo. In Takotsubo, there is a bulging. You can see the bulging of the wall of the left ventricle, which is like a jar that is used to trap the octopus. Octopus will go inside, will not be able to come outside. The presentation will be like MI. So most of the time, the patient will be in Takotsubo cardiomyopathy exposed to some kind of life-threatening illness. Life-threatening illness can be like the earthquake is happening. Imagine right now, there's an earthquake happening in a multi-story in a city, and the person is in a high-rise building at the 30th floor, right? And then the person rushes to the lift. Whenever an earthquake is coming at that point of time, you are not supposed to take the lift. You are supposed to take the stairs. This patient make the grave mistake that earthquake ho raha hai, and the person ran into an elevator and suddenly the electricity went away. Whole elevator is checking vigorously on the 30th floor. Elevator can fall any point of time and the patient will be exposed to a life-threatening illness. So earthquake may stuck in an elevator is like one situation that I can say where person will be exposed to life-threatening illness, and that will cause massive catecholamine release. Catecholamines जो इतने large amount में यहाँ पे release होते हैं, they are gonna cause damage to the heart, and it can cause the left ventricle wall not to function optimally, and therefore the cardiac output will decrease. There is a catecholamine surge. Let me describe it once again. This is a couple. Both of them are like 70 years of age. They are like childhood sweethearts. They got married at 20 years of age in college only. 50 years they spent together. Today, wife died, and in afternoon, husband also died. You know, close, somebody very close. They've been together for 50 years, and now suddenly like wife died and then the husband also died. So like death of a loved one, like death of a loved one does not mean like death of somebody who's like a distant relative. Obviously distant relatives can be loved ones also, but when we talk about close family members, no, close family members, real love I'm talking about, you will see come across so many instances. Like recently there was an episode in Delhi only. The husband had died and the wife went and did cremation of her husband at this Nigambod Ghat, and when she came back, she also died. And her son was shocked, like, mama also died, daddy also died on the same day. So death of a loved one, earthquake, stuck in elevator. I mean, those are the kind of situations that they're given in the paper. And then there's a catecholamine surge. So patient will initially present with chest pain. And when somebody will come to you with chest pain, you will get an ECG done, and the ECG will show an ST elevation also. It will show elevated troponin I also. So you will think that, oh, this is a case of ST elevation MI, and you will take the patient in the cath lab for a percutaneous coronary intervention. When we will do coronary angiography in the patient, you see any patient who's going to be subjected to a percutaneous coronary intervention, we will first do angiography to see which blood vessel is blocked. Like in most cases it is anterior MI, so we are thinking that probably there's a thrombus in the left anterior descending artery. But the coronary angiography when was done, surprisingly the report was perfectly normal. On the monitor there is no obstruction of the artery, there's no spasm of the artery, there's no obstruction in the form of any non-flow of the contrast, because this is not an MI. It is a condition that mimics the presentation of myocardial infarction. So first he will give you these triggers in a question. The triggers in Takotsubo cardiomyopathy can be any of the two. I'll say them once again. Either he will say patient is stuck in an earthquake, Richter scale 7.0, whole building is shaking, the guy went into elevator doors closed, and then light went off. The elevator is shaking, earthquake continued for 1 minute, life-threatening illness. Second is death of a loved ones, that is I've currently explained. And then when we took the patient in the cath lab, it looked like a ST elevation MI. Everybody was convinced this is just MI, we'll do a ballon angioplasty, patient will recover. And surprisingly, angiography is normal. So he said, what will you do in this case? Then we will not give like dopamine, dobutamine in this condition. Though there is like cardiogenic shock happening, we will be using a intra-aortic balloon pump in these patients. The basic message is that this is a transient cardiogenic shock that is occurring in this patient because heart muscle is not working properly. In fact, at this moment, I also want to bring to your attention the fact that I have spoken about cardiogenic shock earlier. In cardiogenic shock, I said patient will be having features of heart failure. Along with this, there would be acute kidney injury failure that would be occurring in a patient. Cardiogenic shock, the treatment is we give norepinephrine. For cardiogenic shock, we can be using dobutamine. We nowadays don't recommend using dopamine because of the pro-arrhythmogenic potential, but this is the only variety of cardiogenic shock where we don't use norepinephrine dobutamine, because already there is a catecholamine surge now. If I will give NORAD for this patient, he will rather have more damage to his left ventricle. You can notice that in this patient, if I do a echocardiography in this particular patient, if I do a bedside echocardiography, it will be showing this peculiar bulge of the wall of the left ventricle, and the Japanese name for this is Takotsubo cardiomyopathy. This is the only example of cardiogenic shock where we don't use inotropes. We don't use inotropes. Norepinephrine, dobutamine is contraindicated in this condition. Norepinephrine is a big no. We don't use. दे दिया गलती से तो it will cause worsening. I mean, in fact, even removing the name from here की कोई confusion ना हो कि सर notes में लिखा था तो पर confusion लग गया भाई है ही नहीं. Not by inotropes have no role in this case. Okay, a miscellaneous fact, vitamin B1 deficiency and beriberi is asked. What blood test is done for diagnosis of thiamine deficiency is RBC transketolase levels. एक तो ये question था, what is the test that is done? So RBC transketolase levels. It can be two varieties, wet, we call it wet because lungs are wet, because this pulmonary edema, it's also called as high output heart failure. Three causes of high output heart failure are beriberi, anemia and Graves' disease. Mitral stenosis is a cause of low output, aortic stenosis, low output heart failure subsequently. Dry beriberi will cause Wernicke's encephalopathy. The mnemonic is GUAN. You all know this. Global confusion. G would be global confusion. O would be ophthalmoplegia. Here he will ask you what is the cranial nerve that will get involved. A would be like ataxia, and N can be nystagmus that is present. Yes, he will ask you what is the cranial nerve that is involved in patients who are having dry beriberi, that's Wernicke's encephalopathy. Then your answer would be sixth nerve palsy is seen in these patients. Then he will also say that you are treating this patient, what is first one to respond, whether it is global confusion, ophthalmoplegia, ataxia, nystagmus, क्या चीज पहले ठीक हो जाएगी. So first to respond to treatment would be the ophthalmoplegia component. Sixth nerve palsy is the first one to respond in this particular case. I want you to remember that every time there is like a ophthalmoplegia occurring with respect to Wernicke's, it's a lateral rectus palsy that's occurring, diplopia looking laterally. Last time I've talked about sixth nerve palsy was for raised ICP. In fact, okay, that will come in CNS subsequently, so you may not have listened to it. Patients of raised ICP, most common cranial nerve involved is sixth, and even in Wernicke's encephalopathy, it has sixth nerve palsy and is the first one to respond. What is the treatment to be given? Then you will first be giving thiamine to the patient and then subsequently dextrose. If your nurse by mistake will not follow this order, and by mistake if she is gonna be giving dextrose to the patient, then it will cause consumption of residual thiamine. You see, dextrose, when it is metabolized in the process of glycolysis, then thiamine is a coenzyme, so thiamine will be consumed here, and that will cause worsening of the neurological features of this patient. I said if by mistake your nurse will be giving thiamine to this patient, then there would be consumption of residual thiamine and worsening of neurological features would be seen, and therefore like thiamine, I mean dextrose plus thiamine is not given, and it is thiamine plus dextrose. I would like to give a parallel example, like in patients of aortic dissection, I said first give beta blocker, then give sodium nitroprusside. Here it is like first thiamine because that's the deficiency, and then give dextrose. If by mistake the nurse will reverse, then there can be consumption residual thiamine, and there could be worsening of development of features of WE. WE would stand for Wernicke's encephalopathy. The mnemonic for this was GOA, global confusion, ophthalmoplegia, ataxia, and nystagmus. In fact, though I was planning to talk more about the wet beriberi component because heart failure treatment I've already discussed with you, so LMNOP can be used, and obviously here the main treatment would be IV thiamine, but yeah, to decongest we can be giving Lasix for the management of these patients as well. So wet beriberi would be high output congestive heart failure. Dry beriberi is the neurological manifestations. Korsakoff psychosis are not spoken about, that is confabulation, that I would suggest you to read up from psychiatry. Now I will talk about one of the leading causes of death in India. In fact, if they ask you what is the most common cause of death overall in India and in America, then it is myocardial infarction, which would be written in the MCQs as ischemic heart disease. So because patient is having MI and there would be chest pain at rest in this condition, along with this sympathomimetic symptoms would be predominating because patient will be feeling very nervous, there would be a sense of impending doom. But anytime you read a question where a person is having chest pain at rest, for whatever be the duration, then we have to think that it is myocardial infarction in a patient. Obviously, the nature of the chest pain will be diffuse. It is not like a localized chest pain, like retrosternal pain. Retrosternal is localized chest pain, that is GRD. So this is diffuse chest pain at rest in a patient. Usually he will say like 30 minutes, 1 minute, whatever. And the pain will be very, very intense. I mean, pain rating 10 on 10 rating, there would be diaphoresis and like sweating that would be occurring in a patient, though the air conditioning would be running fine in the casualty, though the pain can be radiating also. I mean, the examiner can in this question mention regarding the radiation of pain. Where can the pain radiate to? The pain can radiate to the jaw, it can radiate to the arm, it can radiate to the shoulder, and it can radiate to the epigastrium area also. So pain or myocardial infarction, guys, can radiate in any of the following directions. Radiation will not give a clue. What you need to do is the ECG in this patient, and the earliest ECG finding is not a ST elevation. If he says what is the earliest ECG finding in myocardial infarction, your answer would be development of hyperacute T waves. If he says what ECG finding will persist for whole life in the patient, then it would be appearance of deep Q waves. Deep Q waves indicate cell death. Deep Q waves in myocardial infarction, they always indicate cell death in a patient. The word is cell death. If he says what is the first cardiac biomarker to rise in myocardial infarction, then first biomarker to rise in the patient is, obviously troponin I is the best one. But if he says what is first to rise, then your answer would be given as IMA. The first answer is ischemia modified albumin. This usually rises within the very first hour of onset of myocardial infarction. If this is not in the options, then the second answer should be given as heart fatty acid binding protein. If hard fatty acid binding protein is not given, then the next answer should be given as obviously the standard biomarkers that we do, that is a high sensitivity cardiac troponin T or troponin I can be done in a patient. And don't answer CPKMB. I mean, that is like usually after 6 hours. CPKMB is a good biomarker, but it usually rises after 6 hours. So this is like ischemia modified albumin for first to rise, right? First to rise. If they say what is best, if they say among these, which is the best biomarker for diagnosis or regularly used for diagnosis, then it is cardiac troponins that are recommended, troponin I and troponin T. Last to rise in myocardial infarction is LDH, that is lactate dehydrogenase. It is not used clinically because it can be present inside red blood cells as well. Additional point which I want to bring to your attention is that whenever we are discussing regarding myocardial infarction in pathology, they will always talk about myoglobin, but then myoglobin is not recommended because I can say that myoglobin is present in skeletal muscle also. Myoglobin is present in skeletal muscle also. So if I give DC shock to the patient, like after MI somebody had an arrhythmia and I give DC shock to the patient, then also because the current will go through the skeletal muscle, so it will damage the skeletal muscle and myoglobin will rise. So the point is I'll not be able to prove whether myoglobin came from the skeletal muscle, whether it came from the cardiac muscle. So myoglobin is a very good answer, but I would say, not a very good answer, because I said that myoglobin can be having skeletal muscle source also. I'll say this again. Myoglobin is present in skeletal muscle also and cardiac muscle also. Now, when you will give DC shock to patient, suppose person had an arrhythmia, then the current will travel through the skeletal muscles and will finally reach the heart also and will reset the cardiac rhythm by default. That is okay. But because the current will travel through the skeletal muscles, it can damage the skeletal muscles. The damage will cause myoglobin to be released from the blood from the skeletal muscles. Now, I will not know that the myoglobin that is present more in the blood, did it come from heart? Obviously, he had a heart attack, so would be coming from the heart also, but can be coming from skeletal muscles also. No, I need a single source, right? So the point is myoglobin is not recommended and neither is LDH. This is academic class, no? So I'm telling you all these things. In real practical class, if you talk to a cardiologist, वो हंसेगा क्या sir क्या बात कर रहे हो? We use cardiac troponins and we make a diagnosis. Then if he says what is the cardiac biomarker of reinfarction after 72 hours, then if he specifically mentions the word, तभी मैं ink color change करके बोल रहा हूँ, अगर वो 72 hours के बाद में word बोलता है 72 hours, then it is CPKMB. But suppose it does not say anything. He just says cardiac biomarker of reinfarction. सिर्फ MCQ में reinfarction word is given. There is no mention of the time frame. So कोई guarantee थोड़ी ना है कि myocardial infarction, reinfarction will occur after 72 hours only. It can occur in first 6 hours also. It can occur in first 12 hours also, first 24 hours also. So therefore, for early reinfarction in a patient, very early reinfarction in a patient, I can be using troponin I. What I mean by troponin I is I can go for a serial troponin I, that is rise of more than 20% over the baseline admission value. Let me explain this to you. Suppose patient came now, troponin I was elevated at a particular level. After 6 hours, the patient is deteriorating even further. So I decided to do troponin I again. The troponin I, if it shows a rise of 20% or more over the baseline admission value, like whatever mathematical value troponin I was demonstrated, if it rises further by 20%, then there's a possibility that another artery, like suppose it is a left anterior descending, it could be right coronary artery if the patient also getting involved. So rise of actually greater than 20% over the baseline, rise of 20% over the baseline admission value helps me know that it is a reinfarction. But yeah, after 72 hours if specified, it is CPKMB. As far as the treatment or choice is concerned for ST elevation MI, obviously when patient will come, I will be giving aspirin also, I'll be giving morphine if available, I'll give nitrates if required, but then primary percutaneous coronary intervention should be done in this patient. The first medical contact to balloon time means that if the person calls up our hospital, like in America they call 911, then we should be done with balloon angioplasty within 90 minutes. Primary percutaneous coronary intervention is called as balloon angioplasty, and the first medical contact to balloon time should be kept under 90 minutes. If he says window period for thrombolysis, then window period for thrombolysis would be kept under 12 hours. Like patient had MI at 8 a.m. in the morning, we can do thrombolysis up to 12 hours. Then is the door to needle time, like cath lab facility is not available. So door to needle time should be kept under 30 minutes. And then is a concept that was asked in FMG exam, rescue PCI. Rescue PCI basically means that there is a failure of thrombolysis. Meaning of the word failure of thrombolysis is less than 50% ST segment resolution at 90 minutes after fibrinolysis. Like suppose when patient came, the ST elevation was 4 millimeter. When I treat the patient, then ST elevation will decrease from 4 to 3, then to 2 millimeter, then to 1, and gradually begin to disappear. If the ST elevation is not coming down at all, here I'm saying that ST elevation started coming down, so this is beneficial. This means successful thrombolysis is occurring. Suppose I say to you that the patient had come, I have done thrombolysis in the patient, but ST elevation is not changing. It is still remaining the same. Like you can see the ST elevation here is about like 4 millimeter. It is remaining 4 millimeter only. So that is bad news. I said this is successful thrombolysis because ST elevation kam hota ja raha hai, so that means that my patient is improving. But if there is failure of thrombolysis, and if for failure I'm saying it is remaining 4 ka 4, though the definition is 50% or lesser, I'm saying agar 4 ka 4 hi reh gaya. After starting thrombolysis, 90 minutes have passed by. Like let me say I started good old streptokinase. Or I can start L-teplase, Re-teplase, Tenec-teplase. There's so many drugs available. Streptokinase is one of the oldest ones. After 90 minutes, if I notice that ST elevation has started reducing, and it will start reducing in next couple of minutes only if there's a successful thrombolysis, that means my patient is improving. But this is the situation which is a cause of concern because I have done thrombolysis in my patient, but in spite 90 minutes have passed by, like the ST elevation is not coming down. So this basically represents, this particular part that I've represented at the moment indicates failure of thrombolysis. I'll just highlight this once again, guys. The point to be understood is that I started, this is ST elevation initially present of, let's give it a mathematical value 4 millimeter. If it is coming down, if it is becoming lesser, good. This means successful thrombolysis. But if the ST elevation that is present is remaining the same, and the definition says ST elevation should come down by less than 50% at 90 minutes with respect to fibrinolysis, this is what I've described as called as failure of thrombolysis. This also explains now why we don't recommend thrombolysis in the first place. We send the patient to cath lab hospital. Like I'm practicing outside Delhi, no facility, I'll send him to cath lab to Delhi to get PCI done. But this is still a FMG exam question that if there is a failure of thrombolysis, to karenge kya? So in failure of thrombolysis, we shall be doing is a rescue percutaneous coronary intervention in a patient. Whenever there is a failure of thrombolysis, we shall be doing is a rescue percutaneous coronary intervention. If we don't intervene, most common complication in the first few hours would be like ventricular fibrillation, or it can be pulseless ventricular tachycardia. After 24 hours, in spite of treatment, if somebody is dying, then the answer is unlikely to be arrhythmia. Then the usual cause is that there is so much of structural damage to the heart that heart could not pump blood effectively. So you will say cardiogenic shock, or you will use the word pump failure. If death is occurring after 3 to 5 days, then another reason has to be considered that the heart can burst. There was a transmural infarction, full thickness infarction, and the heart can burst like a balloon. So the technical word that is used here is called as electromechanical dissociation. The word electromechanical dissociation means cardiac rupture. I mean, that is just to मेक इट साउंड सोफेस्टिकेटेड, वो ज़्यादा हाईफाई दिखाने के लिए ना कार्डियक रप्चर जो वर्ड है उसकी जगह पे लिखेगा इलेक्ट्रोमैकेनिकल डिसोसिएशन. The commonest valvular lesion that is seen is mitral regurgitation by default, that I've explained so many times कि कभी भी हार्ट की कोई भी कंडीशन में पूछे ना valvular lesion क्या होगा, it is mitral regurgitation. Dressler also have touched upon in the early part that it is a autoimmune pericarditis. In fact, Dressler syndrome is a autoimmune pericarditis as well as a autoimmune pleuritis. Both दोनों याद कर लेना, pericarditis तो है ही है, pleuritis भी है. It will also cause a development of ST elevation, but biomarkers will be normal. In spite of the fact that autoimmunity word examiner will write himself, we will not be giving steroids for this patient, but we will be giving aspirin. As far as the complications are concerned, it is CALM-D. CALM-D would mean cardiogenic shock, arrhythmias, LV aneurysm, mitral regurgitation due to papillary muscle dysfunction or rupture, and then Dressler syndrome. If he says what is the management, it is best moan. If he says सबसे पहले क्या करेंगे, तो I'll write the full form best moan also. First intervention is always aspirin, not morphine, not nitrates. First intervention is we will be giving to the patient chewable aspirin, sir. This would be a 325 milligram chewable aspirin that should be given to the patient initially, and we will ask the patient to crush the tablet between the teeth so that there is a quick absorption from the buccal mucosa. Along with chewable aspirin 325 milligram, we should also be giving is ticagrelor to the patient. According to the American Heart Association guidelines, all patients of MI should always be subjected to what is called as DAPT. DAPT stands for dual antiplatelet therapy. DAPT stands for dual antiplatelet therapy, that is chewable aspirin and ticagrelor. If he says what is the treatment of choice for ST elevation MI, then already explained to you that we should be going in for primary percutaneous coronary intervention. If he says what is the treatment of choice for non-ST elevation MI, the answer is still percutaneous coronary intervention. Let's look at the full form of best moan here. For the best moan, one of the drugs that is used, this does not mean that beta blocker is the first drug to be used. No, man, it is just that this is a mnemonic which can help you remember what are the drugs that are being used for management of myocardial infarction. So we have to give beta blocker. A single dose of beta blocker will decrease the heart rate and conserve oxygen. I need to conserve the fuel. Then alphabet E will be standing for enoxaparin, that is low molecular weight heparin. The rationale is I want to prevent the clot propagation, क्योंकि जो clot बन गया that will keep on increasing in the left anterior descending artery, right coronary artery. So I want to prevent the further increase in the size of the clot. Alphabet S will stand for statin, so we should be giving high intensity single tablet of atorvastatin like 80 milligram to the patient. Alphabet T is for actually the older version, like when we did not have PCI facility available, we used to do thrombolysis. So I'm just putting a star here to say that this is a backup treatment. Ideally, I should be taking the patient after giving medicines directly to the cath lab, and I should do a primary percutaneous coronary intervention. But like I have explained to you that if I am at a place where I don't have facility, so I'm just adding the word here, or if I don't have the facility, then I can be subjecting the patient to thrombolysis. The decision is based on the transport time. Like if it will take more than 2 hours for the patient to be transported, then no point of taking him for PCI. Let me say patient is in Rajasthan in Alwar. From Alwar to Delhi, distance is hardly 80 kilometer, let me say, but the traffic on National Highway 48 is so crazy. Gurgaon aata hai, Manesar aata hai beech mein. It will take 4 hours to reach. So then I will tell the family member कि भाई you can check on Google Maps. It will take more than 2 hours. Not a safe approach. वो कह रहे ठीक है sir, what should be done? I said okay, thrombolysis. You can imagine any two cities, tier 1 city, tier 3 city in India. Distance between the two may be 100 kilometers only. In America, 100 kilometers can be covered in 1 hour, even less than that, because there's a freeway, right? An expressway. In India, a highway will be choked by all the traffic. So if the transport time is more than 2 hours, don't transport. Then manage with thrombolysis, obviously after taking consent. But if the transport time is like adha ghanta, like suppose patient is in Manesar, has to be transported to Gurgaon, from Gurgaon to Delhi, or let me say tier 2 to tier 1 city, yeah, I mean under 2 hours. That remember that value of 2 hours, though I've not written there. So thrombolysis is like an old approach. Ideally, we should go for primary PCA. Now, the remaining drugs are very simple. We will give morphine. It is an analgesic. It conserves oxygen. Alphabet O is oxygen to be given to the patient. A is obviously aspirin. And then I will just say that the alphabet T I'm using once again because I want to use statins in my patient also. So T is coming for statin also. Or in fact, I can use that in A only. Why to create any confusion? A is for aspirin and A is for atorvastatin. Otherwise, the alphabets will be missed now. I mean, if I say statin got T, the alphabet will be missed. So aspirin, atorvastatin, and N is nitroglycerin that is given sublingually. Nitroglycerin is given like dose is 0.4 milligram that can be given 3 times at a gap of 5 minutes. Like you can give one tablet right now, then you can give a second one after 5 minutes, but always check the BP because nitrates always cause hypotension. And in wali list में से two drugs are not given in inferior wall MI. I'll just explain that to you subsequently the rationale, but at the moment I just want to say that don't give nitrates in inferior wall myocardial infarction because there is hypotension there, and don't give metoprolol also in inferior wall MI. There's a bradycardia. I'll write it down subsequently, but best one is a mnemonic to remember. What do we do in नीट पीजी एंड एफएमजी दोनों में इतना बड़ा सवाल पूछा एमआई पे, बोला करोगे क्या, तो एस्पिरिन देंगे। नॉन मेडिको को भी पता होता है यार, पहले एस्पिरिन देनी होती है और टेका कलर देना होता है, बाकी सब कुछ बाद में। नाइट्रेट, सबलिंगुअल नाइट्रोग्लिसरीन, ऑल दीज थिंग्स विल कम लेटर। फर्स्ट इज चुएबल एस्पिरिन एंड टेका कलर should be given to the patient. Now coming to the ECG based questions, I want to tell you that always when they give you a 12-lead ECG, check out lead number 2. Lead number 2 is called as rhythm strip. It is used for calculation of the heart rate. If you count the number of squares there, this is like 1, 2 and 3, a little more than 3, 3.5. If I divide 300 by 3.5, the heart rate of this patient will be less than 100 beats per minute. So at least I know I'm not dealing with any tachyarrhythmia, neither with a bradyarrhythmia. Then you check out P, Q, R, S and T are present. So this tells me that the person is also in normal sinus rhythm. If the person is in NSR and the heart rate is less than 100, then I can assume that this is not a question on tachy and bradyarrhythmias, and I can straight away move on to the precordial leads. If you check out the ECG present here, lead number V1, lead number V2, lead number V3, V4, V5, V6, all are showing presentation of ST segment elevation. Is starting from as early as lead number V1 and it's becoming very very prominent as you are moving from V1 to V6. So the answer in this particular case would be given as extensive anterior wall myocardial infarction. I want you to remember when to say the word जिसको हम बोलते हैं ना massive heart attack हुआ है. Massive heart attack is the technical word is extensive anterior wall MI, where the ECG findings will be present from V1 to V6. Now suppose in this same MCQ, if the findings were given of ST segment changes that you can see here were given from V2 to V4, then you would have simply said the word anterior wall myocardial infarction. So I want to talk about infarct localization. When do you say anterior wall MI and when do you say extensive anterior wall MI? The rationale is that if it is going to be anterior wall MI, then you will say that this is V2 to V4 changes. But if it is like so many changes from V1 to V6, then you will say you're dealing with an extensive anterior wall myocardial infarction. So it helps us identify like which territory is getting involved, and the territory that is involved here is left anterior descending artery. ये सबसे common artery होती है जो MI में involved होती है, and the patient mostly will die. Mostly it's a male patient. It will create a widow. So therefore this artery is also called as widow's artery. Anatomy वाले बताते हैं left anterior descending artery is called as widow's artery. Having said that, when we focus on the next ECG, here also my student said कि सर ST elevation present था और वो मतलब V2 से ही शुरू हो गया था, V3 में भी है, V4 में भी है, V5 में भी है, but then this is not convex. This is exhibiting that concavity na, especially if you move laterally you can notice that this is not having a convexity but a concavity which is present. So if there is a chest pain described, and this was in FMG exam very shockingly कि ST elevation present था multiple leads में, the question was mentioning a patient is having a diffuse chest pain. Some past history of Khansi Zukam was also given in the patient. Then he said that person is having diffuse chest pain, ST elevation is showing a concavity, and the findings were present from V2 to V6. If the past history of cough and cold was given, it becomes all the way more important. Even if it is not given, chalega. Our answer would be given in this particular ECG as acute pericarditis. And if he specifically mentions past history of URTI, upper respiratory tract infection, then it can be a viral pericarditis like it happened in COVID cases. And inferably also I want you to check out this is that ST elevation that you're noticing is concave in upward direction, whereas whenever it is going to be myocardial infarction, it would always be convex in upward direction. So this is ST elevation, like you can see the arrow going up with the concavity of acute pericarditis. This was a difficult one in FMG exam. Previous one, I think in NEET PG, that pretty decent question on myocardial infarction was put up, that is extensive anterior wall MI, but this I expect like students to have a bit of difficulty, but anyway they've asked it, so chalega. Next is again a NEET PG question where my student said कि sir normal sinus rhythm ही था, but in the precordial leads V1, V2, V3 and V4 you can notice very symmetrical deep T wave inversion. So in the precordial leads, because there is no ST elevation present, even in this question, it was mentioning chest pain only, that is at rest, extensive sweating, but there's a T wave inversion present, no ST segment changes. So our answer in this case would be that the patient is having non-ST elevation MI of anterior wall again, because V1 to V4 are studying anterior wall. The answer in this question is anterior wall non-ST elevation MI. मैंने anterior wall कैसे निकाला? That is from changes from V1 to V4. In fact, here I can say that even the septum is involved, because जो V1 वाला lead होता है ना, V1 V2, वो septum को read करती है. So I can make it more specific by saying anteroseptal. I can make it even more specific. Let me just jot it down also. I can make it more specific by writing the word anteroseptal non-ST elevation myocardial infarction. Non-ST elevation MI क्यों बोला कि भाई यहाँ पे तो सिर्फ एक ही है ना, T wave inversion is present, there is no ST elevation that is present in the patient. At this moment, I think it's clear to you that lead number V1 and some part of V2, they help in studying the area of the septum. जो septum वाला area होता है interventricular septum, the wall separating the left and the right ventricle. Lead number V2, V3 and V4, they help in mainly studying the anterior surface of the heart, and lead number V5 and V6, they are helpful in studying the lateral surface of the heart. So if the changes are present in all of them, then I can say that it is a extensive involvement, then it is a extensive myocardial infarction. Let me write it once again, guys. Lead number V5 और V6 side में लगाते हैं ना. So lead number V5 and V6 which are put in the side would basically tell you that it is the lateral surface of the heart getting involved. So I just wanted to focus on like the surface of the heart at the moment. I'll say it once again: V1, V2 for the septum, V2, V3, V4 for the anterior surface, and V5, V6 for lateral. Now this is a INI-SET question that came where my student said कि sir V2 में और V3 में ST depression आ रहा है. Like मैं उसका marking करता हूँ so that you are able to relate to this better. I think it's very well zoomed, very clear. This is the R. I'll use a finer font also. Give me a second. Yes. So here we go. This is R. This is S. And then you can see the ST depression. दिख रहा है ना? ST depression present. Even in lead number V2, you can see the ST depression. So lot of guys बोला सर ये तो नॉन ST elevation MI हो गया anterior wall का, but one guy was very smart. वो कहता नहीं नहीं सर, बाद में ना there was a upright T wave, there was a upright T wave present. The movement, like every time I have described like ST elevation or ST depression, there's always a T wave inversion. मैं इसको highlight करता हूँ. Every time I draw a myocardial infarction before you, whether it is ST elevation MI or non-ST elevation MI, I always show a T wave inversion. This is ST elevation MI, T wave inversion shown. Compare this again. This is ST depression that I am showing at the moment, followed by a T wave inversion happening in a patient. So you can see that this is also convex. This is also convex. This is non-ST elevation myocardial infarction, and I have also highlighted in this condition the presence of T wave inversion. I'll just do the activity once again. Just I want you to follow my marker and check out the convexity of even the ST depression. Yes, so this is the ST depression that is coming up, and then I've shown a T wave inversion. You can actually, we can measure, like this is the ST segment depression. We can measure that this is the ST segment elevation. So these are the two findings that can be occurring in a patient. No doctor can predict which of the two types of MI will occur. What I want to bring to your attention is that anytime both types of MI, it is a T wave inversion. But here, one of the students pointed that boss, it was having presence of upright T waves. ST depression is there, agreed. But there was upright T waves present. This is a feature which is seen with posterior wall myocardial infarction. Then you will not give your answer as non-ST elevation MI of the anterior wall. You will answer this as posterior wall myocardial infarction. I'll just make you practice this here after I've written the data. Let me, like I've zoomed out of this, so let me just write down the data so that you are able to remember this on a long-term basis कि posterior wall MI को कैसे identify करते हैं. In posterior wall MI, the first thing that you're supposed to check out is lead number V2, V3 and V4 by default. Even V4 में भी same ही दिख रहा है भाई, जो precordial leads होती है वही common वाला MI पूछता है वो एग्जाम में. तो इनिशियली लेट्स अज्यूम कि मुझे पता नहीं है कि पोस्टीरियर वॉल है या एंटीरियर वॉल है. आई जस्ट नो कि V2, V3, V4 में चेंजेस दिख रहे थे. तो एटलीस्ट मैंने इतना तो देख लिया ना कि देयर इज अ ST सेगमेंट डिप्रेशन. इफ यू आर नॉट कन्विंस्ड, लेट मी डू इट अगेन मैन. लेट्स डू इन V4 ऑल्सो. आप देखो ना यहाँ पे V4 में ये R है, ये नीचे आ जाते हैं तो S हो गया, and then this is the ST segment depression, but then this is followed by an upright T wave present. अगर आप FMG एस्पिरेंट हो तो आप इस चाहे ECG को छोड़ देना, तो मेरे हिसाब से तो पढ़ना चाहिए, बट या इनिसेंट हो एस्पिरेंट हो तो फिर तो आना ही आना है, विच इज दैट दिस इज ST depression understandably which is shown, but then after that it is followed by an upright T wave, whereas traditionally we always have is a T wave inversion. नाउ दिस इज नॉट कन्फर्मेटरी, ये सिर्फ सजेस्टिव है। कन्फर्मेशन के लिए क्या करेंगे, आई विल आस्क माई टेक्नीशियन टू पुट V7 V8 एंड V9। तो मैं अपने स्टूडेंट से पूछा भी कि डिड द क्वेश्चन मेंशन V7 V9, दे सेड नो सर, देयर वाज नो मेंशन ऑफ एनी V7 V8 V9, वो लिखा था तो हम पोस्टीरियर वॉल MI बोल देते। सो आइडली फॉर डायग्नोसिस ऑफ पोस्टीरियर वॉल MI, लिसन टू माई वर्ड्स केयरफुली, ideally for diagnosis of posterior wall MI, both information should be given by the examiner. It is V2 V3 V4 showing ST depression with upright T wave, and V7 V8 V9 that will be showing the traditional data, that is ST elevation with presence of a T wave inversion. So these are what are called as reciprocal changes. देखो ये वाला जो findings मैं लिख रहा हूँ ना, this is based on the fact that अगर damage पीछे है and you put electrodes on the front, the current is going away from the recording electrode, so they will be in ST depression. When current will go towards the recording electrode, there would be an ST elevation. So ideally तो देखो posterior wall MI के diagnosis के लिए there should be presence of reciprocal changes, but ये तो इनिसेट एग्जाम है ना, इनिसेट में तो फिर वो बोलता है कि भाई मैं तो थोड़ा हट के पूछूंगा, so he deliberately did not give this information. My students were like itching, कि sir, if it was posterior wall MI, he should have given V7 V9. मैंने बोला भाई competitive exam है, देखो in a competitive exam he'll try to make things difficult for you, so he did not give V7 V9. I understand that he should have ideally given, but then the remaining findings they said, हाँ इतना याद है sir that you said this fact, so like they were able to mark this as, most guys were able to mark this as posterior wall MI, though ideally I mean इतना मुश्किल नहीं करना चाहिए, because I posted this to a cardiologist, even he first looked at the ECG ना, ऐसे WhatsApp पे किसी को भेजो तो nobody will look at it seriously ना, ऐसे हंसे हंसे में बोला this is non-ST elevation MI, so I said ध्यान से देख, तो देन इज लुकिंग एंड इज लाइक अच्छा किसने भेजी, किसकी है, केस डिटेल बताओ। मैं कहा यार जस्ट पास MBBS इंटर्न्स से पूछा ये, एंड इज लाइक अच्छा ओके, अरे नहीं नहीं दिस इज posterior wall MI, cardiologist, right? And that girl, she's my student, man. I mean, a very famous endocrinologist at the moment, right? You understand, right? Medicine करने के बाद she's done endocrine, right? Endocrine वाले जो NEET assessment topper होते हैं, तो even her first instinct was like, I asked her, okay, doctor, like what is your first instinct? And she casually answered this as, I mean, answered this casually as non-ST elevation MI. सो आई मीन वाई एम टेलिंग यू दिस इज के भाई नीट एसएस वाले भी है ना, वो भी कंफ्यूज हो रहे हैं इससे, बट एनीवे चलता है, राइट? अब ये थोड़ा आइसोलेट, ये पता क्या कर, ऐप वाले इसको पहला क्वेश्चन डाल देंगे, मैं गारंटी से बोल रहा हूँ। जितने ऐप ये क्रिएट करते हैं ना, फोमोज वाला, वी गिव कॉन्सेप्ट, वी कॉन्सेप्ट, दे विल पुट दिस क्वेश्चन एज द फर्स्ट क्वेश्चन ऑफ कार्डियोलॉजी, एंड पीपल विल गेट फोमो, क्योंकि मैं तो जो डिस्कस कर रहा हूँ दैट इज टुवर्ड्स द एंड ऑफ द वीडियो ना, लोगों को चाहिए शॉर्टकट मसाला, एंड दैट मसाला इज लाइक I mean, medical side can't be masala, right? It can be like made interactive, it can be made interesting, it can be made understandable, but it can't be masala. So everybody thinks, oh man, ECG questions are so difficult. Bhai, NEET SS walo se nahi solve ho rahe. Okay. So you guys will do it, right? Sometimes, when you are at the peak of understanding all the 19 subjects, people do better. Next question. Hot favorite of FMG examiner. I don't know why. वो आपसे जो चेंजेस पूछता है वो लीड 2, लीड 3 और लीड AVF के पूछता है गाइस। जब भी ECG देखोगे ना तो कहाँ कहाँ पे देखना है, वन इज आई एक्सपेक्ट यू गाइस टू लुक एट V2 V3 एंड V4 फॉर पिकिंग अप चेंजेस ऑफ V2 V3 एंड V4 फॉर पिकिंग अप द चेंजेस ऑफ एंटीरियर वॉल मायोकार्डियल इन्फार्क्शन। ये देख रहे में ना थोड़ा सा ए जैसा लग रहा है, द वे ऑफ ड्रॉन इट ना, दिस लुक्स लाइक अ अल्फाबेट A, सो इट इज एंटीरियर वॉल MI। और इसको अगर मैं ऐसे बोलूँ ना कि अगर मैं इसको ऐसे ड्रॉ करूँ लाइक दिस, राइट, लाइक दिस, इफ आई जस्ट रैंडमली, इट दिस लुक्स लाइक अ आई, inferior wall MI. Let's do this again. What are the leads in which you would be checking for anterior wall MI findings? It is V2, V3 and V4. These are the leads which are used to study the anterior surface of the heart, and you can see this looks like an alphabet A. And here if you look at the data, it looks like an alphabet I. But anyway, the point is, अब FMG एग्जाम वाला क्या कर रहा है, this is what he's asking you. This is the ST elevation that is can be seen with T wave inversion, the classical like the ST elevation that is present in lead number 2, 3 and AVF for inferior wall MI. Inferior wall MI may like, okay, let me write it here. In inferior wall myocardial infarction, it is the right coronary artery that gets involved. In inferior wall myocardial infarction, the thrombus is developing in the right coronary artery. राइट कॉर्नरी आर्टरी को स्टडी करने के लिए जो स्पेशल लीड्स होती हैं उनका नाम 2, 3 और एवीएफ होता है. एंटीरियर वॉल के लिए जो लीड्स होती हैं दे आर गोना बी V2, V3 एंड V4. सो 3 numbers to be remembered. RCA thrombus is the cause. It can be a ST elevation or non-ST elevation MI. वो कोई प्रेडिक्ट नहीं कर सकता है, but yes, RCA thrombus is present. In inferior wall MI, the damage occurs in the right ventricular wall. In the right ventricular wall, vagus is present. Because in the right ventricular wall vagus is present, so damage to the right ventricle wall will cause irritation of the vagus nerve, and irritation of the vagus nerve will cause a development of bradycardia and hypotension. That is why you are not supposed to give metoprolol in this patient. If by mistake my nurse will give metoprolol, already the heart rate of this patient is low, it will become more low and patient can die. If by mistake my nurse will give sublingual nitroglycerin to this patient, I told you nitroglycerin causes vasodilation and is contraindicated if systolic BP is less than 90/60. Here already the BP is less because of bradycardia. These two drugs are absolutely contraindicated. These two drugs are absolutely contraindicated in patients of inferior wall myocardial infarction. And an additional point I also want to say is that in these patients, because vagus nerve is irritated, therefore a lot of time these patients would be having vagus irritation can also contribute to reverse peristalsis, and the reverse peristalsis will also cause development of vomiting. So here the question will also begin by saying old man comes with chest pain and multiple episodes of vomiting. So if a question is mentioning chest pain, vomiting, bradycardia and a hypotension, the examiner himself is trying to tell you that I'm asking you regarding inferior wall MI. Your eyes should go where? Your eyes should go at the following leads, that is lead number 2, lead number 3 and lead number AVF, which is classical for this condition, and you will be able to identify either ST elevation or ST depression of this patient. As far as the word acute coronary syndrome is concerned, anybody who comes to me with development of chest pain at rest, obviously the chest pain should be diffuse chest pain, and the chest pain is present at rest for maybe 20 minutes, 30 minutes, maybe 1 hour, because Indian patients take their own sweet time to come. It should not be localized chest pain. I'm talking about diffuse chest pain. Then 3 differentials are there. If it is ST elevation MI, ST elevation will be there and biomarkers will be showing a gross elevation. This will usually say value greater than. Because it is myocardial infarction, how will the examiner write it? He will say value of troponin I or troponin T. I'll just move this marker this cursor below. The value more than 99 centile of the upper reference limit. When you write it, I would suggest you to write it in both ST elevation and non-ST elevation MI, because obviously both will be having biomarkers increase. HS means high sensitivity, cardiac troponin I, high sensitivity cardiac troponin I, value greater than 99 centile of the upper. That's just to make it sophisticated. Yeah, it means elevation. Cardiac troponin I is elevated in the blood. वो क्या लिख रहा है? Value more than 99 centile of the upper reference limit. तो everybody is thinking कि पता नहीं यार कोई बड़ा हाई-फाई सा analysis हो रहा है. None man, this is not. This is just to create some FOMO. Value more than 99 centile of the upper reference limit of high sensitivity cardiac troponin I. In ST elevation MI, either there will be ST depression. Sometimes there may not even be ST depression. It can only be a T wave inversion that is present. So this is a standard finding for non-ST elevation MI. Now comes unstable angina. In unstable angina also there can either be ST depression or it can be a T wave inversion. It can be both of them. It can be either of them. So the ECG finding of non-ST elevation MI and unstable angina is the same. But in this condition, the cardiac biomarkers are normal. So you are easily able to differentiate between the conditions that I mentioned here, because in the MI part, you will always be noticing that there would be elevation of cardiac biomarkers. Whereas when it comes to unstable angina in a patient, it is the chota branches, the perforators that get blocked. So therefore the biomarkers remain normal in this condition. A simple table, you just have to analyze ST elevation with value elevated of cardiac troponin I, ST elevation MI. ST depression with T wave inversion and value elevated of troponin I, non-ST elevation MI. But if ST depression with T wave inversion is given and biomarker is normal, then don't answer everything is normal. ST elevation, ST depression is there, T wave inversion is there, it is unstable angina. Now I will be comparing this with data for prinzmetal angina versus chronic stable angina. Prinzmetal angina is characterized by vasospasm in the coronary artery of the patient. That's why it's called as a vasospastic condition. This condition is characterized by ST elevation present. This is the only angina that has a ST elevation. All anginas have ST depression. That is why prinzmetal angina is also called as variant angina. Why we call it variant angina is because this condition has a spasm. V for variant, V for vasospasm, and is the only one that has a ST elevation present. The investigation choice of this condition can be a coronary angiography. The coronary angiography in this condition will be revealing spasm. I thought it is MI, but there is a narrowing of the artery. It's a spasm of the artery. The spasm can be relieved by injection of nitrate during angiography only. Now, if I give nitrates, the spasm will begin to resolve in this patient. If I check the biomarkers in this patient, like suppose initially when patient came with chest pain at rest, I thought it is a case of ST elevation MI, but when I will do cardiac biomarkers in this patient, cardiac biomarkers will be perfectly normal. Biomarkers are normal in this condition because spasm will not cause necrosis. Spasm does not cause necrosis, so biomarkers will be normal. So I will tell this patient that I'll put you on a drug of choice to prevent this vasospasm from occurring. The drug that we will be using in this patient to prevent the development of vasospasm is a long-acting calcium channel blocker, that is amlodipine. I hope you can appreciate that this will help in preventing the vasospasm of the coronary artery, which is more common in the morning hours. And I also want to say that patients who are having prinzmetal angina have higher incidence of migraine. Migraine is also vasospastic disorder. Prinzmetal angina is also a vasospastic disorder. Coming to chronic stable angina, here in FMG exam he said patient is having difficulty in climbing stairs. जब वो stairs चढ़ती है लेडी तो उसको chest pain चालू हो जाता है, क्योंकि जब exertion करेंगे तो obviously the patient will be developing chest pain. Then she stops, तो chest pain ठीक हो जाता है. Again she climbs, again she is having chest pain. And then in these patients, if you are doing ECG at rest then ECG is normal, तो यहाँ पे हम ट्रेडमिल टेस्ट करते हैं. सो ट्रेडमिल टेस्ट जब करेंगे ना, जब वो, क्योंकि अब जब पेशेंट आपके पास आया तब तो चेस्ट पेन नहीं है, इट इज ऑन एक्सर्शन, राइट. सो एट द मोमेंट पेशेंट इज सिटिंग इन फ्रंट ऑफ यू, देयर इज नो एक्सर्शन, सो ECG विल बी नॉर्मल, तो ट्रेडमिल टेस्ट करते हैं. लेकिन यहाँ पे जो इन्वेस्टिगेशन चॉइस है आइडली वो होता है CCTA, दैट इज कॉर्नरी CT एंजियोग्राफी. वी कैन ऑल्सो बी डूइंग अ कॉर्नरी एंजियोग्राफी इन दिस कंडीशन विच विल शो अ फिक्स्ड ऑब्स्ट्रक्शन. We can also do a coronary angiography in this patient, लेकिन ना coronary angiography invasive होती है. If the patient is not having very severe symptoms now, because on exertion arrest पे नहीं है, so they don't agree for angiography. So in the MCQ, if they ask you single best answer, though both any of the two can be done. One is invasive, second is non-invasive. आजकल non-invasive को prefer करते हैं ना, तो coronary CT angiography is done in these patients. The accuracy is 98%. Coronary angiography 100% accuracy can be maintained. क्रॉनिक स्टेबल एंजाइना में क्या होता है, ब्लॉकेजेस आ जाते हैं. सो यहाँ पे ऑब्वियसली आई विल बी स्टार्टिंग माई पेशेंट ऑन सर्टन मेडिसिन लाइक वन, तो बिकॉज देर इज ब्लॉकेजेस बाय द कॉर्नरी बाय द एथ्रोस्क्लेरोटिक प्लाक्स, तो स्टैटिन देने. स्टैटिन के साथ में वी विल ऑल्सो बी गिविंग लो डोज एस्पिरिन इन दिस पेशेंट्स बिकॉज दे वुड बी having future risk of MI. But then the main treatment that I need to give, nitrates I will also give because he's having chest pain. But then the point is, main treatment in this patient will be that either I can suggest a coronary artery bypass grafting because there is obstruction in the coronary artery by atherosclerotic plaques, or we can do percutaneous coronary intervention with stenting in a patient. वो ऐसे होता है कि जैसे अगर रिपोर्ट में आता है ट्रिपल वेसल डिजीज, सो फॉर ट्रिपल वेसल डिजीज वी गो इन फॉर coronary artery bypass grafting. But if it is a single vessel disease or a double vessel disease, then we go for percutaneous coronary intervention with stenting in a patient. I repeat this again. If he says that the patient has been diagnosed with triple vessel disease on the basis of coronary CT angiography, then statins will continue whole life, low dose aspirin will continue whole life, nitrates will continue, but CABG would be required. I'm not writing it next, but it's understandable if he says single vessel disease or double vessel disease, then percutaneous coronary intervention with stenting would be done. Among the last things, though this is covered in physiology, I would like to mention regarding flow pressure volume curves. Very simple. देखो जब ये नैरो हो जाते हैं ना, आप देखो यहाँ पे I'm not getting into एंडास्टोलिक वॉल्यूम को क्या हुआ, I'm not getting into physiology. बस सवाल निकालना 30 सेकंड में, 30 सेकंड में I'll try to finish. You can see this graph is actually narrower than the actual graph. You can also see this graph is also narrower than the actual graph. So if the graph is shrunken horizontally, then it is always mitral stenosis where end-diastolic volume is lesser. But if it is shrunken and the vertical height increases, it is a feature of valvular aortic stenosis in a patient. Now you can see the graph has become chauda. This is going to be end-diastolic volume that is increasing because there is regurgitation of blood into the heart. It is horizontally chauda. So because it is horizontally broader, I will call it mitral regurgitation. But here you can see that it is also not only horizontally, but it is also vertically getting increased. So that would be aortic regurgitation. First, just focus on the narrow, that is stenosis, then is the chora, that is the regurgitation component. One is broader horizontally, second is broader horizontally plus vertically. Though I could have gone into the pathophysiology of that, but that would take a very long time, and we're doing a revision at the moment. So these are certain important aspects which I thought I should mention towards the end, especially the aspect of ischemic heart disease. So guys, keep hammering, keep the pressure on, keep on pressure on the books on, right? Because when you keep on doing these things on a repetitive basis, that is all the attitude is all about, right? I mean, doctors are not supposed to have big muscles, right? I'm not gonna show to you, show me attitude, man, right? No, I mean, how do doctors show attitude? Brain power. We are not like loud talkers. We don't like flex in a gym. We don't put reels of कि जिम में वर्कआउट कर रहे हैं, डांस कर रहे हैं, राइट? आई मीन करते हैं लोग ना, वो ठीक है यार, पर्सनल लाइफ में कोई कुछ भी करे, राइट? आई मीन द पॉइंट व्हाट आई एम ट्राइंग टू से इज दैट जो फ्लेक्स है आपका, राइट, द फ्लेक्स ऑफ योर्स इज the brain power. Knowledge is power, guys. That is how you are able to, like, do something constructive. काम तो सभी कर रहे हैं, right? But then I want you guys to be like the cream of the society. I want you guys to be doing great work in future, and obviously then saving patients and earning money will come by itself. Thank you so much for your patience and hearing me out.